Guys.
Yeah, wait 1 minute. The moderator, we request Dr. Pratap Kumar sir and Satya Vamshi Krishna sir. Oh, Sunil, yeah. Ganesh, you can proceed, Ganesh.
Yes, sir. Yes, sir. This is a 37-year-old gentleman who complains of right elbow pain for past 4 months. He had a trauma to his right elbow 12 years back. On a clinical examination, there was a tenderness over posterolateral aspect of right elbow, and elbow movement was painful with flexion. There's no other significant findings other than this. These are his clinical examination findings with supination with elbow flexion and extension. His X-ray image. You could see the osteochondral loose bodies over this anterior aspect of elbow. These MRI images showing confirming the MRI and CT images confirming the loose bodies over the anterior aspect of elbow with ECRB edema of ECRB attachment site. So over to Dr. Abhijit sir and Gautam Tiwari sir for the sir.
Can you hear us?
Yes, you can hear.
Can you hear us?
Yes, sir. Yes, sir. Yes, sir.
Right. So the elbow is in lateral decubitus position, and we're just going to mark. You can see the setup. We have the scope trolley on the opposite side of the elbow, and we're just doing the markings. The instruments come over the patient on a Mayo trolley. You can see the Mayo trolley. And we're just doing the markings for the portals. So we just mark the olecranon, medial and the lateral epicondyle. Markings of the tricep ulnar nerve. And if you can see, $250. Yeah. Lateral epicondyle. Soft spot. Steps. Can you see the markings well?
Yeah, dully visible, but could you tell us the range, show us the range of movement?
I have lost
We can hear you. Hello,
yeah.
we can hear you. The question was, what are the patient's symptoms here? Does he have a terminal restriction of pain and
I can hear you properly. 1 second.
Okay, can you hear us now?
Better.
Could you give a brief detail of
5 degrees terminal flexion, 5 degrees terminal extension at the most. He has pain in the elbow, so maybe we are expecting a little bit of synovitis. Lateral epicondyle or lateral condyle, a little piece of bone.
I think that we know people do scopy in prone supine. Advantages for the audience.
So you can do scopy in supine, but you need a hand traction for that or hand holding for that in supine. Lateral is the most easiest position to do scopy on because a lot of work is done with your hands towards the patient's head. Posterior compartment. So the biggest advantage is posterior compartment is oriented well. You're working from the top rather than working from the front in a supine position.
Sir, can you show us the working and the viewing portal for the audience?
Yeah, so what we're going to do is we're going to insufflate the joint. Simple needle. Green needle. So we've marked the soft spot. So
What is a soft spot? Just
so soft spot is a triangle. It's a spot in a triangle between the lateral epicondyle, the olecranon, and the radial head. So mark the centers of those, and you will get a soft spot. You can normally feel the soft spot, and you put a needle in it, and it goes between the radial head and the capitellum, and then you insufflate the joint with saline. And normally when you do that, it goes easily without any pressure, and the fluid comes back. Can you see that?
Yeah.
Which means it's in the joint.
One of the most important things to understand is that with insufflation of the joints, you're creating a working space, but it does not increase the distance between the anterior structures, the neurovascular structures, and the capsule. So you've got to be very careful from that perspective. Okay?
Okay, got it.
That's it. So that is joint nicely insufflated.
Can I request the cameraman to just focus the position of the surgeons, the tower, and how is the whole setup placed?
Okay.
So Dr. Abhijit is standing on the.
Yeah, so let me help you. Let me see if I can push the patient while you're doing it. You want me to hold it?
So tower is on the
Okay.
back,
Let me hold
facing the
it.
back.
I'll this side.
The surgeons are standing in front of the body or the face, right?
This is the anterior anteromedial portal here, and we'll just make a small.
Can we have a close-up view?
We cannot see the
Right. So
port or the marking.
you always start anteromedial after the insufflation of the joint. And then it's a skin cut dissection on, and then choker.
So don't you look for the ulnar nerve?
So we mark the ulnar nerve, and it is always dorsal or posterior to the medial epicondyle. So, and the portal is anterior to the medial epicondyle.
So normally you don't suggest that we put your finger and palpate, than relying on the surface marking.
When you palpate and then you can mark, you will, when you put the portal, you will hit the lateral ridge. Medial ridge. When you hit the medial ridge, you have to make sure you don't go dorsal to it, you go ventral to it.
What are the indications I can ask for where you have to explore the median ulnar nerve first before we go for this portal?
So normally ulnar nerve is never explored, it is marked. See, for every arthroscopy, things are just marked so that you know where they are. And then obviously there is an element of a learning curve for this. But you can start off by holding the ulnar nerve with your finger and then doing it. Once you do a few, you will know that it really doesn't need to be done, because you are ventral to the ulnar nerve rather than dorsal. Tissue.
So your viewing portal is always proximal and medial, right?
Yes. Yeah. So the first portal is proximal medial. Once you get into the joint, then you can use the needle to direct you for other portals. So under vision. So the first portal always will invariably be blind, right?
So the scope looks big. What is the size
So
of
the scope is a 4 mm scope. So you can do it with 4 mm. You can do it with 2.7. It's a surgical preference.
Any questions from the audience can be directed to us.
Yeah. not yet. That's muscle.
Is this just gravity assisted saline, or you use any pump for this elbow wrist?
Just a normal saline on without a pump.
Okay.
I mean, you can use, the other things you can use is you can use a syringe with some fluid in it, and you can use your other portal of the cannula to allow pressure if you want pressure. This is a 2.7.
While Abhijit
Yeah.
is trying, can you just describe, what are the superficial nerves which you have to be careful while going around?
So most of the superficial nerves you have to be careful of is on the lateral side. The medial side, the superficial nerve you have to be careful is the medial cutaneous, the dorsal medial cutaneous nerve. Sorry, the ulnar nerve on the medial side. On the lateral side, you have the radial nerve on the anterior and the cutaneous nerve on the posterior. So your portals, the closer they are to the humerus and more proximal, you're safe. The moment you start going distal, which means going towards the forearm, that is when you start feeling the pressure of the nerve.
Somebody wants to start scopy, what are the cases you recommend that we start off with?
Starting scopy, that's it. So you have to spend time observing it. I think elbow is the wrong joint to start scopy without understanding it, because it's a very difficult scope, and you can sometimes see us struggle, and as always in life surgery you struggle. Let me try. Yeah.
I think if you want to do a first scope, you do with the lateral epicondylitis or
Yeah.
this body.
Right, give me the 2.7 scope, please. Yeah. So elbow scopy, you have to see a few, you have to help a few, then you can think of doing.
Yeah, of course, cadaver workshops, what do you recommend them? You think they're good enough to train yourself, the cadaver workshops?
I mean, I'm not sure if they are good enough, to be very honest, because cadaver is, you still don't get the real. Okay. Right. Sister, can I have a scope, please? Not very good. Okay, we'll make it work. So we're shifting to 2.7. Yeah. It's okay. That's okay. We'll connect it. It should just click.
So in elbowscopy, they say that, viewing portal, once you insert and come out, going back is always a challenge.
Yes.
So do you agree with that? And things to avoid?
Is the sheet, what am I? Is the sheet longer than the scope by any chance? Because I can only see sheet. Sister, what scope is this?
Gautam, 1.7, 2.4 and 3 mm. So they
Right, so I think they've given me a 2.7 sheet, but I
Yeah.
think it is a 2.4 scope.
yeah, that's what. So you can just
Because the length of the scope does not match the sheet.
yeah. Please give 2.7 scope, and there is one Arthrex 3 mm scope if you want to try that. So Ganesh, please help them.
Easy. That's okay. So your Karl stores, what is that scope of?
Castos we have 1.9, 2.4, 2.7.
Is the
Arthrex,
length is same?
Arthrex is 3 mm.
Bigger. Okay, let's put this one on. 7. So I mean, I generally do scopes with 2.7 or maybe a 2.9. Scopes probably supplied by ConMed. And the reason is that it has a wider angle, so you can see a lot of things. So white balance, just white balance. White balance, okay, it's white, right? Thank you. Okay, right, let's start the fluid. Fluids on. Okay, so we're in the joint. You can see synovitis as expected.
You can see that. Just give us a brief round around into the joint. What would be the first time to look around, and how do you
So
proceed
you
from
have
there?
to find the capitulum, know where you are. I don't know how much deep I am in. Okay, so you can start seeing bone now, which means I am good. Yeah, so now you can see the radial head and the capitulum. You see that?
Perfect, yeah.
Yeah, and you can see the amount of synovitis he has. So now we are good to make a lateral portal. So lateral portals you can make 2 or 3 depending upon how you want to work.
So Gautam, you did that anteromedial portal, right?
Yes.
So just you found the soft spot and then you put a needle. When you are taking the trocar, like, because a lot of neurovascular structures lie anteriorly, so what is the tips that you...
So stay close to the bone.
Yeah.
Because you stay close to the bone, you're okay. But however, the problem with staying close to the bone is that you... Where am I? Needle is in. Yeah. Can I have a spinal needle, please? Because you also want a working space.
Yeah.
Okay, so this, I am probably a little anterior and a little inferior. I want to be a little higher than that. So I want, it's not bad. So you see that fold of the synovium?
Yes, we can see that.
Yes. So there's no cartilage there. You can see?
Yeah.
It's bare. It's bare. So I can be a little more up and a little more in. Yeah, there.
Sulam, you can ask them to record it and take some pictures.
Because that will allow me to get there. And if I come back a little bit, then see that?
Yeah.
That is there. That is where I want to be. See that? Okay?
Yeah, beautiful.
That is where I want to be. Let's take it off. So if you go proximal, then you're okay. Because the radial nerve is away on the lateral side at this point. As you go distal, the radial nerve comes in. Give me a...
So your plan for this case is just an osteophyte removal, or are you planning capsule
So
release?
we'll do, he does not have much of restrictions.
Okay.
He's got only terminal range, and I don't think I can improve that. The reason being, he's got an elbow that is arthritic. So if the elbow is arthritic, I can't do much with it. So I've come a little anterior. Where have I come? There. That's okay. I'll work with that. So the more anterior you are, the better it is because your working is easy. The more closer to the arm you are in the portal, so now I need a smaller shaver because I've got a 7, or you give me a bigger trocar.
Gautam, I think so. We have 4 shaver.
Yeah, you have a 4 shaver. You don't have a, because I've got a 2.9 scope. So you see that?
Yeah. No, we had 2.4 shaver, but yesterday it got some struck. I think so. I had some technical.
That is the loose body. Yes, I'll have to increase the portal. So you can. So I'm just changing it to a Visinger rod. A 4 shaver. You can get some smooth cannulas as well, but smooth cannulas sometimes are not available. You have to scout for them. इसको change करेगा. So you take this off, turn it to face me. Yeah, not in. It goes the other way as well. So Smith and Nephew. Nice. So Smith and Nephew. So Smith and Nephew is very, very tricky. So what they've done is, for a small shaver, small joint shaver, you need to have a different handpiece. You can't use the same handpiece. It's not, can you make it foot?
No. It's only hand.
It's only hand?
Yeah.
Okay.
Sorry.
No problems. Make sure I don't press it. Okay. Where am I? I am in. Hold this there. Keep the elbow like that. Okay?
Yeah, good.
So what we're going to do is we're going to do a little bit of shaving. Because if you stay close to the capsule, okay, so that's the loose body.
Clearly visible for us.
Yeah, so I will just take the base of the loose body away. Can we have the suction off? Take this off. Take the suction off. Okay. So this is easy. So this is a very useful tip. You can take the suction off, and then you will see the joint will not collapse. Because all you want is taking the bottom of the loose body off.
The location of this loose body is in front of radial head?
No, it is in front of the coronoid.
Okay.
You see this? That is coronoid.
Yes.
Is
Yeah.
that a loose body? As
Yeah,
well?
that's a loose body.
Yeah.
No, that is the osteophyte of the coronoid.
Okay.
Hold this. So because there is so much synovitis, you can see the fronds.
If you want, you can use RF also. We have that RF.
So I tend to avoid using RF in the elbow if you can.
Okay. No, we like to use RF in shoulder and knee just to take out all those loose strands. Wrist and
So I'm not used to hand control, so bear with me. I'm used to foot control.
You are doing good. Great job. Thanks, Abhijit and Gautam.
So So the problem is I am so used to working with the foot, so I can concentrate on movement of the shaver. That is something that I would advise people, because
Which according to you is the most difficult area to access with
the
scope?
posterior, because you're going close to the triceps and the nerve. Now, so you can see it, I can pretty much eat this up. It's a soft body. So if I don't have a grasper at times, you can pretty much eat this up, but we'll remove it. So how much is left? We still have stuff here.
You can use a biter, like
Yes, you
the
can
bill
use
or
a,
something.
yeah. So the other thing with elbow is, because we are not using cannulas,
Yeah.
you have to avoid too many ins and outs.
Very valid tip.
There. I'm struggling. I want to go. Okay, so you can see this.
Yeah, yeah, yeah.
This is a good sign, which means it is more or less getting loose. But I think I might just eat this up. It will take me a little while. It's a soft bone. If not, then I will grab it, because my portal is small. Reassess. So only this much is left now.
RF, sir, in elbow. Any reason?
So it's the proximity, I mean, especially the wrist, we are worried about the cartilage, which are all so closely packed, and the intrinsic ligaments also. Elbow, yes, to a certain extent, but then again, I mean, I'm not sure, I was not there in the beginning. He's isolated now, or he's just gone with that. So, anteromedial portal, yeah, okay.
So it's taken a little while, but we've managed to eat it up, most of it. And you will find these bodies are reasonably soft.
Hand surgeons generally small people, so we work in small spaces.
Yeah, don't generalize us, please.
No, we were just talking about the radio frequency and why not, so I was just telling.
No, so
Yeah.
small joints avoid radio
Yeah.
frequency.
That's the only reason. Unless you have a very good inflow and then you're constantly irrigating, and then maybe yes. I mean, very rarely we use it for scapulonate tightening and
You can use. So
this, yeah.
for wrist, I think again there is a small radio frequency probe.
The wand is there, so
Yes.
it's malleable, the probe, so you can just go exactly where you want. It's not a rigid probe, so then you can use
So
that.
I can take that off. Give me a grasper, please. So more or less I've taken most of it out. On the top. There. Is it?
It's a big one, huh?
Yeah. Let me take. Okay. Let me go for that one. Hold this. Bring that into vision. Yeah. So this is the one we looked at on the scan. Yeah. Come on. So again, you can see it's attached. I get all the way up. So it opens fully. Okay, hold this. So no. So don't pull the elbow towards you because it makes my life really, really difficult.
If anybody is attending cadaveric wrist scopy courses, one of the first exercises we do is we tie up a capsicum. And then we ask you to scope and pick up the seats. I mean, that's the first exercise which is done in a wrist scopy cadaveric course. And it's so beautiful inside a capsicum. And it's like all the loose bodies. So your triangulation, your dexterity comes with that. So we start off.
Sir, what's the take on this new nanoscope technology by Arthrex, a smaller scope, any use of in the wrist?
I mean, if you have a lot of money, yes. If you're in the US and you have a lot of money, then yes.
Scopes come out.
But
Yeah,
it has its own
please.
kind of this one, but most of them can be done with what we use with the 2.3 scope and everything. It's supposed to be disposable.
There you go.
Which we would never dispose as an Indian.
Trocar again, please. So if removed the body, I'll show you. So it often happens that the scope comes out when you pull the body a little hard. And then it's a task. Okay, so we're back in. Camera is turned around. Okay, so we'll show you a little bit now. So we've removed the body, see? It's off. So that is the coronoid. Give me a second, I'll show you the coronoid.
Do you think removing the tip of the coronoid will improve the flexion? Do you plan to do that?
Okay, so just do that for me. Okay. You can see the coronoid?
Yes, we can see that.
Yeah, and so when you flex, you can see how so you can see the osteophyte. So that is the osteophyte. The entire red thing is the osteophyte. That is your radial head. It has some degree of cartilage and loss of cartilage. That's the capitellum. So if you hold it here, if I look up, you can see the center of the radial head. See that?
Yeah.
And you can see the inferior surface of the capitellum. It's already frayed. Now, with the 2.9 scope, you can potentially try and go in, see that? But not advised if you... no. So hold this. Hold the... So that is why I need a cutter. Hold on.
So
See that? So that is where you get osteochondritis dissecans. Come to the trochlea now. That is the trochlea. Okay, and And then this is your, you see the muscle there, that is your tennis elbow coming across from there. I have a hook. Okay, so that is your trochlea starting there. That is the capitulum. So I would probably want to take this off if you want to give, if you had restriction of movement. So that is like doing an arthroscopic OK. Okay, you can see the trochlea, and then you can shift the scope onto the other side and look on this side. So he's got flexion, and then the flexion is not a problem. So it's really, if the audience want, we can take this. Otherwise, do less damage. I have to remove that bit. And let me see how big that is.
Do you use osteotomes to remove the such osteophytes?
Osteotome is very difficult to get in there. And you can get hand osteotomes in. But you can use the shoulder periosteal elevators and they will help.
We have liberator. Yeah, we have that.
Yeah, we have. I saw that. So a lot of dissection can be done through the probe. So that is your capsule. So now once I've opened this, now my elbow will start swelling. So I have to be quick now.
So you want to do posterior?
Yes. So I'll give, let me just, give me a grasper please. No, give me a punch. I'll just punch it out and then shave it off. Because I have taken it piecemeal, it becomes very difficult for me to now take it out with a grasper. So something's wrong. Hold on. Don't touch the elbow. Let it drop. So if you move the elbow, it moves. My position moves. Okay. So I've just got that little piece left and I'll shave it off. Shaver please. So that is my, you can see the anterior capsule is breached. So now there's just no point in doing too much here. Have suction please on this. That's it, not two. Stop. Suction off. Okay. So there is nothing now. It's removed. Now if you want, I can do a little bit of burring and then that's it for the anterior side. I can take that coronoid piece.
Can you just show the anatomy of the ECRB? Show the
ECRB attachment, okay. Can I have the hook please? So it's where my hook comes in. Okay, so he has, you see that red bit?
Yes,
that's the, if you look at the scan, just hold the hand there. Relax, let me go in.
Sir, can you just demonstrate the audience where you do a tennis elbow release arthroscopy?
Yeah, that's what I'm saying.
ECRB.
Okay. Hold this. Okay. So you see that piece of bone there. If you look at their scans, they have a little fracture there, and this is this muscle, the front of it. You see this white bit? Sorry, I am making you seasick. See that white bit? Where my tip of the probe is?
Yes, we can see that. So to shave that off,
This.
right, to see the exact proper belly of the
This is
endless
ECRB,
part of the.
internal attachment of ECRB.
That is
So my portal is a little anterior because that was not the idea. So if I have to do ECRB, you have to come on it and then keep eating it and go back. So you have to come from here and then go out. Okay?
Yeah, Gautam,
Yes.
another 10 minutes, then we will go for the talks. So
Okay.
what is your plan? Now you want to go posterior?
Yeah, so I want to go posterior. I'm just thinking, should I burr this off?
Yeah, we have burr also, Silam.
Yes, sir.
Yeah.
Yeah, burr. Let me just burr this off. If I burr this off,
Patient
I'll
has
just-
good range of motion.
Sir, for ECRB release, how much do you take it and how much you know when to stop? That is from.
So you have to, so ECRB, if you go too much, you will go to ECRL because they have superficial fibers. So once you see muscle fibers and you've taken the tendon bit off, then you're good. Then you stop.
Is it an ideal indication for a learner to start an arthroscopy? Maybe if you start by tennis elbow release, you can, even if you are not successful in the initial time, you can just put an incision in the outer side and get off with it.
Absolutely. The only problem is your lateral.
Yeah.
Okay. So what is burr set at? Can you put a little bit of suction on this? No, it goes off fully. The suction is too strong.
Silam, just keep midway, Silam, rather than complete.
No, yeah, but it does, the inherent pressure of the suction is too strong. Okay, doesn't matter. Don't worry, I'll sort this. So I have to determine how far I can go. So I'm starting lower first. I don't want to go beyond this. My elbow is in 90 degrees of flexion.
Is it the same acromizer bar used for the shoulder?
Yeah. So you get smaller burrs. You get a 2.9 burr. Hold this.
Do you prefer the smaller bar?
I do. But then with Smith and Nephew, the problem is you need to have a smaller handpiece. You have a ball tip? Yeah. Give me a ball tip if you can. So this is how much is left. Yeah, but just bend the. That's it, thank you. So you get ball tip burrs as well. Okay. The problem is taking it out, putting it in. No? Give me a second. So the burr is making a noise, which means I'm coming to good bone. so can we reassess? So now if you want, we can do a, because I've taken the osteophyte off. I have left the tip still because the tip looks articular now. But I can take a little bit of this off. Let me see if I can do the burr. And then I can give.
Do we have cannulas for elbow like shoulder and?
Yeah, you have cannulas, you have smooth cannulas.
Okay.
So don't use the cannulas that have got threads on towards you. That's it. That's it. Leave it, drop it. Okay, hold this. Do that for me.
Beautiful, Gautam. I think so. We have another 5 minutes. Then we go with the talks. But
so
you people, we will be watching you. So you can just tell us like what next you are going to do.
So we are going. I think this is done more or less.
Yeah.
So what we need to do now is just take this. So you can see I've come to the cartilage level.
Yeah.
So I just need a periosteal elevator. Give me that shoulder periosteal elevator.
Liberator.
The other one. And I'll just break this. Drop.
Is it possible to show the posterior portal
Yeah,
just
okay.
for the audience, if you can? Difficult part.
Okay, so that
Yeah.
is.
Yeah.
Give me the other one. Okay. And you can also do a capsular release with these. So this is what I'm interested in taking off. But even if I left this, it will not cause a lot of problem because it is only cartilage. It will eventually just dissolve because it does not have a bony support.
Sir, how do you do the capsular release usually with the periosteal elevator or
Yeah.
shaver?
So I do both.
You never use the RF for it, right?
I try not to use RF in the elbow because the amount of there is a risk of chondrolysis. Okay, so I've taken off the tip of the coronoid. Right, give me a shaver, grasper or shaver, whichever, and then that is it. So we are done in the anterior part.
Yeah.
Okay, so you want to do a capsular release, you have to go up. You have to have another portal to go up and then do the capsular release from there. Straighten the elbow.
But I think so doing a stiff elbow is more challenging.
It is. The less the space, the more the problem.
Yes, the tennis elbow release will be ideal, and even if you want to open it in the lateral side, you can get away with telling that it was a keyhole. So big incision won't be needed.
True.
Suction, I would need. So, yeah, just hold it there. This is suction. The capsule keeps covering on me, and I think I am wasting some valuable time here. Right, go on. Suction.
tips when if there is a bleeding and there is some bloody field, what tips you have?
Say again?
If there is a bloody field, so
then I think you cannot do arthroscopy with a bloody field. Give me a grasper, please. So I think you should know when to stop.
yeah.
Stop, go open, do as little harm as you can. We have got nothing to prove to anybody.
True. So you are going to take separate portals for posterior?
Yes. So I'll give this, Abhijit. You want to?
I think so posterior portals will be little challenging. We just want to know.
Okay. So I think I have a little bit of, hold this for me. I think I have got that little piece of bone left. There you go. Okay, so I think I am done here, pretty much. Right, knife please. So you can see the elbow is already swollen, yeah? So we're going to go posterior. Two ways, you can go a mid or a trans triceps, or you can go medial lateral. The problem with medial lateral is ulnar nerve. That is when you have to really hold the ulnar nerve in your thumb and then go posterior. So there is merit in doing posterior first.
What is your post-op protocol when you see a swollen elbow like this? Any special precautions you need to take?
So the post-op protocol would be soft roll and a crepe and full mobilization, no restrictions, because we have not done anything in terms of repair. That's it. So this is, can you see what Abhijit is doing?
Yeah.
So it's very important to do this, because this will make sure that all the adhesions on the tip of the olecranon and all your scar tissue is gone. And it always looks a little odd, the olecranon. Okay, that's it.
So in post-traumatic stiff elbow, this step is very important.
Yeah, so post-traumatic stiff elbow, things you can or you would want to do. See, he's on the, can you see?
Yeah.
So things you want to assess is what all compartments you want to visit and how much work you want to do on each compartment. Because no matter how much you do arthroscopic, it's always less, because it looks very big, or you feel like you've done a lot. When you get an X-ray of these guys, you have done just about bare minimum. Needle please. So we're in the posterior portal now, and then that's it. Okay, can you see the needle coming in?
So this is posteromedial.
Yeah, so the scope is trans triceps.
Okay.
And then you have a posterolateral. You don't want to go posteromedial because you have the nerve there, right? And the elbow swollen. So you really don't know where the nerve is right now. That's it. Shaver, please. Yes. So now that I have spent a lot of time anterior, I've made Abhijit's life difficult. See, one place where you can actually try and use the wand is the posterior. But then, what do you want me to do? You want me to extend, flex? Okay.
You just tell the audience what all you can process you can do in the posterior elbow. One is the osteophyte loose body removal. Then.
So that is, so when you ask what should the beginners do, you know, so I mean, we've been doing elbow arthroscopy for a reasonable amount of time, and you can still see a struggle. It gives you an idea of how difficult the joint is.
Gautam.
Yes.
Abhijit, I think so. Anil Bhatt sir and Srinivas Rajappa sir has a flight to catch.
Okay.
So we are seeing you.
Okay, no problems. No problems.
So we will just go with the talk.
Yes.
So anytime you want to pitch in and tell something, you please.
Thank you.
Thank you very much. So it's
Thank
a very
you.
big, beautiful demonstration and a big round of.
Hello. Now we can starting session 5. I call upon the chairpersons, Dr. B. Sivakumar sir, Dr. C. Sugavanam sir, and Dr. U.T. Vasan sir. I call upon Dr. Srinivasan Rajappa sir to give his first talk on scaphoid.
Let me see.
Can you hear me? Yes. Okay, great. Thanks. Regarding scaphoid fixation, percutaneous and open techniques. Okay, sir. Thank you very much, and good morning all of you. And again, I wish to express my thanks to the organizing committee at Preethi Hospital for having invited me and giving me this opportunity. I sort of tailored this topic a little bit, and I'll confine myself to percutaneous or mini open fixation of scaphoid fractures. So we look at the indications, we look at the relevant anatomy and the technique. I show you some case examples and of course some complications which you should always try and sort of avoid. My indications for percutaneous, the word percutaneous here is very, it means different things to different people. I come back situations where a patient comes to me maybe 2.5 months with a scaphoid fracture with certain parameters which are not altered. That's definitely an indication for me to do percutaneous technique. If it's undisplaced or even minimally displaced and I can reduce it, then that's another indication. There's no carpal malalignment. And also an associate, if I'm fixing a distal radius fracture, there's an associated scaphoid fracture which still fits into the parameters I mentioned, and that's again an indication for percutaneous fixation. Now this is a classic indication. Now that's a very small fracture. There's no carpal malalignment. You can see the fracture here also. This guy actually presented about 2.5 months later. Now this is still okay for me to go and fix percutaneously. So that's in my opinion a good indication to do this technique. A little bit of relevant anatomy that we all know that the scaphoid can be fixed from the palmar side. It can also be fixed from the dorsal side. Now, if you look at this cadaver model, this has been taken up from a book without permission. Okay, so, but it's okay, I think. So you put it from the volar side, here in the distal and almost in the middle, you really cannot get to the center of the scaphoid. Now, why is this? Because the trapezium gets in the way. You can do this differently by levering the trapezium out, or you can also go through the trapezium and get that wire there. Whereas if you go from the dorsal side, you got a wire straight down into the middle of the scaphoid. Now we know that one of the basic rules of scaphoid fixation is you get the screw in the center. If you get the screw in the center, you get the longest possible screw, and if you get the longest possible screw, you get the best sort of stability. Now, that's again the guide wire going from the dorsal side. Now, it's because of this anatomical issue that I am more sort of inclined to do it from the dorsal side. However, I'm not saying that that's the only way to do it. It's just my inclination to do so. Now, the screws in the scaphoid, there are some basic rules. You got to get it center. Now, this is like doing, I sort of imagine the scaphoid where the center. The only difference is the hip, you can get it inferior, but here it's a good idea to get it center. Now, if you put it in the center, you get the longest possible screw. If you get the longest possible screw, you get the best possible stability. Now, the screw head should not be sticking out because on the proximal side, you will get it on the radiocarpal joint. And if you are at the distal, you don't want any problems in the scaphotrapezoidal joint. Now, adequate compression to be used, because there are some situations where over-compression can be problematic. There's a little bit of eyeballing there, so if you're going to compress too much, then you're going to get into trouble. If you're not going to compress enough, then that's going to be a problem also. Now, how much compression to be used, I think it's dependent on the surgeon, the situation, the nature of the fracture, and so on and so forth. Now, when you're doing it from the dorsal side, it's important to know that there are structures which you cannot violate. So it's because of these things that I never do a percutaneous from the dorsal side. I had a situation where I was trying to do percutaneous, which means without making an incision. You got the guide wire in the center, and then now I'm drilling. And then you got the thumb going up like that. The thumb is fanning, which means I know my drill is very, very close to the EPL, or maybe chewing up a little bit of the EPL. That was dreadful to see. I know I cannot show you a video. That would be blasphemous in this audience to show a video of the thumb going like that, but nevertheless, you have to trust me on that. I witnessed it. So since that time, I always do a mini open technique. I retract the EPL, I retract the extensor tendons to make sure. It's only a 1.5 centimeter incision. And the trade-off is that 1.5 centimeter incision, not too bad a scar, but the EPL is working. I think I'm going towards that. Rather than an incision, I mean, very fashionable percutaneous without incision technique. I think that's maybe not my cup of tea. Now you can injure the posterior interosseous nerve there and also produce a neuroma. So again, I'm emphasizing the point that it's important to see what you're seeing. When you're doing an open technique, now this is very, very important. Now if you do not flex your wrist enough, a lot of the scaphoid is undercovered at the distal radius, especially the point of entry. The point of entry is not there. The point of entry is here. So if you do not flex the scaphoid enough, you're going to get in there. Now say, for example, you're doing a fracture which is there. Now this can really cause two problems. Number one is you're going to sort of break open the fracture there, produce a lot of fragmentation. Number two, you're not going to get enough bite on the proximal fragment. And number three, your guide wire is not going to be in the center. So the best way to do it is to flex the scaphoid, get that point of entry out, see the dorsal scapholunate interosseous ligament and just get adjacent to it, and then the whole procedure becomes easy. Of course, this was emphasized by Dr. Joseph Slade, who popularized this technique. Now you can see as you flex the wrist, you get that. I have to make a confession here. I do not do this technique. I tried and tried and tried. I couldn't get that round hole, so I do not do this technique. In my opinion, it's much easier to just do it, eyeball it, and do it off. Now this is a case example, again, a patient who had a scaphoid fracture. This was 2 months old when I did it. So the technique which I described, go to the dorsal side, make a small incision and track the tendons and do it, and you get the screw in the center. Now you do all these things. This is my favorite view for scaphoid fracture. Now this is a supination oblique view. You can see the pisiform there. We spoke about it yesterday. This is not a dislocated lunate. Now, in my opinion, you see most of the scaphoid in this one. Now, there have been situations where you got it here right, you got it here right, but when you do it here, you're either too dorsal, palmar, and things like that. So, in your supination oblique view, if you're good, then I think you're likely to be good in the other views. Now, this is the follow-up of the patient, and this is again, sometimes I do. I agree this is middle third or even proximal third fracture. So in this patient, I opted to do a fixation from the palmar side. Again, these are the important things to you. The EPL there, first extensor compartment there, you got the nerve there. Then you make a small cut, you use a needle as your guide wire sleeve. You come to the distal pole of the scaphoid, and then you drive the guide wire inside, get it center, drill the screw, and then drill the hole, and then put the screw inside. You can definitely have a lot of complication. All of these are mine, okay? So you put a screw and you can break the guide wire there. Now the easier technique would have been you drive the guide wire in, get it out on the palmar side and keep it. In fact, the surgeon who told me, who was assisting me in this operation told me, you always do it, why did you not do it this time? So the thing is, don't break your rules. Always do the same thing so that you don't get into complications like this. Again, this is a short screw. So you can see, this is the supination oblique view. This is very, very good in this view. But if you look at the supination oblique view, you're not okay. So you can have a short screw. And then this one, you can have a screw cut out on the medial side. You can have the screw cut out all over the place. So these are complications which are best avoided, and it should always be avoided. Thank you so much.
Thank you, Dr. Srinivas. We'll have questions at the end of the session. Can I call upon Dr. Terence Jerome for his talk on scaphoid non-union, how to approach?
Good morning, all. Respected chairpersons and then my dear colleagues. Thank you so much for this opportunity. Special thanks to Sivakumar sir, Prahalad, Dr. Prahalad, Dr. Vinod, Dr. Muthu and the team who has been successfully organized this meet. With this brief introduction, I think my topic is on the scaphoid non-union. Probably I like to say evidence-based approach, or how I approach. These are my disclosures. We all know that the concept of scaphoid non-union protocol keeps changing, right from 1946 to 2023, and hope so also in the future. What we know is we don't have consensus on scaphoid non-union or scaphoid fractures which may go for a union. So Joe Dice once said that you show me the scaphoid fracture or in an X-ray, it's very difficult to say it's healed or not. On the contrary yields, even if you show scaphoid fracture united, there might be difference in opinion between two different operating surgeons. One say it's united, others say it's partially united. So meaning to say that scaphoid non-union and the union is also very difficult to diagnose. I like this slide because Girdlestone once said that the bone is something like a plant with its roots and soft tissue where its vascular connections are damaged. Then it requires not the work of the cabinet maker, something like a gardener. You need to garden the the scaphoid with its vascular connection, or you need to garden the scaphoid to heal or to go for union. We all know that the intraosseous supply is precarious in scaphoid non-union, and one of the reason for going for AVN. Other predisposing factors that Singhi is told that most of the scaphoid fractures, around 80 to 90%, they unite well with treatment and with conservative. So we have only 5 to 10% of the patients who have scaphoid non-union and where we need some treatment. The possibility could be that the patient had a displaced fracture or other comorbidities like delayed diagnosis and treatment.
So as I mentioned, the problem is only 5 to 20%. There will be pain, restriction of movement and limitations of activities. And these are the cases where the X-rays and the MRI and CT scans are helpful in diagnosing the fractures. CT will help you to understand the trabecular pattern, and MRI will help you to differentiate whether these patients have AVN or not. And then the grading is also equally important, because you should also know whether there's any associated deformity or what sort of non-union is there, whether it's a vascular non-union or a fibrous non-union or even a complete collapse and then has a bone cyst or not. So this non-union is also important when you grade this according to this slide. So ultimate treatment is to get the bone union, correct any deformity. This deformity can be because of a humpback deformity, and stabilize the carpus bone. A rigid fixation is ideal, and this relieves the symptoms and probably the future arthritis. Challenges we have is lack of consensus. We have couple of hand surgeons here. We have ourselves our own surgical technique and our own surgical expertise. So we can't force you to say this is the ideal treatment, but there is a consensus, general consensus. You need to fix the fracture, probably with a vascularized or non-vascularized bone graft that will allow you to heal. So there are concepts where you say that screw alone can do a good fixation and can give a good union. So this is one series of it all from Ikeda and Hegesi. They found that a stable non-union of scaphoid screw fixation alone does well. Similarly, this is a medical student who came with failed conservative management of 6 months, and what we did was just a percutaneous fixation, and this fracture healed well at 6 months. This is the follow-up of the same patient. So again, the question also arises whether we should do non-vascularized or vascularized bone graft. I think there is a paradigm shift which everybody will understand, or everybody will agree with me. We are moving towards a non-vascularized bone graft. The concept of vascularized bone graft has been limited to specific indications. So I think good news is here that you can use a non-vascularized bone graft in most of the scaphoid non-unions when it's indicated. So we have this patient with scaphoid non-union of 9 months old. What you could do is, these are the MRIs, and what you could do is we harvest a chunk of non-vascularized cortical graft from the distal radius, just put it in between the scaphoid non-union site, and then we fix to get this functional outcome. Similarly, again, a 25-year-old man where we had a strut graft from the distal radius interposed between the scaphoid non-union site, and this was the follow-up where you could get. Similarly, again, there's a patient of 2 years non-union where a strut graft was used. The limitations of strut graft alone without fixation is that it could be, it needs a long period of immobilization, and probably it's inconsistent with avian conditions. So there is a role for vascularized bone graft because it is an osteogenic progenitus. It gives some sort of blood supply and also have a graft which does not resorb, just sort of stability can be obtained from vascularized bone graft. So there are types of vascularized bone graft where it could be a pedicle bone graft or it could be free vascularized bone graft. And fixation modalities are also like upgrading. We have a study from Eugene et al. They say that you do a plating or do a 2 scaphoid screws, more or less the biomechanical strength from a union is also good. The union is also good in these cases. The other possibility is that we also know that assessing postoperative scan, the postoperative union is mostly by the CT scan. So what we also propose that a high-power Doppler ultrasound is also helpful, equally helpful to assess the union of scaphoid. This is a quick slide. So how we do these high-power Doppler in postoperative patients of CT, scaphoid non-union, we compared with the CT scan and also the Doppler, power Doppler. We found that both the results are equal. We could get the graphs and we could publish the series in JHS British. A quick couple of cases here, a scaphoid non-union, which was treated with 1-2 intercompartmental pedicle vascularized bone graft, and this patient did well. We also found that postoperatively the union was confirmed by hyper Doppler, and this is the functional rate of movement at the follow-up. Similarly, case 2 with scaphoid non-union with a collapse in the cyst and also a humpback deformity. What we could is curate the cavity, put a vascularized bone graft there, and this was the union, and this was the final follow-up. Again, this could be confirmed with a non-vascularized bone graft. This is an interesting case where he could not see a scaphoid fracture at the presentation at 2016. 2016 December, the scaphoid fracture was diagnosed with a CT scan. Patient did not have any treatment. 2017, this is the series where there is sort of collapse and sort of deformities happening around the scaphoid non-union. 2018, this developed into avian. So this is what serial X-ray we had, and I performed a vascularized bone graft in this patient, and this was the postoperative CT, which compared with the power Doppler. So more or less they say that this fracture is going to union with all these features. Immediate post-op, 4th month, and in 6 years of follow-up, he is doing well. So this could be published here in this. So there's one interesting study which we did with Scott Wolf, who is the author of the Green's operative hand surgery. We found there are certain predictors which say that these are reasons where the vascularized bone graft or a non-vascularized bone graft tend to fail. Non-vascularized bone graft tend to fail if have delayed presentations. Vascularized bone graft has to be carefully done if it is a humpback deformity. Also, we found certain cases of rare injuries where there is a perilunate fracture dislocation with a proximal scaphoid attached to the lunate. Here, what happens is this scaphoid is being lying there for more than 4 years with perilunate dislocations. What we need to do is just reduce this fracture, and then you could put a screw fixation there, and this is how it comes. So scaphoid is completely intact with the lunate. We just need to fix with the distal scaphoid, and this is how this fracture united. So we also know that there are certain number of patients who are still have a scaphoid non-union, but they do well. So we revisited retrospectively 20 patients who had scaphoid non-union, and they're happy. They don't want any surgery. So this is one interesting study. We found that not all scaphoid non-union does need surgery, but there are some indications where if you have collapse, we call it snack deformity, they might land up with arthritis, and then they do well. This is one patient who we call as happy scaphoid non-union. He does not come to me for the scaphoid problem. Rather, he came to some other problem. So we need to say that these scaphoid non-unions, they do well if you don't even manage for longer durations. Certain cases, they have problem where you need to have surgery. The other last component is that distal scaphoid non-union is also rare, but it is reported. So we also have a series of distal scaphoid non-union. What we found is that this is a medical student who came with the distal scaphoid non-union here. What we did is we put them on conservative management. Even though it has looked like non-union fragmentations and collapse and deformity, it has healed well. With this, I invite you all to the Trichy first annual orthopedic conference. That's on 19th November. I invite you humbly to attend this meeting. Thank you once again for this wonderful opportunity.
So thank you, sir. Now the scaphoid session is over. Any questions on the for the first two speakers from the floor?
Very nice presentation.
Thank you.
I think for Terence, I would like to ask one question. Most of the time when they come in a delayed way, you do an MRI, and in the MRI there is a picture of early avian. We don't know what is the grade of that early avian, and many radiologists are in the habit of giving early avian, and we are not also sure of what to do. Okay, grafting and osteosynthesis is accepted, but how do you take this report of early avian, and how do you proceed? And legally, how far we are permitted for this?
So again, it's a very valid question. We also look into features of early avian. Sir, I take it as even if it is avian or not avian, I see how much amount of proximal bone is viable, or in the CT scan whether trabecula is intact, or you have the possibility of putting a bone graft in between. I don't have a good view of avian or early avian or late avian. I look at it as a proximal bone. Unless you have a gross collapse, you don't have the possibility of reconstructing. Still, I give a try of a vascularized bone graft, and then I'll fix it. Legally, I don't find any reason to worry about early or delayed, because avian is very difficult to diagnose initially in scaphoid fractures, unless if it's a proximal pole, not treated, and then been lying for a long time. So very difficult right of treatment. Also gray zone of understanding what to do in such cases. But rather intervention does really good to well in fusion.
Sir, just a question, an extended question that was asked by Sivakumar sir. That is, what is your indication for a proximal pole excision?
Sir, there are few studies, I think one from Mayo Clinic also. Scaphoid non-union, they excise the proximal pole, and then they take the hamate, the proximal portion of the hamate, and then they come and fix it. Excision alone doesn't give you any improvement, or doesn't give you any solution what you wanted. You wanted a pain-free mobile wrist. So excision alone doesn't give you this result, the proximal pole. Rather, it should be reconstructed either with a vascularized bone graft or with a hemihamate.
So there is absolutely no indication for
I
it.
don't find any advantage or sort of thing in proximal pole excision alone.
Even though if it is totally avascular and it is...
As Dr. Bhatt sir mentioned, that there is a possibility that scapholunate instability might occur, because you remove the scaphoid from the proximal pole, the scapholunate gets into problem, and then you have a slack wrist, scapholunate advanced scapula collapse. Thank you.
A beautiful demonstration, presentation. I think so. Terence has lot of publications and papers on this. Just one silly question, like, see, everywhere we cannot find Terence and Anil Bhatt sir to come and do microvascular flap, vascularized flap. No, what I'm asking is it possible for a general orthopedic surgeon to do a microvascular flap, like vascularized flap for scaphoid? It's just muscle pedicle flap, or you need to find an vascularized vessel pedicle and then you have to do that?
It's a good question. Thank you for kind words.
Yeah.
So good news is that you don't now the shift is towards non-vascular bone graft. Even a distal radius do well. There are specific indications where we have the role of doing either pedicle or a free flap. Those are all scaphoid fractures, failed scaphoid fractures, failed non-unions. There we need to do a free medial osteochondral flap. Those are all vascularized bone graft where we need to do a free. We have to do free anastomosis. 1-2 intercompartmental supraarticular artery is quite technically needs a learning curve, but you don't worry. Good news is that you can do with a distal bone graft. Most of the cases you can do well.
Thank you.
So next one question is for the first to Dr. Srinivasan. Sir, do you immobilize fixation after the fracture fixation? Do you immobilize the fracture, sir?
I think so. Sir has left, sir.
Okay.
Has a flight.
Okay. Right.
So, I would modify the question whether you want to put a thumb slab or a below elbow cast. Both have same intention and same purpose. Rather, I moved to a below elbow cast. Thinking is that 15-20 years back, we know that the reason for clubfoot was calcaneocupoid joint. It took 20 years to think 1 inch above. That is the subtalar joint. Similarly, it took 20 years for us to change from the thumb cast to a below elbow cast. We have a empty number of biomechanical studies to prove that below elbow cast is sufficient. I have moved to below elbow cast. And the duration is around 4 to 6 weeks. Why 4 to 6 weeks? Because by the time you get to know it is united by a CT scan is around 4 to 6 weeks. To be on the safer side, I would like to do an early CT scan around 6 weeks and see if it is partially uniting or uniting. If it is uniting, a good news. I will still prolong for 4 to 6 weeks with a removal splint and then start therapy on it. I think Dr. Pak may have some different opinion on it also.
I mean, below elbow, what do you mean by below elbow actually?
Thumb free.
Okay. I would put it at the IP will be free for me.
Okay.
Yeah. That, I mean, the good old teaching of up to nail and all is not there, but IP joint can be left free. It's like the same concept of one joint above and one joint below.
Thank you, sir.
That is what, and to answer to my first vascularized graft, quadratus, muscle ped, that's what we were taught. But we have a large series published recently where at all levels of non-union, we just use cancellous, distal radius cancellous compact graft. You need to compact it nicely. It almost acts like a cortical strut. At the same time, it's cancellous bone, so it also gives the vascularity. And MRI is like a photograph at 1 point of time. When you take an MRI at 3 months, it's different, 6 months is different, 1 year is different. So when patients come with MRI, it's like a photograph taken during a process of avascularization or revascularization or infarction. So we need to understand that. Absolutely no, as Terence said, no legal implications because it's a process. And in the beginning, when the avascular insult happens, the body is trying to heal it up with a creeping substitution and revascularization. That also can show, and then the revascularization happens. So we absolutely don't go by the MRI picture in that sense. You would go by the intra finding of punctate bleeding, intra finding of the cartilage, the quality of the proximal fragment or any of these, and then take a decision whether you want to go for a salvage or you want to vascularize it or you would just put a cancellous graft. I think that should be the way it should be looked at. Anyway, thank you. Coming to my topic.
Thank you. We got a slight change in schedule. Calling on Dr. Anil Bhatt to talk on CRPS, how to approach.
Thank you. Thank you so much. So it's a difficult topic, and as surgeons, we all of us have faced this, and we will continue to face this, and we don't know which patients will have this problem. So the predictors are really, really tough to analyze. But then whatever evidence I have got up to the latest evidence, I try to put it here and give it to you.
So most patients, especially with distal radius for us in upper limbs, would come with this kind of a picture where this hand is swollen and the patient comes with a lot of pain. And if you carefully look, I always ask my PGs to document this in terms of, color changes and the loss of sweating and hair, because we are also looking at the sympathetic and parasympathetic system involvement. Classically, undergraduates are taught that there will be patchy osteoporosis in CRPS, but a lot of times you might not find that unless it's a late case. So most of these patients come with pain and limitation of movements. Now, a lot of patients with distal radius fractures who have just come out of the plaster may also come with this, and there'll be always this dilemma between a stiffness because of the plaster, or is it patient has developed CRPS. So you need to be very careful when you evaluate these patients in terms of their movements, in terms of their pain, in terms of other symptoms which are very specific to CRPS. So before we brand the patient to CRPS, you need to be looking at, is it because of immobilization stiffness, or is it because of CRPS itself? At the end of the day, it is a very debilitating, painful condition. There is sensory, motor, autonomic, skin and bone abnormalities. Most of us end up treating the other part. We all dump them with antidepressants and all those things, but we are not treating with why that limb went for dysfunction. So the very specific criteria are there. One of the commonly followed criteria would be the Budapest criteria, where there is a presence of continuing pain which is like disproportionate to an inciting event. For me, it's like almost similar to compartment syndrome sometimes. So that disproportionate kind of pain with your usual analgesics and NSAIDs, and must report at least one symptom in 3 or more of the following 4 categories. The first category, and also at least one sign in 2 or more of these 4 categories. The first category is the sensory system. There will be hyperalgesia or allodynia in these patients. The next category is the vasomotor. There will be temperature asymmetry or skin color changes or skin color asymmetry. The third is the pseudomotor or the edema, which means sweating changes or sweating asymmetry. And the fourth is the motor or the trophic changes. There could be decreased range of motion, motor dysfunction in terms of weakness or tremor, and trophic changes where you see the skin, dry skin, the nail changes, and also the hair growth which is lost. And at the end of the day, when you want to brand a patient with CRPS, there should be no other diagnosis that better explains the symptoms and signs. Is it because of plaster? Is it because of the fracture? Is it because of patient is completely quite not mobilized? You rule out all those things, and then you come to this diagnosis of a CRPS patient. As I said, for me, it's almost like compartment syndrome. So I have put my management of 4 Ps here. We all know about 6 Ps and 7 Ps. You need to prevent it as much as possible. Physical and occupational therapy plays a huge role. Pharmacological agents and procedures sometimes. And of course, patient counseling and psychological intervention. So these are the components of a CRPS. Now how many of you use these drugs? NSAIDs? Any show of hands? Muscle relaxants? Antidepressants? A lot of them. Anticonvulsants? Steroids? A lot of them, again, okay. So these are the ones which commonly are used. Yesterday also, when we were judging the poster, I think somebody said, I put her on tryptomar and she was fine. But then, that's not the case always. So what does evidence say? There's absolutely no major evidence for paracetamol for the degree of pain control, and there'll be some amount of evidence for NSAIDs in CRPS-1. Absolutely no evidence for anticonvulsants like carbamazepine, phenytoin, and antidepressants. And there's absolutely no evidence for muscle relaxants. We are unnecessarily giving all these medications for our patients, especially muscle relaxants. So there is no evidence. If you search through the evidence, you hardly would get anything for these kind of things. Corticosteroids may have a positive effect on CRPS-1, but we don't know what is the duration and dosage. People have tried from 30 to 100 mg, from 2 weeks to 3 months, but there is no huge evidence for that. So this particular 2022 systematic review shows that prednisolone may be effective in alleviating the CRPS symptoms, but of course not much evidence there. So steroids might play a role, but not absolutely no evidence. So I would give you at least 3 or 4 major evidences. One of the major evidence, level 1 evidence, is vitamin C. And vitamin C will save you from a lot of these patients coming back to you again and again. So please, look at the evidence and use vitamin C, daily supplementation of 500 mg of vitamin C, up to about 50 days, decrease the 1-year risk of CRPS after wrist fracture. So this has one of the highest evidences if you look at all the systematic reviews here. And it could also prevent CRPS also. If you have a patient you know is a type A kind of personality, or somebody who would not mobilize their hand and wrist and elbow and might be developing CRPS, start them on vitamin C. So there is a very good evidence of vitamin C. Most of this is again 2021 systematic review. The second evidence, bisphosphonates. Bisphosphonates have almost changed the way we have been treating CRPS. Again, level 1 evidence, RCT, systematic analysis of RCTs only this particular studies, and show that the CRPS1, they have a huge role with bisphosphonates. Okay, and again, even parental bisphosphonates are first line of agent. We don't use it in our routine practice, but first line of agent is recommended for bisphosphonates. So the bone mineralization, demineralization often accompanies CRPS, and the bisphosphonates basically inhibit bone resorption, improves pain and edema, and that is how they act in this. The third evidence is ketamine. So you're going slightly towards the invasive procedures now. Ketamine infusion has got a very good role, and so if you have a good anesthetist with you, if you have a good department backup, we work with palliative medicine in our institution, and they give these ketamine infusions, short ketamine infusions for this patient. It works wonders for some of the categories of patients. The fourth evidence is, of course, physiotherapy with in management along with the pharmacological agents, and again a very strong evidence of this graded motor imaging should be there. I'll come to that. What is it? So this is one of the major things which we have been using in our CRPS patients, which is called as a mirror therapy. I'll show you how to do it, and I think all of you should have that in your armamentarium if you're dealing with upper limb fractures. It's basically to create an illusion of normality in the affected limb, and involves concealing the affected limb behind the mirror. I'll show you how we do it. And the non-affected limb is positioned so that its reflection is superimposed on that mirror to where the affected limb should be. So the brain is tricked in such a way that what the patient is seeing is the normal limb. Okay? And the brain has been shown to prioritize visual input over proprioceptive input. That is and it's an Indian who described this, who has come out with this studies, and it's a beautiful way of dealing with these patients. And then there is the next step is what is called as graded motor imaging, where participants see a lot of photographic flashcards, because what happens is the patient dissociates their limb completely away from the body part. So that is a problem with CRPS. They don't want to recognize that it is their limb at all. And participants imagine moving the affected limb into the position demonstrated on the photograph, and then the mirror therapy comes. The other last evidence, probably not very strong, is gabapentin. Gabapentin works basically, especially with neuropathic kind of etiology. And if you look at the dose, it's quite high, and generally it's less than about 50% of the patients. So, but then it has positive impacts on depression or exhaustion or sleep disturbances. These are only the end result of CRPS. We are not treating CRPS here. That's why I put this evidence last. And more than half of the patients taking gabapentin will not get meaningful pain alleviation, but may experience negative side effects. As I said, prevention is always better. Regional anesthetic techniques like brachial plexus blockade and then stellate blocks. But stellate blocks, if you put the first stellate block, patient responds, then only it works. Otherwise, it will not work. So don't keep on going on giving stellate ganglion blocks. And then also calcitonin spray is also supposed to be preventive. What we follow at Manipal based on all these evidence. Prevention, we start with vitamin C. Sometimes we give regional anesthetic techniques like brachial plexus, or nowadays we have switched over to sometimes ketamine. Edema management, contrast baths, splinting of the deformities, and of course active assisted mobilization of shoulder and hand, and then the mirror therapy. This is how the mirror therapy works. This is the box you create, and one side it has the mirror, like this. Okay, so the patient places the injured or the CRPS limb inside this box here. Okay, and they sit opposite. The therapist and the patient sits opposite here, and on one side is this mirror here, and this is what happens. Okay, this is the injured limb now, and patient has less grip, there is a lot of pain, there is a lot of swelling. Okay. But then when the patient keeps the same limb inside now, this is the injured limb inside, this is the normal limb here, and he's looking at the mirror, and the brain is tricked that what is inside the box is the normal limb. And now see the grip, what happens. His grip is really strong. He's assuming this, what he's seeing in the mirror is the normal limb, but actually moving the injured limb inside. Okay? So this is how the mirror therapy happens, which is basically the visual inputs to the brain is much better than the proprioceptive pain, and that's how the mirror therapy works here. We do these stretch board kind of exercises. We also concentrate on the upper limb like this. These are stretch board exercises which can, these pecs are changed, and slowly the range of motion is increased each day so that the amount of flexion increases. So they have a lot of, our occupational therapists have a lot of these gadgets. It's all done there, very cheap. Can be done in your clinic or your nursing homes or hospitals, wherever you want. It doesn't cost much, but they are very, very effective in getting their range of motion. So it's classic shoulder hand syndrome. Shoulder will also be stiff in these patients. So you need to be using all these gadgets here. I said we start on vitamin C for about 12 weeks if the established CRPS is there. Pre-gap 6 weeks if there's a lot of overlay or functional component in these patients. We do give NSAIDs, but then just a short course for about 10 days. And we use this lignocaine and prelocaine cream. Actually, this is by the palliative medicine, so it helps a lot for them in a local control of their pain. And they feel better, so that is used with these. We might add vitamin D or vitamin B12 or calcium in some patients based on the blood levels, nothing else, not routinely otherwise. This is day 1 patient. Hardly any amount of flexion, swollen hand, just barely able to do this. This is how we admit them at least for a week, all these patients when they come. We insist that they get admitted, and slowly the improvement happens here. This is day 4. By about day 5, they're able to do it, and they're able to have good pain relief. It's not that they get a full fist, but they're able to get good relief of pain, and they start cooperating with you, and that is how it continues at home for them. And by about day 7, you see the edema has disappeared. You can see the veins there, almost able to make a fist like this. So this kind of protocol has been working for us a lot. Bisphosphonate, sometimes we use a second line, even though nowadays the evidence is primary kind of first line treatment. And then ketamine infusions, we use, all these are invasive procedures, we usually keep them as second line. And local blocks sometimes, and stellate ganglion blocks. So increasing evidence of role of central mediated systems here in the development and maintenance of CRPS. And symptoms are due to changes of cortical processing and neuroinflammatory process. And use these drugs based on the evidence. Please go read about these and know not to use muscle relaxants, anticonvulsants unnecessarily on these patients. And that probably gives a lot of good results. And there's emerging evidence that techniques like mirror therapy, what I showed, is very, very useful. I take this opportunity to invite all of you to our Oasis Con, which will be the next weekend. All the South Indian states, please do come. And if at all our friends of hand surgeons are here, who have inspired you, we have our ISHCON next weekend, the week after that at Chandigarh. And I'm the secretary for the Hand Society, so we want, if at all we have inspired you about upper limb and the hand, we want you to be the members of Hand Society. There are a lot of opportunities, a lot of fellowships. Praveen is here and Terence is here. They do a lot of good academic work, so I want you to be a part of it. Thank you so much.
Thank you, Dr.
Thank Prahalad and Sivakumar sir for this opportunity. I think it's great. I think the future is not about big conferences, but very, very high quality work and conferences or meetings like this. That's very nice. Thank you so much.
Thank you, because it was a very rare topic. I think none other than you can present this topic in such a presentable way. I think we cannot even take this in the books because there is a lot of confusion also when you go in through the text and literature. There will be a lot of confusion about the RSD and these things, CRPS, and somehow or other you have presented it in a very nice way. Thank you, Dr. Anil.
Thank you, sir.
Thank you so much. Oh, sir.
But sir, just can I have one question? That is, how long usually it will take for the patient to return to a normal, sir? Actually, I am an unfortunate doctor who has been sued by a patient who is a distal radius fracture who got CRPS, and the case went on till 1 year. And at 1 year, when the judge told her she's absolutely fine, so they couldn't find any fault in me, but case is still running. But the patient thought after 2 months that this guy has done something exclusively wrong in the wrist after putting the K-wire. So it took her almost 1 year for her to become normal. She's consulted several doctors. She didn't stick to any protocol or any single surgeon. That was the main problem, I think. Exactly. She left my treatment and went to 5 or 6 people.
Exactly.
And so what is the average duration of time in which might get okay?
As you said, that's so variable because it depends on when they come to you and where all they've gone and what all has been happened. And you know, the patient should have that confidence and come and stay with you if you have a defined protocol. That's very important. That's why I said we insist them to get admitted, and they themselves see the results which happen on day 7. 1 week of therapy and you know, all the medications, constant supervision and change of splints, and all those things happen in that 6 days when they're there in the unit. I tell them Monday if you come, only Saturday you will go, you won't ask for that. So it's very variable, but if you are behind them, I think I'll give a timeline of 3 months for them to be much better than what they were on day 1. So that it'll take some time, because again I showed you day 7, still not able to make a fist or anything, but they start cooperating, they start going home. I mean, when they go back, they start doing their work and everything. I ask them to come back on an OP basis into occupational therapy, and you know, so by about 3 months they're very happy. They say I can do this. So ladies especially, they just want to tie their hair independently. So they're very happy with those kind of things. So I would, if the protocol are followed, probably by 3 months, I think you should have a very happy patient with you.
And sir, in TKS and all, we tell that before pre-op night you give a gabapentin 300 preemptive pain management or like thing.
Okay.
Anything has a role in this?
Only vitamin C.
Okay.
Only vitamin C.
Thank you. Thank you.
Anil, very lucid presentation, and CRPS, as the name suggests, a very complex one. I just have one question. I mean, the old classification of CRPS 1 and 2 is gone, or?
No, it's still there, sir. So I didn't really go into that, but make sure it's not CRPS 2, which means, especially in an operated case, or any patient where a nerve is going along that particular site of injury, always rule out that. So there is again a role of sometimes carpet release and those kind of things, even in distal radius where it's not operated, because there is some underlying kind of an injury in these patients for the nerve. But if you know that somebody's operated, there is a nerve which might be damaged there, make sure that we get the NCV and ultrasound, especially ultrasound, for us to trace the nerve. And that is very easy to treat for us, because if there is a nerve, it's damaged, there's a neuroma and there's a CRPS, it just goes off after your treatment. So that differentiation has to happen in terms of a nerve injury related CRPS2 versus this.
And the second thing about the bisphosphonates, I thought their role was mainly as anti-resorptive. These patients, you have an osteoporosis of the juxtaperioarticular.
Yeah.
So I thought that was meant for that. I didn't know it had a relief pain.
It has an antioxidant effect with the anti-resorption, bone resorption effect, which will drastically reduce the edema and pain in the beginning, but it has a continuous effect later, a cumulative kind of effect later. So what is the thing, bisphosphonates?
Thank you very much, sir, for
Thank you.
the very beautiful presentation, because CRPS, everyone in our, I think so, if somebody has tell that he doesn't come across this, then he's not practicing, I think so. So what is your take on steroids? Like?
Yeah, we generally avoid them because, again, we search for a lot of evidence for that, because generally for me, a lot of patients would have come with a course of steroids already. So our threshold is really high to put them on steroid again. So we don't, and I don't know the dose. We saw the evidence. There's hardly anyone telling what is the dose, what is the duration. Both are all very
ambiguous, as of now at least.
Thank you very much, sir.
May I ask one?
Sir, one.
Out of the box question probably. We know about medication, what you have told. Any effect of meditation and any evidence for that?
At the end of the day, I think the person who has to meditate is a treating doctor.
Thank you, Dr. Bhatt. We'll go on to the next topic on perilunate dislocation by Dr. Satyavam Krishna.
Good morning. I thank again the Preethi Hospital for this opportunity. So today I'll be speaking on the perilunate fracture dislocations. So before we start, I think I'll just touch up on the brief anatomy. I think first thing is we have to get our carpal bones, the anatomy well. So then, so we have many volar ligaments, extrinsic ligaments. So this is where you can see this is a space of Porio where there's a weak spot where the lunate can dislocate. And dorsally, if you come across, there's only one ligament, unlike the volar side, that's the DRC. You can see that this is a single ligament, so connection is a very crucial ligament. Other one is DIC, between the triquetrum and the scaphoid. And coming to the intrinsic, that is within the carpal bones. You see, this is a scapholunate. Scapholunate is like nothing but like a ACL for the hand surgeons. And you see lunotriquetral, you see the volar is strong. Dorsal is strong for the scapholunate. So just a brief anatomy. So I think most of us miss the perilunate because we miss the what to look in the radiographs. So whenever you see a lateral view, you look for the lunate and the scaphoid. So normal is 30 to 60 degrees. When you see lunate tilting back, that means it's a DC. Tilting volarly, that means it's a VC. So these are things you have to look at the lateral view. And also the captate, lunate and radius has to be in the same line. So coming to the anterior PA view, you have to look at the gillulus lines. Most of you know all this. So these bones form a 3 parallel lines. So you can look at these dislocations where the gillulus lines are not maintained. So coming to the main topic. So this is the Mayfield. Of course, most of this is controversial, but most of us do follow this. The injury starts at the scapholunate interval. Then it goes to the lunar captate, then the lunar triquetrum, and then the complete lunar dislocation. So I'll just show you a graphical image. So you see what happens, the mechanism is when there is a extension, intercarpal supination and ulnar deviation. So first thing that happens is, you can see that's the volar scapholunate ligament which is ruptured, but still the joint is okay. Then the insult continues, then you see both dorsal and volar is gone. So now scapholunate is completely ruptured. So this is where you see the scapholunate instability. Then when the insult proceeds further, then you see the captate goes behind. So this is called as dorsal perilunate dislocation. That means the captate is dorsal, but lunate and radius remains same. So this is like a stage 2 dorsal perilunate. So just get this in mind. So then next what happens, then the insult continues and the captate tries to push the lunate out. This is lunate dislocation. So that was perilunate, this is lunate. This is the last stage of lunate dislocation. So see, this is the example of a dorsal perilunate. You see this, the lunate and the radius is in alignment, whereas the captate and the rest of the carpus is dorsal. So this is dorsal perilunate. So coming to the last stage, there's lunate dislocation. That means, the lunate is out. So whenever there is a fracture, you have to add the word trans. Like, suppose you have a scaphoid fracture, we say it's trans-scaphoid. Or if you have triquetrum, you have to say trans-scaphoid, trans-triquetral fractures. So what do you manage? When you see the patient first, of course, you can try close reduction in the emergency. Just give traction and try to put the bones back. But most of the times it's unsuccessful because they are so unstable injuries, you can never get them in alignment in the ER. So most of them will require surgery. But if you don't get it, nothing to worry. So then what happens? Then you want to do it emergency or elective. How do you decide that? Say emergency when there is a median nerve compression. And the patient complains that there's a lot of numbness in the hand. Then I think you need to take up this case for the emergency. Or if you can do it electively. So again, dorsal or volar. So normally, traditionally, all wrists we go dorsally. Volar is recommended when the fragment, as I showed, the lunate is hitting, too volar, hitting on the nerve. where we have to do a carpal tunnel release and get that fragment out. Or some surgeons also advocate repairing the lunar-triquetrum volarly because that is thick there. So then coming to the approach, dorsal approach. So this is the Mayo's approach, Berger's ligament sparing approach. So you retain the part of the ligaments and you take a flap. But unfortunately what happens, most of the injuries, there's already a rent created. There's nothing for you to look for the approach. So just go through the rent. If you think that capsule is intact, then you use the ligament sparing. So here you can see that the dorsal capsule is stripped of the distal radius. So then suppose now there's no fracture, there's only soft tissue injury. Then what you have to do is, as I told you about the Gillow lines and the other alignments, you put a K-wires in the scapholunate, you use a joystick, reduce it, and then repair the scapholunate ligament. So here we use a suture anchor. So most of the times what happens, the rupture happens at the lunate. So you have to use a suture anchor on the lunate to repair the scapholunate. What if there's a fracture? The other common thing is you have a scaphoid fracture, usually they are proximal pole. So here then we have to, there's nothing to repair, we have to use a screw, Herbert screw. Then lunar triquetral, of course some surgeons repair it, but for that you have to go again volarly. So opening both sides may not be a good idea, but I generally just use a lunar triquetral pin. Then after this what happens, you just want the joint to be stable for some time. So you use this diamond fixation. So you pass a scapholunate, lunar triquetral, then you pass a wire to the captate. So they form like a trapezoid or a diamond shape. Then you immobilize them for 6 weeks. So I have to close the capsule, that's very important because the dorsal stability is dependent on that particular ligament. So this is one of the X-rays you can see well-reduced scapholunate. So coming to the neglected perilunate, what do you do? See actually, again some people recommend open, just try it irrespective of the duration. In my practice, if it's something 3 or 4 weeks more than the injury, I just go with proximal row carpectomy. So that's the easiest thing to do. So coming to the recent paper which we published, the new variant, it's a radially displaced. Here what happens, the ulnar nerve was injured unlike the median nerve. So thank you. I just want to share the regards from Dr. Rajkumar. I think is contesting for the next IAS Vice President. He needs your support. Thank you.
Thank you, Dr. Satya. So, thank you. We'll
thank you.
Questions at the end. Next, call upon Dr. Sunit to talk on DRUJ instability.
Good morning and thank you very much, Chairpersons. So I'll just briefly touch upon DRUJ instability. Probably we had a live surgery yesterday of supposedly wrist arthroscopy. So I'll just touch upon briefly the anatomy. If you see, the distal radial ulnar joint is the pivot for your pronation and supination. That's how your rotations are affected in this particular pathology. And if you see, there's a difference in the curvature of the radius as well as the ulna at this level. So the joint as such is not stable. It depends a lot on soft tissue stabilizers. And here comes the picture of the TFCC. And if you see, the attachment of TFCC is in a particular point called as the fovea, which is devoid of any articular cartilage on the ulnar head. So coming to the complex proper, this was described by Palmer and Werner. And the primary component, that's the primary stabilizer of this joint, is the radio-ulnar ligament. Again, 2 components, radial volar, superficial and deep. And if you see what's the concept of stability, the one what we see from the joint proper is only the superficial part, which is just a shock absorber, while the deeper invisible part from the routine wrist scopy is the one which is the primary stabilizer. So once the deep foveal attachment is gone, your just TFCC starts floating up and you develop this instability. And the other components of your complex are the articular disc, which is a primary shock absorber with minimal role in stability. And then you have your ECU sheath, ulnocarpal ligaments. All of these have a role, and some dynamic stabilizers like your ECU tendon and pronator quadratus, and some role of the intraosseous membrane as such in this stability pattern. So if you see DRUJ instability, you can see them in a variety of injuries. It could be isolated DRUJ injury, acute or chronic. It can be associated with distal radius fractures or with Galeazzi fracture dislocations, with associated ulnar styloid fractures, or sometimes a chronic presentation or associated with arthritis. If you see the acute DRUG injuries isolatedly are predominantly because of TFCC injuries, and there is a classification by Palmer. Class 1 is a traumatic one, which we are routinely concerned of. This presents with the ulnar side wrist pain with or without clicking. When you try to reciprocate with the axial loading, they start developing pain. There is tenderness at the fovea. And when you try to compress this, the TFCC compression test is usually positive. You compress and rotate the forearm to locate which component could be the pathology. Then you check for the translation of your distal radial ulnar joint. And in chronic cases, you may find your piano key sign. You will just push it in and it starts popping out. So when you see a patient with acute painful DRUJ, so what matters is whether this joint is stable or unstable. If it is stable, though they are in pain, it's actually possible to assess that, and you just need a above elbow splint in 4 to 6 weeks of neutral rotation and reassess after duration of 6 weeks. But if you are suspecting instability, then the possible attached lesion here could be a foveal detachment. That would be a 1B Palmer injury, and that's where the picture of MRI comes in. And if you have a significant tear in a high demand patient, you can either go for an arthroscopic or open TFCC repair. That's a type 1A tear, a central perforation post-traumatic, and usually central perforations are treated by debridement. And if like in a degenerative tear, you may add a wafer resection or ulnar shortening to take care of your ulnar positive variants. Yeah. So, and a type 1B tear is where your undersurface, that's the foveal attachment is gone. There are indirect signs like your trampoline sign is positive, the tautness is lost. You can actually hook up the entire TFC complex up like with a hook. You see it's totally unstable in the small video that's being played down. And there are many ways of treating this acute DRUJ instability. If you find a peripheral tear, a massive peripheral tear, in spite of having an intact fovea, also can have a significant instability. So we do a outside in repair. That's the commonest way of doing it. Sometimes inside out. But if your pathology is in the fovea, you definitely have to reattach your disc or the ligaments back to the fovea. And there are many ways, arthroscopic or open. And the routine way of doing it is arthroscopic transosseous repair, where tunnels are passed across the fovea, and you pass sutures, loops, and non-absorbable suture is taken. Fiber wire of configuration 20 is passed, and then you just pull it down to the fovea and either tie it on a bone-off bridge or a push lock anchor. That addresses your instability part. And this patient, like the video shows, it's also got a massive dorsal peripheral tear. So here you also do an outside-in repair of this dorsal peripheral tear. So that complex, whether it's a massive dorsal tear or a foveal tear, sometimes have to be addressed incomplete. And most of these patients end up with a plaster, above elbow, or a sugar tongue kind of splint for a duration of 1 month, and then go ahead with your rehab. So on an average, we say it takes about 6 to 8 weeks for the rehab process to complete and get back to work. And the minor patterns, like majority of them, just go for a debridement. And when you see these instability pattern associated with a distal radius fracture, the incidence is almost 80%. And the risk factors at time of presentation, if the patient shows very wide displacement, or there is severe shortening of radius, that's when you expect the complex to be torn. And whenever you fix them, you have to follow the parameters, like the radial shortening should not be more than 5, the inclination, angulations. Only when you restore the radius, you can expect the ligaments to heal properly. So intra-articular fractures again have a significant role in this instability, and it's always your fixation that is important. So whenever you find a distal radius fracture, the first thing to do is anatomical fixation. You can't expect stability to restore with a suboptimal fixation. So after your anatomical fixation, then assess it again. If you find instability only in a particular position, you can pin it or put a cast. It doesn't really matter. But if it's a multi-directional or a bidirectional instability, preferable to go for an open or arthroscopic TFCC repair in the same sitting. And the other pattern is where we see the Galeazzi injuries. Again, here the distance from the joint has some particular significance, like in type 1 injuries where it's within 7.5 centimeters, the incidence is more, and type 2 where it's much far away, the incidence is less. So again, the anatomical reduction of radius is of paramount importance here, and after fixation, if it is reduced and stable, just immobilize. If it is reduced and unstable without a fracture, just pin or cast it. With the fracture, try to fix the ulnar striatal fracture and cast him. But sometimes you find irreducible DRUJ dislocations in Galeazzi where you need to bring out the interposed tissue where ECU is the primary pathology. And isolated ulnar styloid fractures, again basal fractures are the one which are supposed to be a culprit which add to this instability. Indications of fixation are young patients, basal fractures, high demand patients, heavy laborers, and there are many ways of fixing it, a simple K-wire, but preferable to do it by open procedure. You can never get a styloid fixed by closed procedure. You can use steam tension band wiring or headless screw depending on the size of the fragment. Coming to chronic one, chronic pattern is seen in chronic TFCC injuries more than 6 months, as other also with malunited distal radius fractures, SX low pressure injury, made lung deformities. They present with loss of strength, weakness, instability, piano key sign positive, Trinclis translation. And the aim here is to correct the bony alignment if you have anything and to rule out arthritis. Only then we progress with your ligament reconstruction, and the procedure of what we routinely do is the Adams procedure. That's a reconstruction using palmaris longus graft. So instability pattern on table is shown better under anesthesia, and you go ahead with your tunnels on the radius, the graft is passed, and you routinely expect a reasonably good result with this reconstruction. There are other procedures like if you have arthritis and instability, no point in going ahead with reconstruction, like you have your Sivakapanji procedure, which is a procedure of choice in young patients, and Darax. Darax as a routine is not routinely done because there's a chance of radioulnar impingement. What we do is a modified Darax, especially in low demand elderly patients, where you put a tether of ECU tendon to prevent that impingement from happening. And I think that's all. Thank you.
So, okay, sir. The questions are at the end of the session. We call upon the next speaker to talk on carpal instability, Dr. Abhijit. Okay. Sir, then I call upon Dr. Jyoti Prashant to talk on carpal tunnel release, endoscopic technique.
Good morning, everyone. First of all, I would like to thank Dr. Prahalad sir and the organizing team to give me an opportunity to present before this august audience. I would like to play it as a video. That is a video. Okay, so in this video, I will show how we can do an endoscopic carpal tunnel release without much of a any other instrumentation. Just what you need is a 4 mm normal knee arthroscope. Here in this you have used, you have drawn the Kaplan's cardinal lines, and you have putting a S-mark bandage, and you put the tourniquet. It's totally under local anesthesia. You are putting an incision at the crease, transverse incision on the wrist crease. The incision doesn't move into the hand. Actually, the hand is totally spared from the incision. So, have a wireless mic, please. So, so as the incision doesn't go at the hand, all the incision is at the carpal crease only. So that's a small incision. You are using the 4 mm arthroscope. You are not using the irrigation fluid or anything. You are just using the scope to put it inside. First, once you put the incision, what you see is the palmaris longus. You just separate it with a retractor. Yeah, okay. And then you see the retinaculum. This is a flexor retinaculum. You are seeing cut. And you are taking a small scissors which is curved to the ulnar side. There is an ulnar side curvature to the scissors. You are visualizing it directly through the scope and visualizing the flexor retinaculum and slowly cutting it. You can see that in one hand you have the scope, other hand you have the scissors. You are just moving the scope forward and slowly millimeter by millimeter. Take care that you shouldn't open the scissors too much inside the flexor in the tunnel. You can slowly see and progress it towards the end. See that median nerve is down. You are nowhere damaging it. Your both hands are stable on the table. Okay, your both hands, your elbows are kept into the table and it is absolutely stable. Your hands will not move. With one hand you are seeing the scope and other hand you are just moving the scissors forward. See that? The entire flexor retinaculum can be slowly released like that. And you can just open the scissors edges so that it will also increase the space there. It's like a neurolysis of the slowly open that and you can have absolute control of what you are cutting because you are seeing the entire thing. You are slowly putting the scope inside, and you can do the same thing for the opposite in the forearm region. It's far more simple. You can see that extension of the retinaculum in the forearm region. And once you cut the entire thing, you can see the muscle belly. This is actually not a fast forward thing. It will take only 4 to 5 minutes. That is, this entire video will last almost 3 minutes, and you can put last small sutures, and that will be along the crease. So it will not, this is a usual scar, not that big, but this is a normal when it opens scar, and this is a scar. You can't see the scar at all. This will be hidden in the crease. So there is absolutely a totally scarless surgery. So I have done almost 150 cases from around from 2015. I have published the functional outcome also. So this looks very difficult, but initially in the maybe or the first 10 or 20 cases you might need some time, maybe some 10 or 20 minutes. But now my average time is 8 minutes. And the only thing is that the patient will complain of tourniquet pain because you are doing it totally under local. Initially when my time was 10 or 20 minutes, I had a bit of a problem with it. But since now I finish it fast, so when the patient starts complaining of tourniquet pain, my surgery is over. So this looks, the only thing is that you should take care of the recurrent branch of the median nerve, and you can see it properly because you are putting totally under arthroscopic guidance. So you can see the median nerve properly, you can see it entirely all the way through, and you can release it. So it doesn't need any sort of endoscopic cannulas or endoscopic retrograde knives, no two portals, only single portal is enough. Only thing is that a learning curve is maybe first 10 or 20 cases, it might need time. You can convince them for an open release if you are finding difficulty in it. But still, if you're trying to do converting it into open release, better do not a transverse incision because it will be difficult to convert into an open one. You can use a longitudinal incision and do the same thing with the scope. So, any doubts regarding this presentation? This talk is for 7 minutes. Video finished in 3 minutes. So, I wanted any discussion from the audience or any doubts for it.
Actually showed a scar, right? The advantage of the scar.
Yeah.
But you see most of the carpal tunnels, you see 1 year down the line, the scar is never visible.
Yeah, that is true. 1 year down the line, it is absolutely true.
So I just want to know what are the advantages of doing endoscopic over open, apart from the scar?
Most of the thing is that the pain, post-operative pain, and the most important thing is that the hand has got so much of neurons and nerve endings. The wrist, the proximal part of the wrist, the incision is converted from a high nerve zone intensity to a low nerve zone intensity. That is a neurological, the sensitivity of the hand and the wrist is different. So when you convert the incision from the hand to the wrist, the most of the post-op complications and pain is gone. So patient is absolutely okay. Patient might drive a car and come the next day because you have just only a small sticker down there. So the patient is getting back to normal life in 1 day. Maybe the next day the patient is okay with it. So that is what I found as an advantage. Maybe as a long term, at 1 year or something, it might not create a significant difference. But as everything is going arthroscopic, this is also going maybe, that's all.
Good. Jyoti, we'll have a discussion of all the papers for the next 5 minutes. It's a good display. You said you did the follow-up of these cases.
Yeah.
Did you check for the pillar symptoms?
Yeah, actually, I am publishing it. Almost 150 cases. I got a follow-up of 75 cases only. The immediate and it is under statistics. Probably within 1 or 2 months, the results will come. I published this method in a journal, There is this technique. As a surgical technique, I have published it, but the functional outcome I am yet to publish. It's under statistical evaluation. So the power and all has been assessed, and the post-operative pain score, everything is being assessed. But I don't have a comparison between an open arthros, because I am not doing an open
At all.
carpal tunnel at all since
Okay.
2016 maybe. Totally I am arthroscopic.
See, Stryker introduced a dedicated scope for this with the special instruments, all that in mid 90s, 94, 95 introduced, purely because of the cost disadvantage.
Yeah, that is
it
a
came
cost
up.
where the cannula is put underneath and you can put it down. And this does, I tried that also,
Okay.
but the cost issue was
It's
the
very-
thing that
very high.
stopped me. And moreover, there is only a bit of space there. So there is, I felt that the cannula is also going tight there. The only, I didn't use the irrigation fluid or cannula also. I just used the 4 mm scope only. I'm not using anything more to increase the space there. Just putting the 4 mm scope and guiding it while I cut with the scissors. And scissors should be curved to the ulnar side. It's a curved scissors with the end, it is blunt. It is not sharp in the end. It is a specially designed scissors which is curved to the ulnar side and the end is blunt, so that it will not hurt anything like the deep palmar artery arch or anything. The end is blunt. It is specifically made for arthroscopic carpal tunnel release.
In the distal end, would you be able to see the carpal arch, arterial arch? Because
I
that is
haven't yet seen the arch, but once the flexor retinaculum ends there, you will see the muscle there. That is the end point of your cutting.
okay.
So the last flexor retinaculum, you go cut it, and at the end you will see the muscle, the thenar or hypothenar muscle belly you can see. At that point of time, you know that it is over, and you mark the Kaplan's cardinal line to know where it ends. Where it ends, and you can palpate your scissors tip at that line. So that is another point in which you can know whether it is complete. So you draw the Kaplan's cardinal line at the distal end, you know. When your scissors reaches there, you can just superficially, subcutaneously, you can palpate and you can confirm that it has reached there. You can visually confirm it by the arthroscope. You can, you don't damage anything because you are not opening the scissors too much. You are just opening it a millimeter and cutting the flexor retinaculum, and your edge of the scissors is specially made blunt, and it is curved to the ulnar side so that it doesn't go and hit the damage the median nerve, thenar branch. So all these are the precautions that we should take for this. No added instrumentation needed, just a sharp scissors which is specially designed for this.
Good.
I don't use anything else.
Thank you.
Judy, I think so, very nicely demonstrated procedure, and you should have even showed that scissor, what special scissor is there, no? So that would have really be useful for.
It's a normal scissors only, small normal scissor with the edges curved, edges blunt, and it is.
So your endoscope and scissor both are in the same. You need adequate space to.
Yeah, only that space is there. You can just retractor, a small Langenbach retractor can hook it up, and your hand should be stable on the OT table. So one will catch hold of the scope, other will have the scissors. Your elbow should be resting on the table, so there shouldn't be much movement at the elbow, because a small movement can cause problems.
So maybe you should be first doing few open, get used to the anatomy, and then I think so you should try.
There's only the median nerve which is seen. This is a difficult thing, and a branch of the median nerve that you should be careful that you don't cut too much. Shouldn't be a fast procedure initially. Might take 20-25 minutes initially, but now only 8 minutes. I calculated in the last 8 minutes is average
We have
time.
few hand surgeons. I just few inputs about this.
Hand surgeons might not agree.
No, why not agree? So actually, in hand surgery conference, this can trigger a battle. So there are people who do endoscopic, they are very passionate about it, as you are sounding. But people who don't do, they have so many reasons not to do. But one thing which was very striking is where you told that you never do open. So that is a bit problematic at times, because there are patients with carpal tunnel who have a lot of tenosynovitis. So this group of patients, endoscopic release is very risky. There are patients who are not able to do full flexion of finger. That is the typical sign of tenosynovitis or any abnormal lumbrical muscles in the carpal tunnel. So this type of patient, we must not do endoscopic release. Other than that, it is personal. So we can do a synovectomy which will immediately improve their range of flexion. Otherwise, they take months to improve in range of flexion.
So beneath the median nerve, synovectomy you are telling, open.
So any patient who is not able to make a full fist, what is called as the patient having a palm tip distance. So if palm is not, the tip is not touching the palm, that is a contraindication for doing an endoscopic release.
Fortunately, I didn't have such case maybe.
Yeah. So you see now you maybe you are evaluating your results.
Yeah.
Now on you see patients, I think every 20th patient what you see would be like this, because they have synovitis and they take very long time to recover if synovectomy is not done.
Okay.
In fact, that is the patient where we will go more proximal and have a full conventional carpentine release so that you can release the whole synovium and immediately their flexion would improve. That is the only place where this endoscopic will suffer. And lot of studies have been there. The good results, the difference in the results is only for first month. After that, they both are same.
Yeah, that could be true.
And also, if you are regularly doing 100 cases, that is very good because you have become an expert. But it is not a very good thing to venture for a person who is occasionally doing.
Yeah.
Because carpal tunnel, the median nerve has got so many variations. We recently sent a paper where there is a innervation, the branch coming from the ulnar side, which is very rare. No, so we need to be careful about that. But once you are expert, anything is fine.
Yeah, but in open also, all these variations can create problem because
No,
you are not seeing probably.
No, you see,
ulnar
no?
side.
When you open, you go right on top of the median nerve and you will be seeing all the branches. And when you are opening, one of the nice thing is, on the way, if you find the muscle, then the chances of having variation is 2 times more. So if you see a muscle, you start seeing more carefully about the variations, and that way you will not miss anything. Endoscopic is good, but we should never do when synovitis is there. The finger. That is the main point to know.
Sir, point well taken.
But when you have an acute synovitis with a gap, I tend to give a steroid injection, rest it for a couple of weeks, and then go whether it's open or endoscopic.
Yes,
because
Yeah,
most of the times, when you have an acute RA with a reactive inflammatory component, they do get better just with one simple injection. And then we can do a simple release, this thing. So yes, they're very, occasionally they have a severe structural tenosynovitis where you have to do a synovectomy.
Yes, sir. Acute, that is good, sir. But I was talking about chronic tenosynovitis, which is again a trigger for the patient developing a carpal tunnel syndrome. And it will be 1 in 20 only. So it is not, so maybe in your 150 cases, you would have had 5, 6 only. And
Maybe,
that may reveal in the result.
Yeah, but this type of cases, usually I also give some steroid and I don't operate on them maybe. I don't initially operate at least. When the movement is not fine, I don't operate.
Thank you.
I refer to a hand surgeon.
Give you my card then.
Sure.
The one question, not about the technique. What is your indication for surgery? When do you operate? Do you give a injection and rest it for a couple of weeks before you go for surgery?
Most of the patients who come are finished with the conservative trial by many people. So most of them will come asking for surgery only. Maybe the neurology people will have given pregabalin for years. The muscle would have wasted.
No, I'm talking about local steroid injections.
Local steroid injection.
Yeah.
That may be for synovitis case. As a patient has got a symptomatic synovitis which is causing problem, maybe a rheumatoid or anything like that, I'll go for a steroid injection and give a wrist splint or maybe night splint for 6 weeks. Then after that, if them come, that's all. I don't operate at this point of time.
Yeah, I mean,
not open, no arthroscopic, nothing. I do arthroscopic only, but I don't operate at this. If the hand is because I feel it's not a right time to operate. Maybe.
in my routine practice.
Yeah. That is point well taken. Yeah.
In my routine practice, I started giving injections and rested for with a wrist splint for 2 weeks. My incidence of surgery has come down drastically.
Exactly. Actually, those patients didn't come back again. That is another thing.
Half
I don't
of
know
them
whether they went to anywhere else, but they didn't come back to me. Maybe they would have recovered.
Impressed with your number of 100+ cases.
Yeah, from 2015, sir. It is this much years, over this much years only, this much cases.
Sure. discussion for other papers? Any questions? Perilunate dislocations?
So thank you so much. Thank you.
So we'll have the last talk.
He's here?
The session,
Yes, please. Vijit, please.
Good morning, everyone. I'm sorry for the delay due to the operating schedule. It's not showing up. Yeah, all right. So my task is to talk about carpal instability. But then when we talk about carpal instability, I think it's more pertinent to talk about scapholunate dissociation, which perhaps is the commonest clinical scenario and perhaps is the single most important representative aspect of carpal instability, dissociative, that we can talk about. So here's a case in point. This is a 42-year-old gentleman who presents with left wrist pain. He had a fall and then was splinted with some pain medication, and then again he presents with no relief and some kind of a snapping sensation along with reduced grip strength. Physical examination revealed that the grip strength was reduced by about 40% as compared to the opposite side, and the scaphoid shift test was positive, along with tenderness on the dorsal aspect of the scapholunate ligament. So at this time we were entertaining a differential of a scaphoid fracture along with a wrist sprain or scapholunate ligament injury. These were his radiographs. You can see the so-called diastasis at the scapholunate interval along with a DC deformity if you look at it very carefully. So what do you do at this stage? Would you want to splint and put him on medication or put him on therapy, investigate further, or wait and watch? These are against the CT scans. If you look at it very carefully, you can see the scaphoid is jumping off the dorsal lip of the radius here, which indicates that there is a significant instability pattern along with a so-called DC pattern and a diastasis that's quite evident on these CT cuts. MRIs, to my mind, are not very contributory, so we should always take it with a pinch of salt. And so this certainly was scapholunate, and then we'll understand through the talk as to how to deal with these problems. So scapholunate dissociation is basically one of the outcomes of what is called as a fall in an outstretched hand. This is the Mayfield circle that's been shown here, wherein when there is a loading of the wrist and dorsiflexion with ulnar deviation and intercarpal pronation, there is a sequence of injuries that can occur, and one of them is scapholunate dissociation. Usually the history is that of a fall in an outstretched hand, and there is also history of strenuous work causing exacerbation of the symptoms. Clinical examination of the wrist is something that we'll not belabor too much on, but there are certain provocative tests that we should be aware of, such as the ballotment test, the Watson scaphoid stress test, as well as the scaphoid lift test. The ballotment test or the scaphoid shift test is wherein you bring the wrist from radial to ulnar deviation while you're putting your thumb pressure on the tubercle of the scaphoid, and that relocates the scaphoid and causes a clunk that is painful, and that is kind of indicative of a scapholunate injury. The imaging for carpal instability or for scapholunate dissociation, should that be of confirming what you know clinically and not a discovery of sorts, you should always compare it to the opposite side and always get plain x-rays in at least 2 orthogonal planes, and be aware of false positives as well as the spectrum of normalcy. The imaging basically comprises of x-rays, stress views, MRIs, CT scans, sonography, as well as you can get cine radiography or some fluoroscopy images as well. What are the image characteristics that you would see on the x-ray? It will comprise of the so-called Terry-Thomas sign, which is an increase in the diastasis or the gap between the scapholunate articulation, which is greater than 2 millimeters. There is a foreshortened scaphoid indicating that there is a flexion of the scaphoid, which often results in the signet ring sign or the cortical ring sign. And on the lateral view, you would then see the DC deformity. The DC is basically an extension of the lunate along with the triquetrum. We'll understand that in a little bit. So to understand the DC and the VC patterns, which are kind of very confounding and very intimidating for a lot of us. I remember these terms used to scare us during our residency days, but it's really not all that difficult. So before we understand instability, I think it's very pertinent to understand what carpal stability is all about. And it is an interplay between the ligaments that impart stability to the wrist joint. We should know that the normal kinematics of the wrist joint comprise of flexion of the entire proximal row when the wrist is flexing. The same proximal carpal row will extend with the wrist in extension, and radial and ulnar deviation will cause flexion and extension respectively. Now the proximal carpal row is often referred to as the intercalated segment because there are no direct tendinous insertions onto it, and the movements of the proximal carpal row are forced upon it by the articular surfaces of the distal radius as well as the distal carpal row. And the scaphoid, which has a normal tendency to palmar flex, and the triquetrum, which has a normal tendency to extend, whenever there is a scapholunate ligament injury, the lunate remains attached to the triquetrum, which has a normal tendency to extend, will carry the lunate along with it into extension while the scaphoid remains flexed, and this is what we refer to as the DC deformity, and vice versa. The lunate, when it remains attached to the scaphoid, when the lunotriquetral ligament is damaged, will flex along with the scaphoid, giving rise to the so-called VC deformity. And then this is what happens. These are schematic diagrams. So when you are presented with a case of a scapholunate ligament injury, we tend to ask three questions of the patient. Where does it hurt? Can the symptoms be provoked by active or passive maneuvers, and do they experience any clicks or clunks? And then you ask three questions of yourself. Is the proximal carpal row intact? What is the position of the lunate? And is the abnormal position intermittent or constant? And then based on the answers to these questions, if you have the diagnosis that is clinched as scapholunate ligament injury, the next natural step is that of arthroscopy. We should treat this because there is a known predisposition for development of arthritic changes. Most of the procedures aim to repair the dorsal aspect of the scapholunate ligament because that is the strongest and the most robust part of the ligament. Treatment often depends on the classification and the surgeon preference and the needs and expectations of the patient. Mark Garcia Elias's table here is very, very useful and very practical in determining what should you do based on answers in yeses and nos to these 6 questions. Dynamic and static deformities. Can I just get 2 more minutes, sir, please? Yeah. So stages 1 to 3 are dynamic. What it means is that the scaphoid is still reducible, and therefore there is a potential for a reparative procedure that can be done. Whether you do it as an open or an arthroscopic procedure is immaterial, but this indicates that the scaphoid is reducible. Whereas stages 4, 5 are the static deformity, wherein more often than not you would be required to do a reconstructive procedure such as a ligament reconstruction using a tendon graft. Whereas stage 6 is where you will be required to do a salvage procedure because already arthritic changes have set in. There are a myriad options that are available for us in literature, right from arthroscopic to open, and then simple thermal shrinkage and pinning to complex reparative and reconstructive procedures. What we do in our practice for all dynamic instability patterns is something called as the ADCLR procedure, that is the arthroscopic dorsal ligament repair surgery. Very simplistically, this procedure comprises of the standard arthroscopic setup. We bring a scope in, of course, from the 3-4 portal first, then we switch the portals between the 6R and the 3-4 portal. We identify the ligament that's torn. You get your sutures in through each limb of the ligament that is attached to the scaphoid and the lunate. Then you switch to the ulnar midcarpal portal. You withdraw those limbs out, and then you just tie sutures and get the ligament and the capsule together. So it's like a capsular ligamentodesis kind of a procedure, and that kind of completes the repair and gives you a very robust repair of the scapholunate ligament. I won't belabor too much on this video, but the arthroscopic view kind of looks something like this. Can I'm sorry, I think I had bookmarks to this, yes. So let me just skip out and then show you how the arthroscopic view looks like. So this is one of the sutures coming in from the lunate remnant, that is the capitate for your reference out there. We're retrieving the sutures, as you can see in this particular video. You tie the knot, bring in that knot into the mid-carpal joint, and then as you tighten the knot on the dorsal aspect of the capsule, everything comes together and a robust repair is achieved. More often than not, you would find very robust outcomes in terms of range of movement as well as grip strength. In carefully selected patients, this can be a very rewarding kind of a procedure and is your bailout for most of these injuries. With that, I thank you for your attention. Any questions, I'll be happy to answer. Thank you.
Any questions from the other lectures also?
So regarding the DURJ instability, we are on which portion you immobilize the forearm, sir? Dr. Sunil.
Thank you. Thank you, sir.
It tends to be in a neutral, I mean, you are saying after surgery or like?
No, for conservative management, the initial
for
cases
conservative,
supination.
It would be supination if it is the right hand. For the left hand, I would prefer a neutral position.
For 6 weeks, 4 to 6 weeks.
Yes.
Sir, regarding scapholunate injury, for chronic presentation, will you use any tendon graft to reconstruct? Have you any experience?
Thank you for that question. So yes, for reconstruction, there are at least, I think, about 50 different procedures that have been described, and different tendon grafts have been described. Right from distally based tendon grafts from the volar aspects, such as the FCR tendon graft, you have dorsally based tendon grafts. So you can use any of these in different permutations and combinations. The essential idea, I think, is scaphoid has to be extended back again, and then the remainder of the tendon then will serve as a substitute for the scapholunate between the scaphoid and the lunate. So there is the modified Brunelli procedure, there is a 3LT procedure, there is the Blatt's tenodesis, there is several. Nowadays there is also something called as the internal brace, that is a commercially available system that is available. So any of these, it all depends upon your philosophy of treatment and what you're comfortable with, but most of them will work. However, long-term follow-up will consistently reveal that there is a reformation or the gap will again increase. As long as the scaphoid is maintained in extension and you're preventing flexion of the scaphoid, the patient will do well. However, if that is not possible, if the cartilage, so you have to fall back on the 6 questions of Mark Garcia Elias, and based on all answers to those questions, you should take a call on what needs to be done. Thank you.
If there are no more questions, we'll wind up session 5. Kindly request the chairpersons to present a memento to Dr. Terence and Dr. Jyoti Prashant. I kindly request Chidambaram sir to felicitate the chairpersons, Dr. B. Sivakumar, Dr. C. Sugavanam, and Dr. U.T. Vasan sir. We'll move on to the next session on untouched scenarios. I kindly request Professor M. Chidambaram sir, Dr. Ram sir, and Dr. Rajagopalan sir to chair the session.
Good morning, everybody. All the sessions are going late. I request the speakers to be on time. The first talk is over. Anil Bhatt sir has already finished it. So we will have only 4 lectures. At the outset, we thank the organizers, and I thank Dr. Rajagopal and Dr. Aram sir for having accepted to chair the session. Rajagopal sir, you know, Aram sir is presently the head of the Department of Plastic Surgery, Madurai Medical College. He is our senior consultant in plastic surgery. Shall we go to the... We'll start the session by Praveen. Over to Praveen sir.
Good morning, everyone. Greetings from Ganga Hospital. I thanks all the organizers from the Preethi Hospital to invite me for this good talk and allowing me to present our experience with brachial plexus injuries. So the title was quite interesting, Untouched Scenarios, and that comes the brachial plexus injuries. When I saw this, I was just wondering, brachial plexus anatomy is the first thing what we learn in our medical school. And anatomy, that is the first thing we learn, and somehow it very often becomes favorite question for all the students and also for the examiners, and we all are very much expert in this. Then how it becomes an untouched scenario, why over a period of time brachial plexus surgery does not interest so much? That is because of some myths which are related to the brachial plexus injuries. And as part of this talk, I think first most important is to just melee off these myths related to this. The first and the most commonly thought thing is that results of brachial plexus injuries are very poor. Nothing much can be done for that. But that's not true, because with modern advancement in microsurgery and the nerve transfer, the results are very dramatic. See this patient who was an orthopedic resident when he had a brachial plexus injury. He underwent nerve surgeries and he is now doing orthopedic surgeries and become functionally normal. This is a patient who is a professional cricketer, and this is at 1 year. He has recovered totally normal shoulder and elbow function, and he is back to his practicing nets, and he is very actively involved in competitive sports, and hopefully he may someday make into IPL as well. Another example, a patient who is gone into professional bodybuilding, lifting 130 kgs of weight, a person who can become a musician. So these all professions require so much of fineness in the hand function, which is possible after the nerve surgeries have been done for brachial plexus injuries. Not for everyone, but for partial plexus palsies, patient can be made totally normal, and even the total palsies can be helped. So the one message which I want to convey to everyone over here is that treatment of brachial plexus surgery is effective, and it is quite effective. It is not really a rare problem at all. So yearly 490 cases of brachial plexus are done at our hospital. So that means it is not really a rare problem, and just thinking that it is rare is the main reason for missing these injuries. They often get missed if patient has polytrauma. We will see the fractures, but we don't see the patient hand not moving. Any injury in the proximal part of the forearm could lead to missing of these injuries because patient may not moving the shoulder because of pain, and later on we see that the nerve itself is not working. And any surgery in this region, like a lymph node biopsy for example, is a common reason for injury which is happened, but it is being missed and being neglected, and we think that it is going to recover with time. How not to miss is, yes, we need to examine the patient very properly, and one easy way is to check for sensations. So movement may be restricted because of pain, because of fracture, but if sensation is abnormal, that means that there is some nerve injury. And this could be easily done by always doing a secondary survey in all the patients with polytrauma. Other thing what we believe is that most of these patients will improve with time. That again is quite wrong, because only the palsies which are associated with shoulder dislocation, proximal humerus fractures, which tend to be a low velocity injuries, may recover, but chances of recovery of a closed avulsion injuries is very, very less. Maybe 5 in 100 patients may recover, that too not completely. The last thing, we think that the treatment is very complex. Yes, it requires a good amount of understanding because the patients would be of varying type, but by knowing anatomy well, having a systematic approach, good examination skill, we can very easily treat these patients quite effectively. We need to keep in mind the anatomical variations when we are operating, and we need to be aware of that before we proceed to surgery. Now, coming to the treatment approach, how we proceed with treatment for these patients. Broadly, we can divide as a complete brachial plexus palsy, where all the roots are injured. As we see over here, C5 to T1, hand is totally paralyzed. Partial palsy, where only the shoulder is involved, the C5, shoulder and elbow, C5, C6, which is called as upper plexus palsy. And when the wrist also is involved, it is called extended upper plexus. And when only the hand is involved, it is called lower plexus. So that makes 5 group of injuries, and these 5 we need to have a specific way how to manage, and that will simplify our algorithm for treatment of these patients. Most decisions are made based on clinical examination. There is no need to do repeated MRIs, repeated nerve conduction studies, because they may further confuse. First, we need to take a decision based on our clinical examination, and that could be supported by investigation, not the other way around. Basically, on examination, what we are trying to find is whether the patient has an avulsion or a rupture. The basic difference between these two is, in an avulsion, the nerve has come out of the spinal cord itself. So that means the nerve is not available for repair, whereas in rupture, it is injured outside the foramen. That means the proximal part of the nerve is available for repair. All the examination should focus on finding this difference. In exams, if a brachial plexus case comes, which many times is coming for DNV students these days, the main question is whether it is an avulsion or a rupture. So 2 things which a student must be able to tell is, the Horner sign indicates avulsion of the lower roots, and winging of scapula, which happens because of serratus anterior palsy, indicates avulsion of the upper roots. So that way you cover all the 5 roots, and your answer to the examiner would be quite convincing to him. Then we just examine all the muscles from top to bottom, which is called as walk the plexus. And by walking the plexus, you will be exactly able to point out at what point beyond which the muscles are not working, and that is the site of brachial plexus injury. So there is no need to do too much investigations. Then when to investigate? Do we really require anything or nothing else is required? Yeah, we do investigate, and one of the things which is useful is an MRI. Especially when you are suspecting clinically that patient has got an avulsion. So MRI findings of a pseudomeningocele will further strengthen your clinical examination decision that there is an avulsion. The problem with avulsion is the nerve is not available for repair, so we need to search for other options. Important thing to remember is nerve conduction study, MRIs, both should be done after about 1 month of the injury, not immediately, because the pseudomeningoceles take some time to form. At immediate nerve conduction study, the nerve may still be conducting, it will not give any useful information at all. So it is wastage of money and effort if we do it on 1 week, 2 weeks, 3 weeks. So do any investigation only after 4 to 6 weeks. When do we operate? Yes, if it is an open injury, immediately. Otherwise, minimum 6 weeks waiting, because 6 weeks you give time for the spontaneous neuropraxias to recover. If they don't recover in 6 weeks, then we can proceed for surgery. At maximum upper plexus palsy, we can wait for 3 months. Only shoulder involvement, we can wait for 6 months even, because shoulder is very close to the brachial plexus. So there is a better chance of recovery. Also, the surgery can be done little bit. In global palsy, since all the nerves are injured, we must operate early. Important thing to remember is the golden period of brachial plexus injury ends at 6 months. This 6 months is very critical, because many times we get carried away by all the other injuries, like suppose patient had a head injury, chest injury, he had a femur fracture, femur got infected, we are going to operate that. In that, patient goes for 6 to 8 months, and then the brachial plexus surgery time is over. So it is not required to wait for that long. At 2 months, the brachial plexus surgery can go along with other treatment what this patient is going, because that is going to give a better result. If the patient presents late, still we can help them by doing tendon transfers and free functioning muscle transfer, but the nerve surgeries are the best. Nerve surgeries could be a repair, grafting, or a nerve transfer, depending on what is the type of injury and presentation since the injury. If the patient presents early, it is always good to explore the plexus and see if the original root can be repaired, because that will give the maximum number of axons and give a better result. However, in avulsions and the patients presenting late, we need to do the technique what is called as distal nerve transfers, where we take the normal functioning nerves and transfer them to get a good outcome, as we will see in the next slides. An example of open brachial plexus injury, a perfect case where the nerve is available proximally, we join it with a nerve graft, and it is going to give a perfect result, because it is an immediate surgery, the nerve is good, it is done well, and recovery will happen very soon. If the proximal root not available, we go for distal nerve transfer, which means that near to the target muscle, we see if any functioning nerve is there. We take a part of that nerve and transfer to that paralyzed muscle. Advantage is it is very close to the target muscle, so that means the target muscle is going to recover very quickly. One of the very famous example of the distal nerve transfer is the Oberlin transfer. This is a very amazing concept in which a small fascicle of the ulnar nerve is taken and is transferred to the biceps motor branch in the arm, which is only about an inch away from the biceps. Removing 10 to 15% of the ulnar nerve fascicle does not affect the function of ulnar nerve, but this fascicle does magic onto the biceps, and in 3 months itself you will start seeing that elbow flexion will recover. This our paper details how you do this surgery and how you select the fascicles. Some results: this patient with C5 palsy, he underwent nerve transfers for shoulder abduction, a spinal accessory to suprascapular, and long head of triceps to axillary to get a result like this. We see totally perfect shoulder abduction. It achieved within 1 year. This is the result at 2 years. So these nerve transfers give very nice result and patients are very happy. If patient has got shoulder and elbow, then the palsy is little bit more extensive, but there is no problem at all. We have a good nerve transfer for restoring elbow flexion and for shoulder abduction. We can do double transfer for elbow, double transfer for shoulder. We can do the transfer by anterior approach as well. And this is the kind of result we can get for this patient. Pre-op, patient having no shoulder and elbow function, and post-operatively, this patient is able to do a very perfect shoulder abduction, and we can hardly make out that this patient had any problem at all. So the results of the nerve transfers are quite good and quite assuring as well. Almost 90% of patients would get this type of result. When the palsy is more extensive, we need to use a combination of a nerve transfer and tendon transfer, but still we can get a reasonably good hand function. The problem is when all the roots are injured and all of them are avulsed. So that means nothing is available for repair proximally. So in these cases, we go in 3 stages. First, restoring elbow flexion, then the shoulder, and then the finger flexion by doing a muscle transfers. Finally, this is the type of result we are able to achieve. It is not good, it is not very magical, but it is much, much better than the patient whole life not having any function at all. And they are able to do some activities with this hand, like driving a bike, which in our population patients really require it a lot. More than anything, we are able to make most of them happy because they are able to drive bike, they are able to carry on with their passion. This patient always wanted to drive a heavy bike and he is able to do so after the surgeries. Patients are encouraged to use the movement what they have gained for any activities which they are able to do, like holding a bag, holding a bucket like this. Anything they use makes them much happy and our purpose is served. Lower plexus palsy is quite uncommon, but this can be corrected by doing a tendon transfers like this. This patient had a biceps to finger flexor transfer, and you can see he is doing little adjustment, but he is functional and he is happy. To summarize, brachial plexus injuries are challenging, but with good understanding of the anatomy, examination, systematic approach, we can help most of these patients. Investigations we should order very judiciously, minimum 4 to 6 weeks after the injury. Early nerve surgery is the best. They should be done within 6 months, preferably within first 3 months. Secondary surgeries also can be helpful, but we should treat all the patients early and let it not remain an untouched scenario. It greatly enables the patient to live a better life and they can go with their dreams and do whatever they wanted to do. Thank you very much.
Thank you, Praveen.
Yes, sir.
For your excellent talk on a topic which is a ocean of time is needed for this. You are consolidated within 15 minutes.
Thank you, sir.
One thing I wanted to ask is, how do you avoid shoulder subluxation if you wait for 6 months on upper brachial plexus palsy? So
Yes.
you are told that 6 months of you can wait.
Yes, sir. So 6 months waiting is not like a blanket, every person we wait for 6 months, sir. So there are some patients in lying down position, they will appear as if they are doing some shoulder abduction. But when sitting position, they are not able to do. So those patients have some initial recovery of the suprascapular nerve, but their deltoid is not recovered. So such patients, we could wait for 6 months, and for them, we put a shoulder strap. So if they put a strap, then the subluxation does not happen. But that is only for patients who show some partial recovery in first 2 months. So if it is looking totally paralyzed and hanging and having a subluxation, early surgery is the best, sir. Yes.
The next one is in a lower brachial plexus palsy, what do you do for the sensory recovery? You are
Yes, sir.
told for tendon transfers,
Yes,
but
sir.
for sensory.
Yes, sir. Fortunately, like all the 10 patients, I think we have operated, we recently wrote a paper on that. These patients told that the sensation is totally not there, sir. Because if we see in the hand, the thumb, index are C6, the middle finger 7, and only the little finger is T1. Ring finger C8. So only the ring and little will have little bit less sensation, which fortunately is not the main working part of the hand. So we have not done any nerve surgery for them because they felt that the sensation is quite okay.
For the intrinsic, you do any other procedures combined?
These all patients where we have done tendon transfer, we have offered to them that we are going to do a claw correction, but none of them have come till now. So probably they are able to manage their activities without that itself.
Thank you, Praveen.
Thank you, sir.
Is there any other question in the floor?
Before we move on to the next talk, I request Chidambaram sir to and Dr. Shomash.
go to the next. We'll go to the next talk. The next two presentations are by Dr. Abhijit Salanke, and the first is on pathological fractures in upper limb, how to approach. Over to you, Abhijit.
Yeah, thank you, sir. Good morning, sir. So, good morning. Thanks to the organizer, Dr. Sivakumar sir and Dr. Prahalad sir, for considering me to be a part of this Easting program. Good morning, respected teachers. So, my topic of presentation is approach to pathological fracture. That will be first presentation, followed by recent advances in orthopedic oncology. So, if a patient comes to us in our OPD, and this is a scenario where the patient is having fracture of the humerus, what should be done? So, if we read this X-ray or see this X-ray, there is lesion involving whole of the humerus with a pathological fracture. So that is one thing what we can see. We go to second case, again a kid with pathological fracture and classical fallen leaf sign. So two X-rays we have seen, and what should be done next for them. So the diagnosis is benign or malignant, it depends on your clinical approach and what is the treatment plan. So Vikram Vedha famous movie, who is the hero and who is the villain, we really don't know. So we go to a scenario where a patient was there. So 63 years gentleman with pathological fracture of the humerus. So this was the fracture. Whether it's benign or malignant, we need to assess it. So the orthopedic surgeon thought it is benign. He opened it, soft tissue mass was seen, and external fixator was applied. And patient presented with a wrist drop to us. So this was a clinical presentation, how the patient presented. And on presentation, this patient had lung mets, pulmonary metastasis. So it was a case of osteosarcoma, pathological fracture humerus, which was treated with an external fixator. So we get routinely cases where there is pathological fracture fixed with a nail or a plate, and the diagnosis is osteosarcoma or Ewing sarcoma. So that should be prevented because you need to have a proper approach to any X-ray and then treat the patient. So we go to clinical scenario, a patient with swelling over the wrist. This was the X-ray, and if we want to read an X-ray very properly, there should be a proper systematic method to read any X-ray in our physical clinical practice. So we developed our method, that is A to Z RAM. A is for age of the patient, B is for the bone, which part of the bone, C is for the content, D is for the distribution, E is for exterior of the bone, periosteal reaction, soft tissue mass, F is for the fracture, Z is for zone of transition. So any X-ray you can read in this easy pattern and you don't miss the things. So we thought that we'll publish this A to Z RAM. We published it in Radiography Journal and title is as A to Z RAM in 2021. So this is a subjective method for reading an X-ray. So if you read this X-ray, it's a skeletally mature lesion involving the radius, epiphysis, metaphysis, which is lytic, expansile, well-defined, narrow zone of transition, no periosteal reaction, no significant soft tissue. So most probably it's a benign bone tumor based on the radiology. So if we read any X-ray and see any patient, it's a pathological fracture, we need to assess whether it's a primary or metastatic. If it's primary, we need to investigate it very properly, get a MRI done, get a PET scan done, investigate the patient very properly, and then only do fixation. Pathological fracture is never an emergency. So that is the take-home message of this presentation. Pathological fracture is never an emergency. You need to evaluate the patient very systematically with all these steps. So we can see that the tumors common in pediatric age group are which tumors, middle age group are which tumors, and elderly which common. So more than 60, it's more commonly a metastatic bone tumor. Still we see primary bone tumors in more than 60 age groups. So important on radiology is we need to know the borders and zone of transitions. So this is important how we draw India's borders with a pen and pencil. Here there is a border between India and Sri Lanka on the sea. Here India and Pakistan on sea. Here there is a land border between India and Nepal. So the land border is very well defined. The sea borders are very ill defined. So border between India and Pakistan, Wagha and Atari. This is benign, malignant, very well defined borders. India, Pakistan or India, Sri Lanka border, very ill defined. So this can be malignant and this can be benign most probably based on our findings. So well defined tumor, it's sharply outlined, sclerotic borders. Majority of the tumors are benign. If it's ill defined, most probably it's a metastatic or a malignant bone tumor. So easy to understand, easy to remember. We go to two scenarios. A benign bone tumor you can draw with a pen or pencil. It's a very sharply outlined border. So it's a well defined tumor. We go to a case where it's ill defined. It's a most probably a malignant bone tumor. Then next is the content, whether it is osteoblastic or which type of content, that is very important. So we summarize all the things, A to Z RAM. A is for age of the patient, B is for the bone, C is content, D is distribution, E is exterior, F is fracture, Z is for zone of transition. So after this we devised a subjective method. This was a subjective, we devised an objective method. We use a scoring system. If the score is less than 3, it's benign tumor. Score more than 3, it's a malignant tumor. So lastly, biopsy is very important thing. So we have got our own patent for a biopsy device. So it's a bone marrow and bone marrow biopsy device which has multiple sensors, and this is the device for which we had got patent in March, and this is how it functions. So it's a biopsy device. This is the tumor, and you can preset the distance at few millimeters or few centimeters, and it stops automatically at opposite cortex. So now we are using Jamshedi needle. This can be an advanced needle which can be useful for a biopsy purpose. So this is the device prototype which we have made, and we are making a smaller prototype and final product of this device. So lastly, the patient should be very strong, and limb without limbs, upper limb or lower limb, still the person can function. So next part of the talk is something new, that is use of 3D printing and augmented reality and virtual reality. So use of 3D printing. So we can print any bone, any muscle. So here we have printed talus. So this is the institute where I work. It's a government cancer hospital and one of the biggest cancer hospitals across the globe. So in past we had amputation, multiple treatment options. So what is 3D printing? So like the insect makes a cocoon around himself. So you can put a plastic powder or a metal powder into a 3D printer, and it will print the object what you want to devise or use. So this is a simple thing that how a 3D printer works. This is simple example of a 3D printer machine, how it works. So we'll go by few examples. So use of a 3D printed model for orthopedic oncology case where there is a defect involving the shaft of the femur. You want to cut the bone from here, upper part, here from lower part. So you can use a jig. So this is a customized jig to cut the bone precisely and perfectly. Otherwise you have to use navigation system which is available at very wellness centers across the globe. So you can explain the patients and relative what steps you want to perform before surgery. Use this jig, apply on the bone model, practice all the steps before doing surgery, and intraoperatively it will be very easy to cut the bone perfectly. So the distal part of the bone is cut here. So next is use of 3D printed scapula, what we are using regularly, 3D printed plate and 3D printed model. So this is how you print the bone model for any pelvis case, any pelvis fracture. This can be again a easy method. Complex pelvis fracture, you can put all the parts, plates, assemble, and preoperatively you can contour it on the patients. So we have made a 3D printed model. So this is the tumor. So this is a 3D printed model again. You want to cut the bone from here and here, remove this whole bone. So this is type 2+3 hemipelvectomy. So here the bone model is there, artery, vein, nerves, and this is the acetabulum what we resected for this patient. So you can check what parts you have removed before surgery. Intraoperatively it can be again precise and perfect. So this is the tumor which was removed, and these are the artery, veins and nerves. So we use this to take cuts into the pelvic surgery, hemipelvectomy surgery. So one use is use of a model. Next we go to jigs, and then next we have printed final bone implants. This is the femoral head. We'll later on attach this femoral head to the shaft, other parts with a mesh. Or you can print a 3D printed implant for these cases. So next is use of a 3D printed plate. After model we can print a plate. So these are the bone models which are printed, and this is the customized plate which what we have printed. It's a titanium plate. We can fit it precisely and perfectly without contouring. So that is advantage of this technology. No contouring is required. So we can appreciate here the plate is very perfectly sitting here. It has few holes, so you can customize the holes so that less chances of breakage of this plate. It sits perfectly and precisely. So these are the holes which are made according to your designs that can be made for the patient. We apply a derotation plate anteriorly. So this is the bone which was treated with liquid nitrogen. Put it back again. Slide the plate. Just no contouring required. Very easy. Otherwise you have to do lots of jugglery in the OT. So just slide the plate inside. Fix the screws. So you can use a 3D printed customized plate. This was intraoperative function. So next is 3D printed scapula, what we are using nowadays for last few years. So you can print the scapula, you can print the humerus. So case of Ewing sarcoma of scapula, where the scapula was removed and we had placed a 3D printed scapula for this patient. So this is the incision, remove the biopsy scar. This is the preoperative planning, how you make it. So again you can explain the patient and relatives what things you are planning. This is the printed model, and this is scapula what we are resecting here. So this is the tumor, and we can appreciate this is 20% smaller as compared to this. So you have to make your own planning very properly, that the final scapula is 20% smaller as compared to this scapula. Then only there can be a good closure. So put the scapula again here, fix with the humeral head with the help of a mesh. The patient gets at least 30 to 40 degree abduction movement with this technique. Without any scapula, there will be zero abduction for these patients. So make hole into the clavicle, fix with acromioclavicular joint here, and it's quite stable. Fix it the chest wall here, with fiber wires and fiber tapes. Next we see 3D printed talus. So tumor involving the talus, we have removed the talus here. We have printed the talus, and this is intraoperatively, it sits beautifully. There is no muscle attachment over the talus, so it sits perfectly and precisely. So we have developed multiple designs of talus also, where tibial surface was resected and the calcaneum surface was resected. And these patients have excellent function. This was the follow-up of the patient. Lastly, in routine orthopedic practice, this can be used. So it was a case of pediatric orthopedics done by our friend Dr. Kamlesh Dev Murari. So you want to plan the cuts here. So make the model of the femur. Previously DHS was placed here. So the surgeon wanted to remove the DHS. Take a one cut here, second cut here, third cut here. So again all the steps are performed pre-operatively. Make a jig for the surgeon so that he can cut one part, second part and third part. So osteotomies can be performed. This is the jig what was made for the surgeon. This is how the jig was placed. So intraoperatively the surgical time was very much reduced. So one cut, second cut, and he placed the DHS very perfectly and precisely. So you can take all these steps to make your surgery precise and perfect. So this was the final outcome, how he had done it. So, and lastly, we'll like to show what is virtual reality. So this is how virtual reality works. So there is Oculus specs is there, what we can use. So it can be easy training module for your surgeons and residents. So these are the specs what we use. So it is by Oculus Meta. So you can wear it and there is remote. So you can control all the steps here. How. So intraoperatively this is, we are doing hemipelvectomy surgery for the patient. So these are our two hands. With the help of joysticks and remote, we control all the steps. So that pre-operatively you can show to your residents and it can be a good training module. So virtually you are doing all the surgical steps with the help of the specs and the remote controls. So remove the tumor. Take the saw to take all the cuts and remove the jig, do reaming, put the final implant which is a 3D printed implant again, and your all steps are performed. And lastly a video of virtual reality surgery for biopsy. So this is virtual reality biopsy surgery. So how we perform it? So there are 8 to 9 steps of a bone biopsy.
Step 2, administration of local anesthesia. Step 3, incision with surgical blade. Step 4, insert biopsy needle into the affected area. Step 5, attach the syringe and aspirate the bone biopsy tissue. Step 6, place the put bone biopsy tissue in a kidney tray and use a strainer filter out the blood. Step 7, place the biopsy specimen into sample collecting container with formalin which will be sent to the pathology assessment. Step 8, place suture at biopsy area. Step 9, dressing material is applied over affected area.
So these can be something recent advances. After virtual reality, we are trying to use our own softwares on augmented reality. So if next time in this conference we can have a workshop on 3D printing so that we can have all the steps how 3D printing is performed. In-house you can see it, and a virtual reality workshop we can have. So thank you very much, sir.
There's another paper on 3D. We can have the questions in the last.
Yes, thank you, sir.
I request Vikas Jain, please come. Technology and joint challenges.
Good afternoon to all of you. Thank you, Abhijit, for making my task much simpler. We'll be taking this talk further ahead to what Dr. Abhijit was talking. And he emphasized the use of this technology predominantly focused to onco-orthopedics, while we'll focus the use of this technology in trauma, in arthroplasty and pediatric orthopedics. Thank you, Preethi Hospitals, for having invited me here for this particular talk and introducing this technology, something which is orthopedics redefined and something new which will enable you to start scratching your head as to what you can do now. It's very sure that most of you as an orthopedic surgeons are used to do orthopedic surgery in a fixed protocol manner, while now we want you to start thinking out of the box. And this is how you can do it. I'll shortly introduce you to what 3D technology is. So 3D printing is a small part of 3D technology. Do I have a changer here or it's just a laser? How do I change? Okay, thank you. So this particular conference is on the theme of upper limb injuries and reconstruction. However, I'll be introducing you to few examples, not only of the upper limb, but also of the lower limb. We as an orthopedic surgeons should be optimizing the anatomy, physiology, and the biochemistry of any pathological state the patient comes to us in. And we should give them solutions which will add quality to the patient's life, and thus will add quality years to your patient's life. That is what should be the aim and the motive of every orthopedic surgeon. Also, most of the times you must have seen, because of the off-the-shelf implants that are available to you, at times you are giving them a compromised management, because you don't have something which you think, if I had this implant, I could have done this surgery better. However, now that imagination can come into reality because of this technology. I'll just introduce you to what this technology is. Dr. Abhijit made my task much simpler by introducing what 3D is. Friends, have you ever seen how an implant is manufactured? Any one of you can tell me how an implant is made. How is the screw made? How is the nail made? How is the plate made? If anyone can speak, well and fine in the talk, because we can have this a little more interactive. Prahalad, I can ask you also. Yeah. Have you seen any orthopedic implants being made? Production? So have you ever thought of it? Any one of you? So when you get implants coming to you, and there are so many implant guys here, how is that implant made? So till now, most of these implants are made by CNC technology, it's known as subtractive technology. So you have a metal or a rod or a plate, and you have a computer-aided design for that particular plate or a rod, and then it's the machine that cuts out the metal, and it gives that particular shape or a hole that is required. Exactly opposite to that is additive layering, what we call as three-dimensional printing. So here there is a powder. Dr. Abhijit showed you a video of a cocoon, right? So what happens is, any powder, it could be a powder or a liquid, which is into a 3D printer, and the computer-aided design that is given, it will lay down layer by layer, either from top to bottom or from bottom to up. And that is how anything that you imagine can be taken on a computer thing, and then it can be printed. And that particular technology now has become a boon to orthopedics. How are we going to apply that in our orthopedic surgeries? What are the surgical challenges? And what anatomical solutions are we going to give is what we'll see. So this is a metal printer that I was talking to you about. It's about a size of an MRI machine. This is a metal printer, and in which we put in titanium powder, which is imported, which is biomedical grade, and that titanium powder can be then added in a layering structure by heating it through laser technology, or you can use an electron beam, and you can create any shape that you want. So the advantage of using this technology predominantly is customization. When you go to a tailor, you get a shirt which is made to you as per your size. And in this case, you have a patient and you can think of giving him an implant or a plate, as Dr. Abhijit was saying in one of his onco cases, where he could contour and get a plate made of the size, length, the number of holes, as well as the contour of the plate, which was exactly fitting over the tumor. So such similar examples can be there in trauma. There could be used in plasty, and there could be used in pediatric orthopedics when you do a deformity correction. What is 3D? What do we understand by that? It's nothing but it's an information. Most of you not only do x-rays, but all of you also do CT scan for most of your patients, right? Now what do you achieve out of that? You get an information which comes to you in 3-dimensional, and that gives you an imaginative judgment as to what is the disorder or a disease of that patient, and how are you going to approach. Imagine taking that information onto a software, and that software now will start enable you to do virtual surgeries. So you are going a step ahead. You take that CT's DICOM information, put them into a software, and you start to play with that software. And that software will now enable you to do that particular surgery of that particular patient beforehand actually doing a surgery on the patient. So that's preoperative plan. You can design an implant. I'll show you few implants which are designed by me. And the most important thing is integration. Most of you find challenges if you're an arthroplasty surgeon thinking in terms of how do we integrate a metal to a bone. Aseptic loosening is a big issue. So you really are aiming at having an integration that should happen of a femoral stem when you're doing a THR. So integration is very important, and that problem also is solved using this technology. So the surgical challenges, one is really expressed by Dr. Abhijit when he was showing us all the examples of onco-orthopedics. Second is pediatric orthopedics as well as adult orthopedics where we have deformities. So when you have deformities, you need deformity correction, and none of this deformity is in a single plane. These deformities are in the X, Y, and Z axis. Most of the times we usually tend to do the correction only in one plane. We do not do the correction in all three planes. So hence, we need to use 3D information to do the correction in all three planes. Complex fractures and aseptic loosening. Preoperative plan I told you. So this is something about osseointegration. These are the ways in which the metal can be osseointegrated to that of the bone. Whenever you do a CT scan, it's the DICOM or a CAD file that comes to you. You need to import that into a software. We have a language which is known as STL. Then we do something which is known as segmentation, and on segmentation we can do design, planning, we can prototype, and finally we can print an implant. These are the steps that is done. Let me show you some examples. So what you see here is something in an upper limb trauma, where you can see at the global level there are people who have printed scaphoid. There's a first metacarpal that's printed. There's a lunate. There's a radioulnar defect, again printed with a trabecular pattern. There is a distal radioulnar joint. Again, it is from Actis, but this is what you can make again through a 3D printing solution. You can see a humerus, a complete humerus, with the distal end of the humerus, which has a trochlea and a capitulum, which is exactly the same as that of a patient. So you can do a hemi. Another example. This is a live case. It's a lunate replacement, which is already done in India. Scaphoid replacement is coming. CMC joint replacement is coming. What you can also see is a metacarpophalangeal joint. This is joint in prototype, will be shortly coming to the market. Arthroplasty, upper limb. You can see that there is an upper limb humerus. You have a trabecular base, and you can give, I was seeing one Arthrex solution very similar to this. Radial head. What the radial head that usually you put is not a patient specific radial head, and that results into capitular chondrolysis. While if you do a patient specific radial head, usually you will be avoiding that cartilage damage at the capitular level. A humerus, distal end of humerus, you receive a lot of trauma patients with distal end of humerus, and you end up having a fixed elbow. There is no need to wait. We can give them a solution as far as distal humerus is concerned. Distal end radius, you can give a solution to distal end radius too. Small joints of the hand, you can print IP joints, you can print metacarpophalangeal joints, you can do first CMC joint, you can do a wrist arthroplasty. Using this technology, creating a joint which is patient specific. Think about defects. Whenever there's a defect in the acetabulum and revision surgeries, whenever there's defect using a tibial plate, again revision knee, you have been using augments, you have been using cages, but now you can think in terms of making one single component which is patient specific and it is defect specific. Not only that, you can create a trabecular there, you can create an osteointegration there. Look at this case. A bad, very bad revision, 4th stage revision. The surgeon didn't know what to do. We had to do a segmentation. We had to create a component, acetabular component, and that acetabular component helped to give an anatomical outcome to the patient. Deformity correction. As I have given you an example, this is Dr. Taral Nagda's few cases in pediatric orthopedics where he is using the jig. He is operating upon the bone model. He is doing an osteotomy beforehand and then he actually performs it over this. This is a case, again, one of our friend Kamlesh, also exhibited by Dr. Abhijit just now, where he has performed a Morse's osteotomy, again doing a preoperative planning, making a jig out of 3D planning and then doing the surgery. To reduce the surgical time from 3 hours to 45 minutes, while the anatomical correction and precision was as good as 100%. Now this is interesting. This is something which we made for a patient for a GCT in lower end of tibia, young female. It's a tibial plafond. This is how it looks, a 3D printed tibial plafond. This is another case, young female who had a sonk lesion in the posterior one half of the lateral condyle with an FFD, limp and inability to walk. We created an isolated posterior one half of the lateral femoral condyle. Let me see if I have few videos to play. How will I play this video? Can someone help me? Can you click one of them? Yes. So this is for that same patient. Can you click the other one where we can see the, yeah. So this is 4 months of follow-up at this patient where we have given the tibial plafond operated by Dr. Mani in Delhi. You can see it is metal on cartilage and you can see the congruency. Can you play this video? This is of the same patient where the posterior one half of the lateral condyle was replaced. It is a patient-specific implant. See the congruency of the tibial condyle over the femoral condyle. See the entire range of movement. The patient is 1 month. Patient is painless with full range of movement. Can you play this, the other one? See the movement in the under the tibial plafond. You can see the, give me 1 minute, yeah. Again, few things that can be done by 3D technologies, giving patient orthotics, and now we can make a bionic hand out of giving patient specific solutions. This is something going ahead of what is shown by Dr. Abhijit. Now you can use the virtual programming of a surgery and then you can use HoloLenses, and that is known as mixed reality. So the virtual planning, when it is overlapped using HoloLenses over a patient, you can actually perform acetabular placement, you can do a TKR and you can do a THR. I want you to play this video just for 2 minutes. 1 minute, yeah, fast. Can you play, put in the volume? Yeah, give me, this is the last slide. So what you see here is a hip whiz by Arthro 3D, a very good friend, Dr. Manish Shah from Ahmedabad. He's working on it. He has done large number of knee series using HoloLenses. This example is that of a hip where a preoperative plan is done using the software, and here you can exactly plan out the acetabular inclination, the anteversion, the size of the acetabulum. When you're planning an uncemented one, you will know how much is the surface area that is going to be there. If you also can work out as to which is going to be the best size and the best fit of the acetabular cup. So friends, thank you. This was just a preface to what is coming in the 3D technology. Whatever you imagine, wherever you stop thinking, and wherever you have a situation where your off-the-shelf implants are not enabling you please let me know. Maybe we would be able to offer you some solution which will optimize the outcome of a patient. Thank you so much.
Thank you, Dr. Vikas. That was a very excellent presentation of things to come in the future. And we're happy that same thing have been covered by Abhijit also, and which shows that there are more ways of managing the problems which were difficult in the past. Any questions for all the three talks? We combine it together. Vamsi?
Because I think a good talk. I think use a CT scan with the images, right?
Yeah.
So when the defects are very closer to the cartilage, which the CT doesn't pick up. So when doing some 3D printing closer to the cartilage or the joint, it becomes a difficult. So how do you overcome that with the current?
So it is the surgeon who has to tell us what is the solution that they are looking at, right? One, the CT scan images that are coming to us on our software is where we'll plan out a solution for you. So if you're looking for an implant solution, we have our own way of designing an implant. So there is design consideration, so if you're asking about the intra-articular solution, right? So this lateral condyle was one such case, where it was just the posterior one half of the lateral condyle. It was the entire cartilage, the subchondral bone, which was eroded. We didn't even think in terms of giving any form of cartilage replacement, and then we had to think about this. So CT scan gave us a pretty precise information. Whatever bone we printed out of CT scan, that bone also gave us that exact replica. So I'll show you a few images from where you can make out, because the time was short here, where you can make out how that CT scan is giving an information, 1 mm slicing. You can go up to 0.5 mm and you can get a precise information on the software, and you can do a perfect planning. It up to 0.5 mm. That precision you can achieve. If you are wanting a soft tissue, yeah. If you want a soft tissue. So then you want an MRI. But cartilage you can do even in CT scan. You would be able to get an idea. Yes.
So in that ankle case, you have put a fibula inside for fixation. The angle
it's only the plafond, and it's part of the tibial plafond. That's it.
Okay, but inside that the fibula was also
yes,
there.
There was a fibula that is for osteointegration. Yes.
Integration. So is there any choice that we can use demineralized bone, for example in THR, revision THR, in which there is bone loss? We usually go for a cadaver called Ramaya, and you get a demineralized bone.
So that was the surgeon's choice. You know, the technology that came into play was trabeculae. So we gave trabeculae of the metal inside, and we wanted that to have a bone inside, so that the bone and the metal trabeculae integrates, because we wanted that component. We also did one surface.
You tell
with
that
an
there is no
coating.
loosening possibility there.
Nothing. It will osteointegrate there.
Osteointegrate.
It will osteointegrate. And that's the technology there.
Because very is coming up, and now the commonly done surgeries nowadays is the knee replacements, and of course the replacements again the same thing, that we don't get a patient specific implant.
Yes.
Have you tried on this on any replacement?
Yes,
and what is the longest follow-up you have?
No, so Knee 3Viz, Arthro 3D, Dr. Manish, we don't have a time, otherwise he has a complete software. Now that software is patient specific input of an information, then giving you a patient specific cuts, patient specific modular jigs, and that jigs you can use intraoperatively using HoloLenses. So this is something which probably if there is going to be the next time, we'll invite Dr. Manish, who can elaborately explain about how HoloLenses and how patient specific jigs can be given, making that same jig which is modular. So he uses K-wires, he uses that jig in the manner. Replacements. So, are you asking follow-up of replacements?
Yes. Have you done any replacements using this technology? The implant, the patient-specific implant.
So, patient-specific implant, these were the 3 cases which I have shown you, which has just started, recent. They are recent.
Yeah, that is for the tumor prosthesis. What
Tumor prosthesis is one is tibial plafond, one is the femoral condyle.
Condyles?
Yeah.
But you are not replaced on both the sides. It's on the
We are
cartilage.
doing that for Narayana Health. There's a very, I think it was discussed in one of the IKHS meeting. I think probably in the next meeting I'll be able to show you one
According to
TKR.
you, there is no chance of any loosening. But in normal TKR, always you use a cemented thing. So cemented there is loosening because uncemented TKR. So many uncemented TKR, which was earlier, it was showed failure. So then why can't we use this technology for to make it uncemented?
It is coming. See,
TKR?
Germans are coming
Then
up with.
If it is going to last forever, then why can't we use this technology for an uncemented
Exactly,
TKR?
exactly. So this is coming. You are going to have an uncemented, uncemented TKRs and uncemented THRs, you shortly wait. You already have an acetabulum, femoral component, we are working on a research. We'll have a trabecular or a lattice femoral stem, which is going to be lighter and which is going to give you 100%. So first is the interference fit followed by a biological fit. This biological fit is 100% going to come. And it is going to come. You just wait.
Sir, can
I think he's standing for long.
No.
Prahalad is the organizer. He can ask. He can take me to task in the last.
A question for Dr. Abhijit.
Abhijit.
How do you assess the tumor-free margin? Do you include it into the planning? First thing, it's a tumor-free margin for bones and tumor-free margin for soft tissue as well, because most of the cases are malignant cases. How do you assess that? And second question, you do irradiate and put the same bone by either irradiation or nitrous oxide and all those things. Do you consider, do that bone shrink, or is there any size changes into the bone, and do you consider into that after irradiation?
So for a soft tissue and bone planning, you get MRI done, and soft tissue margins are based on the biological barriers. So muscle, fascia, and joint cartilage are barriers. So 1 centimeter, 2, 3, it is classified. I can't include that. Bone you take 2 to 3 centimeters, and the bone shrinks. No, the bone doesn't shrink. It is same size. Liquid nitrogen may have some effect. There is another technique, you can autoclave the bone, pasteurization. So that gives chondrolysis or osteolysis. So that we are not doing. ECRT just, it radiates, it's 50 grays, very high dose. Normally radiation dose is 2-3 grays. Here it's 50 grays, it makes the bone dead. It's totally dead bone, like a scaffold. And it takes around 9 to 12 months to unite with the host bone. So for diaphyseal part, it's around 12 months, and metaphyseal diaphyseal 9 months. Liquid nitrogen may have some effect, but the bone has not shrunk. In future, this bone may get reabsorbed. Yes, that has happened with us. So whole humerus we are radiated, it has gone away. Whole talus. So that's why we came with the idea of 3D printing. So we were previously using only mesh to attach humerus with clavicle. Then we next went with radiated bone. Then next we tried to make the radiated bone vascular by putting vascularized fibula. So the next thing was 3D printing.
Thank you.
Thanks.
One last question. Last question.
Yeah, last question. This is I would like to thank Dr. Vikas. We had a very brief meeting in Delhi during EC meeting, and the way he was just showing his work, I got impressed because we had lot of trauma cases where we could not do reconstruction, where we ended up doing fusion of a knee or doing some half-hearted job. So this is like when there are so many questions about osseointegration and all. So this is the future. So we are all definitely, this is just thought-provoking, and we have to wait and see.
Because as you told, HoloLens technology has been used in Australia. I've been last month there, HoloLens for reverse shoulder to find out the central point of the glenoid. The HoloLens technology has been correctly used for the reverse.
We have that software now in India, all make in India, and everything going by Atmanirbhar Bharat. And Dr. Abhijit and myself, we are trying hard to give a lot of solutions to the orthopedic surgeons across India, keeping Atmanirbhar Bharat at the core.
We have reached the moon, then this is also not impossible.
Yes, this is not impossible.
So even when we are doing reverse shoulder, so we are just depending on the osseointegration on the glenoid. We are putting screws and all. So
Just to assess the central point of the glenoid, you can correlate the CT and intraoperative HoloLens they are using to get the central point.
So just this is thought-provoking.
Thank you so much, Dr. Prahalad.
Yeah.
Thank you. It was really nice coming all the way to Madurai. I'll ask you one question as to why you didn't ask me about metal on cartilage. You saw 2 examples of a lower limb where there were metal on cartilage, and why is it not that you are asking me a question on how did you design an implant with metal on cartilage.
We are waiting for your long-term results.
Okay, sir. So let me tell you, there has been studies on biomechanics and why metal on cartilage will work. So when you create and using this technology an absolute congruent articular surface to that of a cartilage, right? So till now, whatever metal we use is usually not congruent. Now we are creating an absolute congruent articular surface, which is exactly the positive and negative of that of the cartilage. There are two terminologies. One is coefficient of friction. So when you have coefficient of friction between metal on cartilage, which is less than 0.001, and second is when you have surface loading and there is no point loading in a metal over cartilage, it is only the superficial surface of the cartilage, which is the lamination, which goes away, and the surface loading enables in fact laying down of the matrix in the second layer. So there is no cartilage breakdown. So if there is a broken cartilage on cartilage itself is damaging. That we know in articular fractures, right? While when you do a metal on cartilage, you have to give a perfect congruent surface to that of the opposite knee, and that is going to prevent any form of cartilage damage on the cartilage side. So this is something which now is going to change the way orthopedics is going to be. People have asked me, why not liners? I said that there's no need for a liner. You can directly have a metal on one side and you can have a cartilage on the other side. Non-weight bearing upper limb, beautiful option. Weight bearing lower limb, yes, there is a chance maybe 10-15 years down the line you might require some more things to add, but still you can give a beautiful anatomical solution. Thank you so much, sir. Thank you all.
Thank you all, and we had a very interesting session. 3D printing has been in many other industry before and now come to medicine. I am sure we'll hear a lot about it. Thank you all.
Thank you, organizers. With 3D printing, the artificial intelligence, AI coming up, I think it will take us a long way. Thank you for all.
Thank you, sir. We
excellent lectures.
request chairperson to honor our speakers, Dr. Praveen Bharadwaj, Dr. Abhijit, Dr. Vikas Jain, specific 3D printed specs. 3D printed specs. We also request Rajagopalan sir to. We also request Rajagopalan sir to felicitate our postdoctoral fellow, Ian Buraj, who we have listed today. Rajagopalan sir to felicitate Aram sir. Chidambaram sir to felicitate Rajagopalan sir. the very interesting 3D technology and recent. Now we are moving to the next interesting topic, pediatric orthopedic. So we request Chairperson Professor Gulam Mohiuddin sir, Professor N. Manikandan sir, Dr. Gopi Manohar and Dr. Ajay to chair the session.
So good noon. Kids World is wonderful really. My little house became so wonderful only after my grandchildren started scribbling the walls. Now, the Kids World here is very difficult for us when they come with x-rays. So let me invite the first speaker, Dr. Vidyasagar. He will tell us the right way to read the right as well as left x-rays. Over to you, please.
Thank you very much, sir. Again, I would like to thank Dr. Prahalad and Sivakumar sir for the invite, and I hope I can learn and teach something. So I'll be talking about a way to read a pediatric elbow x-rays and getting the basics right. Yeah. So why it's important to learn, because most of the times in an injured elbow, it's a swollen elbow, anatomical landmarks are changed, and then you won't get compliance to examine because of the pain and tenderness, and mostly the elbow is cartilaginous, so difficult to read such an x-ray. And when in a trauma setting, the views which we take is just haphazard. Whatever is comfortable for the child, we take it, so it may be inadequate also. So before I talk about radiology, again I'll stress that you should have a good physical examination and come to a clinical diagnosis and then proceed for the necessary x-rays. So we all know about the ossification centers. The capitulum appears first, and then the radial head, and then the medial epicondyle, the trochlea, olecranon, and lastly the lateral epicondyle. So that's the sequence which is always almost followed. So we must match that age with this ossification sequence. Always take both the views so that we don't misinterpret what's happening. So minimum 2 orthogonal views is a must. That's a orthopedic rule. And then how to position the x-rays for a true AP view. So that's the, for an elbow, full extension of elbow with full supination of the forearm is the position which we want. But in a trauma scenario where there is swelling, the child may not be able to extend. So if you are looking at the distal humerus, the last image is the one which we will be taking. That is humerus parallel to the, or flat to the slide there down. And that's the way to take true AP. And about the lateral view, the true lateral view would consist of a view where the shoulder, wrist and elbow are at almost at the same level. The elbow is at 90-degree flexion and forearm fully supinated. So that's there in the last position. And with that cotton felt, I have made all the elbow, shoulder and wrist at the same level. When we want special views like internal oblique views, we need to pronate the forearm and internal rotate about 20 degrees when we are looking at a lateral condyle fracture. Same will apply for the medial side also, external rotation. And sometimes just a part of x-ray, like elbow x-ray won't be enough. You want full length of the forearm. What is obvious here is a radiocapitular dissociation, but if we take the elbow x-ray, probably we might miss on what's happening to the ulna. So always look for full length so that we check the ulnar bow as well. And very special situation, we may need another view which is called as a radiocapitular view. And this is an example of that. If you see the radial head of this child, it's slightly posterior sublux. So how do we know whether it's an eccentric ossification or what's happening? So in an X-ray we took, and we took an MRI, and then we noted that there was a radial head fracture. Because of that, it has posterior sublux. Premal sir will talk about these lesions, trash lesions further. So that view may throw a more better light on such things. So stress views are generally not done in a OPD setting, but like morning we did a lateral condyle. So you can stress and look for instability when in theater and the child is sedated. So this is a medial epicondyle fracture. Again, we were evaluating other injury, but we took the chance and did the stressing, and we can see it's mobile, but the treatment still remains same probably in this case. And this is an example of taking the normal X-ray, the same case which I showed, the radiocapitular line cutting behind, and this is cutting in the the normal elbow is cutting directly in the center. So initially we look for soft tissue shadows, where is the swelling, medial side, lateral side, anterior, posterior, and we look for something we call as a fat pad sign or sail sign. So you can see the shadows in the lateral view. So that's the sail sign, both anterior and posterior are there. And we have to look for bony alignment. Is there a good cortical continuity? Is the bone angle normal? That's around 72 plus or minus 5. And how is the shaft condylar angle, which is around 40? And then anterior humeral line, which should cut directly in the center third of the capitulum. Look for the teardrop, whether it's nicely formed or you can see any change. And then look for the radiocapitular line. Also look for something which we call as a coronoid line, which is similar to the Shenton line in hip. So it's continuous with the proximal, the volar coronoid, and it's continuous with the anterior humeral line. It's a smooth line. So if you see any change, probably there is dislocation or something else going on in the elbow. This is the radiocapitular line and the ulnar bow, which Mubarak has described. So that should be touching dorsally from distal to proximal. And rare scenarios where there is no ossification center, we look for these two lines, medial humeral line and lateral humeral line. And when we draw a proximal ulnar axis, so the proximal ulnar axis should lie between these two lines. Otherwise, the elbow is in cubitus varus. So this is a posterior-medial physeal separation, that is post-reduction. We can see the line there. Normal variations, we should be aware that trochlea can ossify with multiple centers, and do not confuse it with medial epicondyle or something. And there is eccentric ossification on the MRI. If you see the capitulum, the anterior part is ossified and the anterior and medial part. So if you see an X-ray of a younger child, elbow less than 4 or so, you can find that anterior humeral line may not actually cut through the middle of the capitulum. So these are normal variations. So few case scenarios I'll talk quickly. So this is a case of distal humerus physeal separation. So we see that medial and lateral humeral line have moved, and we need better views to see the lateral. And then same child, 6 days old, presented with the MRI already done, and we can see the cubitus varus there at the end of the 2 weeks. And that's the physeal separation. We don't routinely do MRI. The child had already an MRI when they came to us. So this can be confused sometimes with a lateral condyle fracture as well if given only one view. So it's actually a posterior-medial or physeal separation. You can see that line, medial humeral and lateral humeral lines. When in doubt, always arthrogram helps to differentiate between these two. Supracondylar, one view is not enough. In lateral, you may see many things which can change the management, conservative or surgical. That's the anterior humeral line cutting. Lateral condyle fractures, you need an internal oblique view. And this is an incarcerated medial epicondyle fracture into the joint, which was thought of dislocation and reduced. But after 4 weeks, he came with this X-ray. And this is a fallen outstretched hand. You can see the radial head is lying 180 degrees upside down, almost outside the joint. In the X-ray, there is a faint thing overlapping the olecranon process. And in the AP view, it's just behind the capitulum. That's shown in MRI. So message is suspect clinically. Remember the ossification sequence. Take care or read the soft tissue shadows. Know the bony alignment and normal variations. And thank you so much for listening.
Discussion. Don't fall for the seemingly beautiful things. They may be really harmful also. So here is Dr. Premal Naik to enlighten on that. Sir, please.
Thank you, sir. This is going to be an extension of the previous talk, and it's very important that sometimes only the x-rays are not important. So this 9-year-old female fell at school, had injured this hand, and this is how the x-ray was. Can anybody find out any fracture in this? So sometimes fractures may not be very visible, but if you look at, say, there's a significant soft tissue swelling. She came to me about a month later, and this is how the x-ray was. Any fracture at this point of time? But the moment you take an opposite x-ray, you will find out that there is some fracture. Now you're looking at a radial head fracture. Then MRI was done, that confirmed the fracture. We thought we'll treat it surgically, but then I decided to give a conservative treatment trial, and everything healed within few months, and she gained good movement. And that is why when the first x-ray is normal and your clinical signs tell you that there is a significant injury, these lesions are known as trash lesions. Trash is a acronym for trivial radiological appearance seeming harmless. It's a very twisted term. What basically tells you that sometimes the injury is so subtle that you need something more rather than an x-ray. And this is the list of injuries which were described by Dr. Peter Waters in his paper in JPO in 2010. For most of these injuries are fairly common, but sometimes when they're subtle, we tend to miss it. So let's go to a case similar to Dr. Vidyasagar, which was showed. This child was 20 months old and treated as an elbow dislocation with this type of post-reduction films. When the child came to me, there was a cubitus varus. In addition to that, there was restriction of movement, and at 2 years it was very obvious because you don't see medial condyle at 2 years. When you start seeing medial condyle at 2 years, you know that there is something wrong with the distal end of humerus where it was an avascular necrosis. This is how there was a significant deformity. The deformity was corrected, and post deformity he again has started going back, and he's going to need some more surgeries coming down the line. Just by not knowing what injury is there, if that point of time, if the surgeon had done either a sonography, arthrogram or an MRI as shown by Dr. Vidyasagar, we would not have landed here, for sure. So how can we get away? This is a similar looking x-ray, 9-month-old female presented with elbow pain. She probably had similar injury at very young age, so probably a case of NI, not accidental injury. How can you treat them properly? Because when you don't have MRI on table, so how do you define your distal fragment? As beautifully shown today morning, what we can do is you can add some dye here. Once you add the dye, your distal fragment is very well delineated. With the good delineation of the distal fragment, you can treat this as a supracondylar fracture. You can reduce it in AP and lateral, and then you can start pinning. You can add some more dye and see finally that you have restored the anterior humeral line. This 10-year-old came to me with severe pain, obviously not much bad looking x-rays, but the moment you take opposite x-ray, you will realize that one piece which is there on the outer side on the right side is in the inner side on the left x-ray, and when you open up and you find that the medial condyle along with the entire flexor origin is within the joint, what you just need to do is to bring it out and then put a screw there, and this is the long-term follow-up of the same child. This is an interesting case. One of my teacher had treated this, and it is clearly written displaced fracture medial epicondyle left elbow. This child was lost to follow-up because of the COVID in between and presented to me very recently with flexion deformity. This is how the x-ray looked like on presentation. And if you look at this, there was a new bone formation anteriorly. These are the comparative views which tell you how is the ossification developing and where is the fracture. This was basically a missed medial condyle fracture which was treated as an epicondyle surgically. This is how the CT scan looked, and this is how the child had restriction of movement and significant pain. So this is what the surgery was done, and this is how this is early follow-up, and he is improving in his movement and has a good bony union, but fishtail deformity was inevitable because initially the fracture was missed. Again, a second case, this child presented very recently, and this X-ray and this CT scan was done. The report of this CT scan was lateral condyle fracture and proximal ulna fracture. So when the child came to me and when I took the X-ray, it was not very clear. I tried taking internal oblique views, but that was not very obvious. And when we did an MRI, we found that this was a coronoid fracture. Coronoid fracture is exceedingly rare. This is my first and last case I've seen in child. These are her more views, and this is the dynamic. This is a sequence of CT scan on your right and MRI on the left, showing that the only thing I did was I put him in a plaster. These are the different views that's shown by Dr. Vidyasagar, that if you take oblique views, you will be able to see it better. But in OPD, to know and take an oblique view is not that easy. This child had a stable coronoid. He could move elbow very well, so we just immobilized him in plaster, and he has gone to have a good elbow range of movement. So basically, what is trash? It's a fancy name given to injury which looks simple on X-ray than what it is. So what you need to do, you need to have a clinical exam, as you have been already told in previous lecture, and you need to have a high index of suspicion. You need right investigation, which can be just a simple opposite elbow X-ray. You don't need MRI, you don't need ultrasound all the time. This injuries may not always need surgery. It can be treated conservatively. What it needs sometimes is a very rare injury like a posterior subluxation with a radial head fracture, which requires an expert's touch, and that is what you need to learn about trash lesions. Thank you very much.
Middle epicondyle fractures, case discussion. Distal humerus, facial separation. Dr. Isu.
Thank you. I'll move on to a series of case presentations. I'll quickly run through the case so that we have time for discussion. So transfacial separation is an extremely rare injury and mostly occurs under the age of 2 years, and commonly it presents in the neonate, and it can be misdiagnosed as septic arthritis or even a birth injury. So it is very commonly missed, and it is very similar to supracondylar fracture. So usually the presentation would be in such a way that the radius and the ulna are translocated medially, so that there is it's almost like a dislocation, but there is a large unossified facial fragment there. So this is the case of a newborn presented like this. The treating surgeon reassured the parents, gave the child a sling, and it went on to heal, and they presented at this stage to me. So this is fully healed transfacial separation. They presented at about 4 years of age with this deformity. So the range of motion was about 10 degrees short of full extension, and about 100 degrees of further. If you take an X-ray, you can see that there is a very steep slope where the trochlea is. Trochlea itself is unossified, and there is a large anterior spur here which is blocking the flexion beyond 100 degrees. So first thing that occurred to me was whether there is an AVN of the trochlea. So I waited for the deformity to worsen, waited almost 2 years, but there was no improvement in the range of motion, no worsening of the cubitus varus also. So finally we bite the bullet, did an osteotomy, and got back the carrying angle. And you can see here, even though we did take a CT scan, we didn't find any AVN here, but you can see that there is a slight fishtail deformity which is developing here. And on surgery, on exposure, this fragment anteriorly could not be excised at all. Part of it we did excise, but it was so large that we feared that the K-wire hold would be compromised. So we excised only partially. On table we got good range of motion. It has healed very well. But this spur over the period of 3-4 months grew larger and has formed a large bump here. It still allows about 120-degree flexion. He has got full extension, and there is a fishtail deformity here. So even though we hear that transfacial separations are generally benign, a closed reduction is okay. Sometimes people advise no reduction, sometimes even K-wire and closed reduction with arthrogram. This is a case that illustrates that if you totally neglect it, it can go on to a cubitus varus. Thank you.
Nice of you, Dr. Ishwar. He will talk on medial epicondyle fractures. Dr. Orthopaedic on the stage, please.
Thank you. Thank you, Preethi Hospitals and Dr. Prahalad for inviting me. Nice to be here in Madurai. So I think this case is almost the same discussion what we had in the first few lectures, that is introduction, radiological, and then Dr. Premal presented on thrash injuries. This will be almost the same thing. So some basics to understand that the medial epicondyle is a secondary growth center. And it appears around 6 years and fuses the shaft by the age of around 14, 17 years. So you'll see a small speck of ossification and then it fuses and it remains there for a very long time. And quite often this fracture, epicondylar fracture, is quite often it's an avulsion fracture because all the strong flexor muscles are attached there. So when they have an injury, it's avulsed from the medial epicondyle. And it is an extra-articular. So you have to understand that there is he was also talking about medial condylar fracture, where the condylar is nothing but the trochlea and part of the epicondyle. So this is purely an extra-articular fragment, which is having the muscle attachments. So based on the displacement, they can be classified. So somebody can notice any changes here in this X-ray. This is a common scenario. In fact, in my earlier days, I did this mistake of missing these fractures. So when you get an elbow X-ray, this is how it looks, and you don't see any medial epicondyle there. You're supposed to see something there. And the same thing is in the joint. It's called an incarcerated. So literally the joint is having that fragment, and quite often they are very unstable. And what do you do? And again, the first lecture, if you remember, you do an opposite elbow X-ray. Quite often in pediatric practice, whenever we are in a confusion status, we are not able to see what is ossification, which one is, we don't even remember sometimes. Just get an opposite X-ray. You can appreciate that fragment is missing there. The simple getting an opposite X-ray can fix this. So this, once you identify it, the treatment will be easy. The same thing was shown in the previous classes. This is not my case, this is Dr. Harish case. So here you can definitely see that the dynamic study's importance. Whenever we have a suspicion of a medial epicondylar avulsion fracture, always examine them clinically. So what do you see? See that he is giving a valgus force, the fragment is just trying to move downwards. So dynamic examination is a very important thing, especially under an image intensifier, and that case went on to have an open reduction. So it's very important to have an index of suspicion. You need to suspect first. For that, X-rays and then examination is very helpful. They can be fixed once you identify by any means. If you are dealing with a bigger child, probably a screw, and most of the smaller kids can be managed with a simple K-wires. And all the fragments will fall on back. And it is, how common is this fracture? They are quite common. They are not that common. In fact, in my whole lifetime, I would have seen probably 5 or 6. Of course, I don't work in a trauma setup, but these fractures are quite rare. Not like a supracondylar fracture and lateral condylar fracture. They can be missed. And usually between 7 to 15 years, they occur. And 50% of the medial epicondylar fracture associated with the elbow dislocation. That means some instability is there. So we should not take it for granted. So this is what I was telling you, incarcerated. That fragment is gone inside the joint. They can be totally missed. This is just a diagrammatic representation what really happens, and the fourth diagram will be the fragment coming inside the joint. So what are the complications if you don't identify and if you don't treat them? Either they can go for a non-union, totally, if it is completely incarcerated, things like that, and obviously there can be a major instability in the elbow. So my take-home message is have an index of suspicion for any elbow injury in a child. So if you examine them clinically, you will notice that medially there may be hematoma, some skin changes, edema, and then of course with the dynamic examination you can get all the messages, whatever you are looking for. And opposite X-ray is a simple tool and quite often helpful. So displaced fractures are always managed with a intervention with a K-wire or open reduction. Thank you so much. I take this opportunity to all of you to support my friend Dr. Rajkumar Amaravati, is contesting for Indian Arthroscopy Society. Thank you very much for Preethi Hospitals.
It's we who has to thank Dr. Rudra because for finishing a little earlier. And high index of suspicion, there's a person in all of our house to suspect us. So don't worry, always will be suspicious.
Thank you, sir. Next, we call upon Dr. Harish to give his talk on acute lateral condylohumerus fractures, not fear, and case discussion also.
Yeah. So first of all, I thank Preethi Hospital and team, Dr. Sivakumar and Prahalad for giving me this opportunity. So we don't want to see these kind of late presentations and chronic lateral condylar fractures. So the aim of this talk is to prevent these kind of late presentations, these kind of scenarios presenting in our outpatient. Okay. So it's very obvious that we have a lateral condylar fracture here. So anybody, even in half awake, they can pick up a fracture here. But it is important to pick up these very subtle injuries. Okay, it looks very sweet and innocent, but it's actually not. So if you look at the dissected specimen here and compare with the radiograph on the left side, you can see a small flake of metaphysis in the X-ray, whereas actually it's a big chunk of chondrosseous part of the distal humerus. Okay, so the correct treatment starts with correct assessment. Okay, the first thing what you need to do is look at the soft tissue swelling and look if the child allows, you look for any instability here. So a lot of soft tissue swelling like we saw in the morning, that indicates the significant disruption of the periosteum in the soft tissue. It indicates an unstable fracture configuration. So next comes assessment of the fracture anatomy and its stability. Okay. So you can look here, this X-ray looks relatively normal here. So this is an AP view, what we think as an undisplaced fracture. If we rotate the limb internally by 15 degrees and take an X-ray, you can see there's a fracture here. So it's essential to get an internal oblique view whenever you suspect a lateral condylar fracture. So this is another X-ray, same child. The staging of this, actually these fractures differ when you compare with an AP and lateral views. So internal oblique view shows a stage 4 fracture. So this was described by Song et al. And he said that 70% of fractures, the amount of fracture is higher and the staging also is higher if we take an internal oblique view compared to an AP view. So essential radiographic examination of suspected lateral condylar fracture has to be all three views, AP lateral and 15-degree internal oblique view. So coming to the stability. So Song has described this staging of fracture which has 5 staging, whether the fracture is displaced less than 2 mm or more than 2 mm. So based on that, he has 5 stages. The first 2 stages is defined as sort of a stable fracture where you can observe or do a weekly follow-up and then treat. The 3rd, 4th and 5th stages are unstable fracture configurations. So it is sometimes very difficult to assess these staging on an X-ray. So I feel whenever you have a doubt, so these are a diagrammatic description of how these stages progresses. So whenever you have a doubt, don't hesitate to get an additional investigation, especially an MRI is which can be done, or an arthrogram when the child is under anesthesia, you can get an arthrogram. Okay. So look at this X-ray on day 1 and this is an X-ray on day 5. So what has happened? The fracture has displaced. This is what we call as late displacement. Okay. So why does this happen? This something looks like our humble politicians which are very simple and look sweet when they present initially. After the elections they look different. Okay. So if you remember this, do not forget that there can happen a late displacement in lateral condylar fractures. Okay, so why this happens is because the cartilaginous hinge which is holding the fracture fragment, the cartilaginous fragment initially, and this is pulled by the common flexor, the common extensor origin, and the cartilage hinge breaks and the fracture starts to displace. So however, one thing you need to remember that there will not be complete displacement and rotation of these initially little displaced fractures, but they sort of translate and it can go on for delayed union or malunion. So this late displacement, as I said, when you look at the dissected specimens, there is break in the cartilaginous hinge and it can go on to disrupt. So if you remember this slide, you will never forget how to treat a lateral condyle fracture, what is the pathology of late displacement. So the risk factors are significant soft tissue swelling which is present initially, which signifies a lot of soft tissue injury, then gap at the fracture site laterally, then the fracture line is through the epiphysis, that is type 1 Milch, and if the initial displacement itself is high. Okay. So intraop you can get a varus stress view and test the stability. So this we did in the morning and we found that the fracture was unstable with varus stress. So if you look, how do you treat these fractures? The relatively undisplaced fractures, song 1 and 2 stage, there is no soft tissue swelling. We follow protocol of putting a slab or a cast, long-arm cast, and follow them every week. You have to counsel the parents that these fractures can get displaced anytime, so you have to come without fail at every week interval. And when they come for follow-up, we have to take off this splint and then take the X-rays in all 3 views and look for any fresh displacement. So if there is no displacement, you can treat for the cast for 3 or 4 weeks, depends on the child, the age of the child, and then start mobilize. If it's a displaced fracture, most of these fractures can be treated with a close reduction and thinning. So if the displacement is more initially, so we can do a close reduction and pinning. If it fails, then always be prepared for an open reduction. So if it's a gross displacement, there have been papers where stage 5 also have been reduced by closed means and pinning has been done. So you can try always close reduction, but if it doesn't come, we can try we have to go for open reduction. So we did this morning, do an arthrogram assisted fracture fixation. So it's a very simple technique, adds little to the cost and time of the surgery, but it helps you in a good reduction. Okay. So indications for open reduction, as I said, if you're not able to achieve a good articular reduction by closed means. So what I want to remember is it's an interarticular fracture, aim for a perfect articular reduction. Blood supply is precarious. When you try for open reduction, preserve the soft tissues. Okay, so I'll go for the case examples. Okay, so whatever is the time, I'll finish in that. So this is an 8-year-old boy, 2 days old injury. So this is injury films. How would we grade this? We will start a proper discussion here. Stage of the fracture.
This is, you can put it as a stage 1.
Yes, sir. So visible only in internal oblique view, not much of displacement, stage 1. So conservative and weekly screening is the protocol for these undisplaced fractures. So we did a weekly follow-up. These are 2 weeks, there's no further displacement. So do we expect any further displacement from here? There is no further displacement at 2 weeks?
No, I don't think it.
Yeah, these at 5 weeks, he went on to heal well and child had a good range of movement. Okay. So the 11-year-old boy, it's a fracture dislocation. So can somebody maybe read the X-ray or tell what to do next?
I think this is very important to realize that this is a fracture dislocation, and the fracture is of lateral condyle because the radiocapitular line is not aligned.
Yes.
So that gives you, that's a rare variety in which the lateral condyle fracture goes all the way medially that it becomes unstable and leads to dislocation.
Yeah, to start with, it's an unstable fracture configuration.
Yes, so there are only handful of papers reported on this type of fracture. So if you realize, I think the best way to treat would be open reduction and internal fixation.
Yes. So we did a close reduction. I mean, actually this child was referred to me at this stage. The referring doctor had reduced and sent it to me. So I couldn't make out any fracture at this stage. Then I thought I'll just observe, weekly follow-up. So is it right to observe or do a fixation straight away?
I think at least I would put 2 KYS at this stage.
Yes, sir. So we'll see what happened. So subsequently, we can see that it started to displace. So because there are a lot of soft tissue injury when there's a dislocation happens, so it is bound to be unstable. So what I did was just put couple of KYS. After a week, when I saw that the fracture started to open up, I put couple of KYS and then the child went on to heal well. So okay, this is a 3-year-old child, something like I would say thrash kind of a lesion, which very thin wafer of bone you can see there. So it's a stage 3 song fracture, Mills type 2. I've just drawn the outline, probably what will be the contraosseous part of the distal humerus which is fractured. So what is the option here? Conservative or closed or open reduction?
I may not agree with your diagnosis actually.
Okay.
This could be transfizial separation also.
Distal humerus separation?
This could be.
Yeah. So why do you think so? I mean, don't get carried away by the outline what I've drawn. I'm looking at the humerus and ulnar line.
Actually, in the transfizial separation, there are 3 groups mentioned.
Yes.
The first one is purely cartilaginous. The second one will have
Something
Thurston-Holland
like
kind of
yes,
small
exactly.
fragment.
Exactly.
The third one will have a large Thurston-Holland fragment. This may be a second category where there is a slight.
So why do you think it's a distal humerus fascial separation? I mean,
yeah, both the radius and the ulna have moved away.
But if you draw a humerus and a ulnar line, it is well aligned. No, don't get carried away by that outline what I've drawn with the pen.
No, the thing is that the lines which you are describing are not very well.
Yeah, for a very small child it
yes,
may not be.
under less than 2 years
Yes.
old, and this child, you have written 3 years old but looks much younger because the radial head epiphysis also has not come.
Yeah, no, maybe 2.5 or something like that.
Whatever.
Anyway, there is a possibility of lateral condyle also.
Yes.
Looking at
It
that.
could be. I'm not
Could
saying
be.
it. We have to prove it otherwise. So before opening it, I will do an arthrogram.
Yes, sir.
And see that is it intra-articular. If it's not intra-articular, you can just put 2 KYs, reduce it to 2 KYs.
So this is the surgical technique what we did yesterday. This method of close reduction. So did an arthrogram. So probably I did arthrogram first here to see what was, whether it's a distal humerus fascial separation or just lateral condyle fracture. So I found out that it was more of a lateral condyle fracture. Actually, I injected more dye and it made my life very difficult when I did this surgery. So, you know, you learn lessons hard way.
Why do you feel that this is a lateral condyle fracture?
No, X-ray, it's obvious that there's a lateral condyle fracture here.
No,
And you can see that the blue, pool of dye is traversing in between the medial and lateral condyle fragments.
There is a fold there. It goes there. Always there is a there. I doubt that this is a lateral condyle fracture, to be honest.
What do you think it is?
This is a physial separation. Because I don't see dye escaping only from the lateral side. If it's a lateral condyle fracture, then your all dye will escape only from the lateral side. Your dye is actually not escaping at all. That gives me a feeling that the capsule is intact and the fracture is above the capsule.
Fracture is above the capsule here.
Yes.
Okay.
Sir, this is the reason why we discuss in the morning. We first try to pin it and then do the arthrogram. He may be in a better position to assess.
There are two views. I agree with what he has done because here the diagnosis was not sure. When the diagnosis is not sure, you need to do arthrogram first. But if the diagnosis is sure and you are fixing it, you fix it first and then do the arthrogram.
Anyway, we all have a different views. I would feel that, probably pinning it is the ideal way because there is a thin flake of bone.
Yes.
What we commonly see in a case of a lateral condyle fracture.
Yes.
So I would pin it and do arthrogram, what rightly done. And is it the same patient,
Same.
what you're saying? Yeah,
Same
here we can
patient.
see it very clearly, the articular surface. But because the dye has gone everywhere, it's now difficult. It is not, conveying that.
Exactly. There's too much of dye. In fact, it was very difficult for me to do the pinning for this child because it obscured that metaphyseal thin flake of bone. So I went ahead and did the pinning. So this is what I don't know what was the reason of this hypertrophy of this fragment on the posterolateral aspect. So I treated as lateral condyle, though the X-ray appeared like that. Of course, the child had a lateral bony prominence, but fortunately the child had a good range of movements. So I'm just observing this child to see how that remodels. Okay, another case, a 4-year-old child, stage 3 fracture, referred after 2 weeks. So why do I call, is it right I'm calling it a stage 3 fracture? I'm sorry for the views. These are 2 weeks. We can see some amount of displacement. So is it right to fix or do we observe?
I would fix it. Okay. Because it's quite displaced, and if you look at the angulation,
The
sorry for the
lateral
X-ray.
condyle also seem to be angulated. It's going into varus.
Yes. So the fracture was not reducible anatomically by closed means, probably because it's a small child. Sometimes we get early soft callus on the lateral aspect. So I had to do an open reduction for this child. So I did a small lateral approach, reduced the soft tissue interposition and soft callus there, and did a pin fixation. So I use a coccus lateral approach, though some use a post-lateral or some use a post approach. For if I don't anticipate too much of difficulty, I just go by lateral approach. So this is the approach I use. So most important is I do not
Harish, I
touch.
would just add one comment which I added in the morning, probably heard
Yes.
or not. So if you are taking a lateral approach, you should take a bigger approach.
Yes.
The reason being that you said you didn't get the reduction.
Yes.
And if you didn't get the reduction, you had to open up. And once you open up, you don't align the metaphyseal part. You have to align the articular part.
Exactly.
And unless you align the articular part, and if you have to expose the articular part
Yes.
and see the trochlea with which the lateral condyle fragment is, you need a bigger incision and you will need an anterior capsulotomy. Little wider so that you can put your Homan all the way on the medial side so that you
Correct.
can see the articular. With the incision which you have taken,
No,
I would
this
be very...
is not this child. I just wanted to show the incision.
Because
that's all.
just time to say that if you don't take a proper incision,
Yes.
you will
So
not.
usually
If you are, see, the message I want to drive
Yes.
is that if you are opening a lateral condyle fracture, you look at the articular surface alignment. Don't look at the metaphyseal alignment.
Yes.
For metaphyseal alignment, you can just take a 1 centimeter incision, align the metaphyses, and put a wire or screw or whatever you want to. But you are not treating the fracture where it is. The fracture is down there, and the metaphyseal fragment is probably about tip of the iceberg, which you are not wanting
Correct.
to treat because this is an epiphyseal injury with a intra-articular injury.
Yes.
So,
whenever I expect
anytime anybody is contemplating an open reduction, they have to open anterior capsule and look at the articular alignment if you are doing an open reduction. Rather than, if you are not confident doing it, you may do a arthrogram and look at the articular surface, which is far better than just aligning metaphyseal and leaving rest of
I agree with you. I agree with you, sir. So whenever I feel I need to do a bigger exposure, I usually go posterolateral, and I make sure that I'm not touching compromising the soft tissue structures there. So that way, gives me a better exposure to the joint and the alignment of the the distal humerus, the lateral condyle and the middle condyle. Okay. So this went on to heal well. This is at 5 months. You can see a lateral spur is the most common thing which happens in these lateral condyle fractures, especially after an open reduction. And I always counsel these, parents of kids that there can be lateral prominence and sort of pseudo-varus appearance. Okay. So this is another child. I think we already discussed about this. Yeah. Shall I stop the discussion here, sir?
We'll continue the discussion.
Pardon?
At the end of the session.
No, this case discussion.
Yeah.
Time is over. Shall I stop or shall I continue?
I have a question for the panel. So whenever we open lateral condyle fractures, some school of thought says that we go for a direct lateral approach. Some school of thought they go for posterior or posterolateral. So we all know that whenever we open a lateral condyle, we want anatomical reduction. The pathology is more anterior. We want to see the anterior trochlea and open reduce there. So what is the advantages or disadvantages of using lateral approach in this case scenario?
I am anterior. Definitely laterally I approach, but as Dr. Premal was mentioning, we open the capsule anteriorly, put a bone lever or a hook on the medial epicondylar area, and you can see the trochlea and the whole of articular surface nicely. And that's what I do.
Once you open
I have a different take. So you can take a posterolateral incision. I have shifted completely to posterolateral incision. If the dissection is, joint is subcutaneous there, you don't retract much muscles. You just lift the triceps, you are directly on the joint. You see the posterior part of the joint. If you want to see the anterior part, just put 2 drops of dye. You will see that also. With a very small incision, you will be able to, you just need to retract olecranon a bit. You will be able to see beautiful articular cartilage. I have done, there's a YouTube video if you want, you can see on my channel. We have done completely displaced 2 months old fracture with this, with an excellent result.
condyle fractures in children, the radiology could be deceptive. I thought you have to open, and even if it is looks like, for example, somewhere in good position, you have accepted it, I thought there could be rotation misleading. That is number one. Number two, there was an article, I think, a couple of months back about the soft tissue interposition in the undisplaced fractures, and in fact, Dr. Harish also mentioned the case. I think you said there was some soft tissue interposition. What the article says is about the periosteal interposition like the medial malleolus. So is it that the present trend is if the X-ray looks good, you will accept it? Or do you think that the X-ray, either AP or lateral view, all could be misleading if you don't have an interrotation view?
Sir, I feel you're right, sir. There will be one paper a lot of things, but one doesn't mean that every case will be there. So, by and large, we have not found any periosteal interposition in a lateral condyle fracture. There may be one of such case. So the thing is, if there's a periosteal interposition, if you're following up that child radiologically with an epi, lateral and internal oblique view, it's not going to show the signs of union the way you want it to see. You can later on displace. It's been shown that 1, 2 and 3 type of fracture, if you observe them for 2 to 3 weeks, they're not going to get converted 5, as Harish already mentioned. So it's not going to displace much. So if you see that there is not, it's displacing or it's not showing signs of union as you want by say about 3 or 4 weeks, you can always intervene percutaneously without opening the elbow. But if it is a type 5, you are obviously going to open it. But there are people, crazy people, who can still reduce type 5 and get good results. It has been published in more than one series, and I also have little experience on that.
The lateral condyle goes to non-union mainly because it bathes in the synovial fluid rather than the periosteal flap which is going inside, like the way we see medial malleolus. That concept doesn't apply.
Okay, Prasad, I mentioned the article, a second thing. My idea was that what looks undisplaced in a AP view can be misleading. This is what I had the impression, but I didn't know if it.
No, that's the reason we are stressing on the importance of arthrogram. To see the alignment.
That I agree.
And open reduction means various approaches and the way to see the alignment.
Madam, let's have one more last case if we can, time permits.
We can continue.
Same lateral condyle. So these are 2 months. This child was treated with surgically. So I pulled out the pins because child was quite comfortable. So do we intervene or should we wait? I know that there's a fracture is in sort of varus alignment here, but clinically it was quite stable. I couldn't elicit any. So do we intervene, Dr. Premal?
So I think I would not rather. I'll go back to the first slide, and I reiterate the point I told you.
This is the patient at 2 weeks after the injury.
Yeah. So if you're doing an open reduction, unless you are getting articular right, then you're not done a good job. That is period, right? So you have to look at fracture as I said in the morning.
It's an intra-articular fracture.
Yeah, if you have an ADER patient, lateral condyle fracture, you are obviously going to open elbow and look at the joint. Then why not give that same treatment to a pediatric whose elbow has to last longer number of years than an adult elbow. First thing is that. The second thing is delayed union is known. And if it goes for delayed union, we have reported our series of delayed union and non-union by treating a percutaneous screw. So you could, if the patient is ready to follow up diligently, you can keep this child under observation, take about X-ray at 1 month, maybe 2 months. If it is showing improved callus formation, you can wait. And if you are in hurry or the parents are in hurry, just put one screw and 100%.
I am not in. I think posteriorly there's good amount of callus there. So I thought I'll just observe. There was some varus small union with lateral prominence. I just waited. So she came recently for a distal radius fracture on the same, the same extremity. So she was doing well. So I just accept that lateral prominence.
I want you to go one slide back. And I just want to beautifully show you that whenever you treat a lateral condyle fracture, whether that fracture is treated conservatively, you treat it operatively, that lateral condyle has a high chance of fusion. You can see there is a fusion already there.
Yeah.
So these are small things. They will not hamper your result even in long term, But if you compare the x-rays in adult, say suppose this same fracture comes to my adult friend, say about 20 years down the line, that will require probably Vikasa's 3D printed plate.
Harish, can I have a question on that?
Yes.
How early do you expect a radiological evidence of union in this particular type of cases?
Especially very young children, about 4 to 6 weeks is
Okay.
what, especially
Yeah.
the metaphyseal, if metaphyseal units, I think I'm not worried
There
about.
is an article and which says about the forgotten phase of fracture healing, and in that he mentions that if you have a doubt if about the early cancer which is not seen in the X-ray, which is not picked up by radiological X-ray, you can do ultrasound, and if you are still money, you can do MRI or CT, but that picks up early. It
Yes.
was actually presented. One study was published from India and presented in the Orthopaedic Trauma Association. But that publication was not for the children, it was for the adults. But it's already given that if you have ultrasound, which is cheaper, it picks up early. MRI picks up earlier than that. Then routinely that is not possible, but ultrasound is possible.
Yes.
So just to continue with your, I completely agree that ultrasound way of doing it. But question is that ultrasound is a very operator dependent, and when I come from a city where there are more than 800 orthopedic surgeons and probably more than 2,000 radiologists. I want to find who can tell me that good callus formation. I cannot sit on his opinion or her opinion that this fracture is uritic. That's bottom line.
I totally agree. It is ultrasound basically is technician dependent. That is number one. Number two, you have to have a specific probe for that. But I have an ongoing study on doing on that, but in adults, not in children. Maybe, it may not be applicable to all institutions, but if the science will progress, I suppose you are depending on many other things. If you have the money, it is still CT. It is probably better than a surgery, spending on the CT. It also picks up. And that series, actually published series, not my series, published series is very interesting. By about 3 to 6 weeks, you can get an idea. But by 8 weeks, you can be 100% sure it will unite or not unite. And radiologically, plain X-ray, absolutely no union. And then after 12 weeks, 16 weeks, as predicted, it united. So it's probably, but I agree with you, it is technician oriented.
I think that's it. Let us summarize what we have discussed here. Okay. So do not forget to discuss with the parents about late displacement, especially in treating stage 1, 2, and 3 fractures, and about the lateral condyle thickening. And of course, we always discuss about delayed union, malunion, stiffness. Okay, you can refer to my article on a comprehensive article on lateral condyle fractures in Journal of South Indian Association of Orthopaedics. Thank you.
Thank you, Dr. Harish. I now call upon Dr. Ashok to take up on the stage to discuss on supracondylar fractures.
Can I have the slides, please? Yeah, good afternoon, everyone. Now, supracondylar humerus fracture is one of the most common fractures we see in our day-to-day practice. Now, a quick show of hands. These are x-rays of 2 different patients. How many of you will operate on these cases? Yeah, very few. Yes, most of you think they are very innocuous and they can heal conservatively. But if you miss this, this is going to be the end result. They're going to create, of course, a cosmetic deformity. The more important thing is this will predispose to lateral condyle fractures in future age. There is a cubitus varus hyperextension. Now, this already Dr. Vidyasagar has explained the importance of how to take proper X-rays. Everyone knows the Gotland classification. First is incomplete fracture and type 3 is complete fracture. The type 2, the posterior cortex is intact. This is what originally Gotland described, and as you can see, the posterior periosteum is only intact in type 3, whereas the anterior periosteum is completely torn. Now, Wilkins modified this. He subclassified type 2 into A and B. In type 2A, there is no rotation or translation, just a pure extension. The anterior cortex alone is breached. As in type 2B, there is associated with translation or rotation. This is the Rogers line. This is the most important radiological finding you have to see. See, whenever you draw the anterior humeral line, usually it will cut the capitulum. In an extension type fracture, the capitulum will go posteriorly, it won't cut. Now, we will deal with the importance of this anterior humeral line later on. This is a very simple algorithm by Professor Teddy's Longo in how to classify the fracture. It will take hardly 30 seconds to classify a fracture based on this algorithm. First, if the fracture is complete or incomplete. If the fracture is complete, then is there any contact? If there is some contact in a complete fracture, it's type 3. If there is no contact in a complete fracture, it's type 4. In type 1, the anterior humeral line will cut the capitulum, whereas in type 2, the anterior humeral line won't cut the capitulum, or there will be a varus valgus gap of more than 2 mm. This is the slide. Now, AOS has recommended that you fix every displaced supracondylar humerus fracture. It means even type 2, type 3, flexion type supracondylar, displaced type. So you have to fix everything. But if you fix everything, there will be is going to be a over indication. Like more than 70% of unnecessary cases will also be pinned. But then how to know whether this closed reduction conservative management is going to fail or not? So this is a good article by Fitzbiggins. So actually he described the anterior humeral line index. See, in the first X-ray at presentation, it was the anterior humeral line is not touching the capitulum. But once you do a close reduction, it was touching the capitulum. The reduction was very fine. But after a week, as you can see, it has gone back. So what is happening? So the anterior humeral line index at the time of presentation is very important. At the time of presentation, if it is not touching the capitulum, it means already there is a hyperextension. If there is a higher anterior humeral line index, then it means the extension deformity at the time of presentation is higher. It means the soft tissue disruption is also extensive. If there is an extensive soft tissue disruption, then there is a less support to maintain the reduction. So there is a very high rate of failure. So always believe on the X-ray at presentation, not the close reduction X-ray. Now, Kang et al., they have shown that if there is a low supracondylar humerus fracture, low fracture is in the lateral view below the hourglass line, you will see the fracture, epi view below the transepicondylar axis. So let's take a case example. So this case belongs to Dr. Kailash. So you can see, so in the low supracondylar fracture, the distal fragment is very small. First of all, it is very difficult to reduce. Even if you reduce, it won't stay there. It is difficult to pin also. So such fractures are usually associated with disruption of the capsule ligamentous complex. So most of the low supracondylar fractures have to be treated surgically. And of course, you will need orthogram. Now, this is the first X-ray which I have shown in the initial slide. See, the most important thing is this is looking innocuous. And even the lateral view is looking like a type 1. But the most important thing is this, the medial comminution or a varus impaction. So in this paper by Debog, actually has shown that all those fractures with the varus impaction and medial comminution, they go for this cubitus varus deformity. They definitely need pinning. But can some fractures be treated non-operatively? Then what is the real indication? So this is a very good paper published in JPO 2012 by Spencer et al. Here, he has given some few indications where you have to, first is excessive swelling. So you will not be able to position the limb at all. You cannot flex the limb, hyperflex. Second is if there is any varus valgus or rotation involved. And then comes the shaft condylar angle. So Dr. Vidyasagar told you the shaft condylar angle is around 40-45 degrees normally. But if it reduces to less than 15 degrees, then you have to. As you I have shown one case where initially the reduction was good and then you are having loss of reduction. So all these cases have to be pinned. So shaft condylar angle, if it extends further, the angle is going to reduce. Again, this is similar to the HLA, the anterior humeral line index. So initial deformity is more than the soft tissue is poor, you have to fix them. So all these things told you when to fix. Now this fracture configuration is going to tell you how to fix. So this is a paper by Bock et al. From Johns Hopkins. They have shown the patterns of supracondylar humerus fracture. The medial oblique pattern, the lateral oblique pattern, and the high supracondylar. See, it all depends on where the fracture line exists. If the fracture line is exiting proximally, medially, then it is a medial oblique fracture. If you try to pin this only by lateral pinning, this is never going to fix it properly. It will be highly unstable. So they will need a medial pin. Similarly, a lateral oblique fracture, proximally the fracture line will exit laterally. Such cases can be treated by lateral pinning. Now, the anterior humeral line, the capitulum is going anterior to the anterior humeral line. So these are flexion type injuries. Flexion type injuries, especially displaced fractures, may be probably a type 4. So all these flexion type displaced injuries have to be treated by surgical means. So what is type 4? So type 4 is a multi-directionally unstable fracture. When you flex the elbow, it will look like flexion fracture. When you extend the elbow, it will get converted to a extension type fracture. They need special techniques which they will discuss in the next lecture. Also, whenever you see a pucker sign, it indicates that there will be some impalement. So the fracture fragment will pierce through the brachialis. You have to milk that to get a reduction. Sometimes in irreducible fracture, you can palpate a sharp spike subcutaneously. Whenever you are palpating a sharp spike subcutaneously, you should have a low threshold for open reduction, because most of the time there will be some impalement of the soft tissue structures. In a posterolateral type, the medial spike will be injuring the median nerve or brachial artery. In the posteromedial type, the radial nerve can be involved. Now, this is a special pattern. Normally, when you see a supracondylar fracture, it's a hyperextension injury. The fracture line, it actually starts distally anteriorly and progresses posteriorly proximally. But reverse oblique pattern, it is a reverse. So here, the fracture line starts from anteriorly in the proximally and then it progresses distally posteriorly. So such patterns, if you go for the usual Blount's technique of reduction, it won't reduce. So if you initially reduce the translation and then if you flex, it is going to impinge, it won't reduce. Initially you have to displace it anteriorly and then you should correct the translation. So take home message is a proper X-ray is important. You have to do a proper clinical radiological analysis, classify properly, and configuration of the fractures are also important in planning the fracture fixation. Finally, don't forget to recognize the special and unusual fracture types. Thank you.
Thank you again. I'll be speaking on technique of reduction for extension type is most common. I'll demonstrate that technique and little bit about the other things also. So what do we want to prevent? Basically a malunion, later on deformity and sometimes stiffness. Very rarely when treated conservatively in huge swelling you may get a compartment. So we want to prevent all those. That's the reason for your intervention. So general indications are here. I think it has already been spoken by Dr. Ashok. So important thing here is if you have a pale hand, it's an emergent situation. If you have a pink pulseless hand, gross swelling, it's an urgent situation. So we have to have a good physical examination. Look for the open wounds, look for pucker sign, check for all the 3 nerves. And if they are able to show okay, thumbs up and show, give you high five and then cut like scissors, all the nerves should be intact. And if they are not intact, look on the lower side. The left hand side, the fingers are little whitish. They are not as good circulation as the right hand side. So pay attention to even the smaller details, and you can also measure a waveform and pulse oximeter. So our goal is to get a stable anatomical reduction and minimize the complications overall. So how do we do that? This is the OT setup. Left side is the side which is being operated. The monitor was in the right side. So the C-arm moves like this. And morning we had a discussion, Premal sir told that C-arm can come from the other side for AP and lateral. So there are 3 ways of pinning and draping. So I'll talk about extension type fracture. It can be done in supine or in prone. So one way to do is freehand draping like what we did in the morning, and the other way is to do it in prone. And you can use an arm board with a folded towel or sheet so that you can pin them easily. This is a technique taught to us by Dr. Sandeep. So he uses that wooden plank, stabilizes the proximal fragment, and then distal you can manipulate without much need of traction and assistance. So he is milking it and then aligning it gradually. So this is the video. Basically they are images and I'll talk about it. Note the fracture pattern, note the comminution, note the line, obliquity before you see direction of displacement. And once you're okay, then you plan traction in about 20 to 30 degree flexion, and you correct the sagittal plane, start flexing the elbow, and you can put pressure over the olecranon so that you also get sagittal plane correction. And that's the shoot through view which we see. Generally our tendency is to external rotate. In stable fracture it will stay there, but this maneuver in case of instability or shear where there is an oblique fracture can displace the fracture. So it's better to take a AP and lateral both by moving the C-arm. And once you are done with that, I generally put a tape, and then our assistant is holding it in a flexed position. And the position of the forearm would be depending upon the direction of displacement. So if it's posterior medial, you close the gap by pronating. If it's posterior lateral, you close the gap by supinating. So remember, thumb in the direction of displacement. So then we get proper views, AP and lateral. If you are happy with that correction, you start your pinning. Start with the lateral pin. See that in the humerus, all the 3 columns, at least 2 columns get good purchase. And I go by feel, proximally without drilling, and then you feel the far cortex while you are drilling. If you are happy with 2 pins, you can do that. Otherwise, you can add an additional pin if you think it is unstable. I move the elbow, range of motion, and see. Sometimes you get this pucker sign, and that can be dealt by milking the anterior muscles there, brachialis, everything can be dislodged, and sometimes you get a pop also. And then the fracture reduces. And then post-reduction, you put them in a which is in less than 90 degree of flexion. So what do we look at? Finally, at the end of reduction, there should be no step. Bowman angle is normal. Teardrop appears normal, no fracture gap anteriorly, and anterior humeral line cuts where you want it, and that's the continuity. So this is an example of oblique fracture, but if you see the post-op X-ray, you can't know which wire is going where. So you need not be so this thing. So there is a proper technique to wire them. So these are a few pinning rules. At least 2 wires of appropriate size should be used. Purchase near and far cortex minimum. Purchase at least 2 columns among in the distal humerus. And then spread or diverge the wires to get the maximum purchase. So this is an example of divergent pinning. Another example of parallel pinning, and you can add one more if you feel it is unstable. When do we need a medial pin? When there is a medial oblique fracture, when there is a high supracondylar, or else a medial or lateral comminution, and a varus collapse where you need to correct it. So when we are doing medial pinning, follow these rules. Pin always in elbow extension. Push the ulnar nerve manually with the thumb. Use a small stab incision if you are in doubt. Use a hemostat to spread it out. And start on the oscillating or a ream mode when you are doing that drilling. You can use a sleeve also. Some people use a drill sleeve. And I use a smaller pin when doing that without opening. So we get a flexion type fracture also, which is rare, but it's important because they are highly unstable and a high rate of open reduction is there. So there are techniques described for reduction. This uses a towel as a fulcrum, and you pull the proximal fragment, push the distal fragment, get it reduced and pin it. But taking AP view is sometimes difficult, I feel, in this scenario. And AO has described a technique where manually you push the distal fragment from anterior and index finger from the posterior through the proximal fragment and reduce it. So this is an example. Distal fragment is malrotated. There is ulnar nerve palsy. I did all close reduction technique. Nothing happened. So I had to open it. You can see the air arthrogram like that there. And then got it reduced and then pinned it. So that's the end result. So yeah, sorry, the slides have moved too much. So this is another example of a transverse fracture, kind of oblique, but if you see it's going in flexion and extension as well. So it was highly unstable. So we used a joystick technique through the distal fragment. I know you'll all criticize me at the end of this that there is something, but I'll show you again. So this is the end close reduction what we got, but there is cubitus varus there, and probably if that olecranon pin could have been maneuvered before pinning the medial side and the lateral side, we would have got a better result. Thank you.
Thank you, Dr. Vidya. And now we'll have a session on hypertension. Our BP shooting up when treating these difficult supracondylar fractures. And it's a rainbow session. We'll have different colors, but which will cost us dearly. And I invite Dr. Somasekhar to talk on pink pulseless side.
Thank you, sir. Respected teachers and my dear friends. I come here not to present my achievements. I have come here to seek answers. I'll present the case. I'll ask the seniors to give me precise answers, because I'm a small-time orthopedician who sits in OP, and suddenly I get a case something like this, not in an institute like this. So what to do? So here is an 8-year-old boy, history of fall while playing, pain in the swelling in the left elbow, and pulse is not felt, but it's relatively pink, and saturation is somewhere around 92%. Fortunately, there's no deficits. What to do now? What should I do? Probably like look at the skin condition. Will it tell me that, okay, you're going to have any vascular injury or not? What is the next line of investigation? Should I do a Doppler, or should I do a CT angio or something like that? And then what should I tell the patient, parents as well? Means it may require open reduction, or should it require vascular repair or something like that? Or its best bet is to refer to an IR center or prepare for CRF and wait. What do you think, sir, when you have a situation like this, Piramal, sir?
I think you have to tell your setup's limitation, discuss with the parents. One additional thing which you did not mention and I routinely do is I have a handheld Doppler. Your all vascular surgeons and plastic surgeons who are doing free flaps, they have this machine. The cost of the machine is only 15,000 rupees. And if you have a pink pulseless hand, and if you do a Doppler, and if it shows good signal, I'll be rest assured I'll go ahead and do pinning, measure it again. If there's no pulse, but if I have these are signals, I'll just sleep on it. So that is one thing which you should invest if you are doing good amount of pediatric trauma practice. I think a 15,000 worth of machine serves a lot of trouble. It can help you in post-operative status. Sometimes you are not happy with your pulsation.
Yes, sir.
The second thing is, if it's absolutely pale, and if your center is not equipped to do it, it may be a good idea to at least give a trial. Suppose that patient has to travel about 200 kilometers. It may be a good idea to at least do a good close reduction, put 3 pins, alert the center where you are shifting that necessary can be. The thing is that sometimes you do it and patients may not reach the place.
Yes,
That is
yes.
again, I've seen everything which is mentioned here and not mentioned there. So talking and educating parents is one of the most important thing in such injury, and you have to tell them your limitations. Say suppose I am in Ahmedabad, but sometimes I may not be able to catch hold of a vascular surgeon. It happened to me in one of my bigger hospitals. A patient came at middle of night at 2 o'clock. I said I'll come down, but 3 vascular surgeons refused to come. What do? I don't have expertise to explore. I can open the artery, I can bring the 2 ends, but I don't have skills to anastomose.
Yes, sir, that's
Very
exactly
well.
what I wanted.
So you need a team. If you do not have a team, the second thing is that if you are in an institute where everything is available, it's a different thing. We are talking about institute where duplex scan is not available. If duplex scan is not available, handheld Doppler works beautifully well.
Yes, sir, that's exactly what I wanted to institute. Is not everybody will have CT angio, and truly speaking, in some centers they will not even be affordable to have a CT angio. So learning color Doppler probably would be the best bet, I think so.
Just to add to one thing more.
Yes, sir.
CT angio is never ever indicated in supracondylar fracture. The reason being, why do you do CT angio? You do CT angio to see where the block is. And in supracondylar fracture, the block is always at supracondylar level. So why waste that 10,000, 12,000 rupees and maybe 12 hours of your time in a non-vascular hand, which requires urgent exploration? So if I have had patients who have done that, and only patients who have survived are the ones which never needed CT angio.
That's exactly, sir. No need to do CT angio. Something you have to learn probably, like, because one of our fellow called me and told, sir, I have a supracondylar, the pulse is not felt. I don't have CT angio, I'm sending it to you. So that's why it's not required. In this case, we did a close reduction. Post-reduction, good waveform is obtained. Now the question comes always, how long to monitor, sir? Is it 24 hours or 48 hours, or is it okay? We can send him the next day.
No, I think if you get the pulsation, that's good enough.
That's good enough.
Only thing is you'll have to take care of the edema and then
Yes.
the compartment and other things which you are going to discuss again. And probably you can observe as an outpatient.
Observe patient. Okay, sir. That's end of it. And this is one.
I would little put it different way. If you have a vascular injury, there is something called as a reperfusion injury.
Yes.
So reperfusion injury is usually at around 48 hours. So if the compartment syndrome has to happen, it will happen for 48 hours. So if you have a patient who is willing to stay, I'll keep that child indoor for 3 days.
3
in a
days.
pink pulseless hand.
Okay.
Which has got good perfusion immediately after that, because I don't want to miss compartment syndrome. Because I have had minor compartment syndrome, I have had a major compartment syndrome referred to me because the child was discharged immediately with a doubtful pulse. So I think reperfusion has to be taken equally seriously as non-perfusion.
He's telling a scenario where he is in
Yes,
the
sir.
clinic. He's not in the setup of a hospital to admit and observe. So in that case, you can counsel and then you can ask them to immediately
No, sir, we
report,
have
or every
inpatient.
day
I
you can
mean,
ask them to come and show you.
Okay, that's one thing, because it's very difficult to convince the patient to keep him for daily to come. It's very difficult, sir. You can keep him there.
No,
That's
the
one
thing
good
is,
thing.
if you are ready to take up a patient with pink pulseless and in the setup, I think that setup will always have one more room for you for
Yes.
2 days. I think that's a bottom line. You
That's-
have to observe those kids for at least 72 hours. Whether you do it, you go there, or you go to their place and do it. If they come to your place and do it, or you keep them indoor
Yes.
and you go and see, it's your choice.
Yes, sir.
The
You need
patient
to
has to be
observe them.
observed, because compartment syndrome is something, you can just not give them full function. It's not like a brachial plexus palsy which Dr. Vadva showed.
So that's exactly, sir.
One
You
more
need to
scenario,
observe them
sir.
for 3 days.
So
That's
one more scenario, sir. Sometimes in Doppler reports, we get like the anterior spike of the proximal fragment is piercing the brachial artery like that, and all. Sometimes we get the reports. And how do we do about that, sir? In one patient, he was a 5-year-old supracondylar fracture, and pulse was not there. Hand is pink, but the pulse oximeter is showing 20 to 30 like that.
See, the thing is, there are two different things we are seeing. Whether we are seeing that artery is injured or not is a different thing, and circulation is there or not is a different thing. Artery could be injured and circulation could be there, and artery could be injured and circulation could not be there. There is no situation in which circulation is not there and artery is not injured. There is no situation, because there is such a nice collateral circulation that even your brachial artery is cut, you can have normal circulation. So we had recently in last week IFIX, Dr. Sheetal showed up a case that everything was normal. Because they found out that artery was cut, they went ahead and repaired it. Had they not done that investigation, that patient would have absolutely gone back without any exploration, because the circulation was normal. I think we should not confuse with pulse and circulation both. Circulation is independent, but if you document, since now you have documented injury to the artery, I think you are obliged to do something regarding that, because you cannot sit on it. Had you not done that, and if the circulation was normal, you would not have done anything. But now documented that there is a injury to the arterial wall, I think you are obliged to do that, because you will not be able to save yourself if something goes wrong and patient ends up in courts.
Have you had any scenario like having a report like this, and you're not able to close reduce on one try, you have opened up and the artery shows some bleeding or anything like that intraoperatively? Is there any scenario like that you've undergone? Because we don't have in-house vascular surgeons to do.
I also don't have in-house vascular surgeon. But the thing is, see, if I am expecting a vascular repair, then I'll have my vascular surgeon. If I'm not expecting it, I'll have him on call, and in that case, I will not open up. I think in last so many years, I haven't done an open reduction for supracondylar fractures. There are multiple ways of doing it without supracondylar without opening it. The only thing which you must remember is that if you have an arterial injury and your pulse is not good, and if you're not getting a good reduction, so if you're getting a soft reduction, that is a scenario in which the artery is interrupt between two fragments. It can be artery, it can be median or anything. So in that case, you are obliged to open up and remove that. You get if you get a 100% reduction in a supracondylar width, even if the artery is cut, that means artery is not between the fracture, it may be cut. Then whether you want to repair it or not depends on whether you have a good circulation or not. If you have a good circulation, there is no need to repair it, because you don't know whether it is an intimal injury, it is complete translation, it is laceration, we don't know. The second thing is that there are long-term studies of people who have repaired a nerve or a vessel, and there are pseudoganglions have been or pseudoaneurysms have been there. Pain is been reported. So once you follow these children long term, then they have problem. Not repaired also have problem, and the ones who have been repaired also had a problem.
Sir, is there any indication for CT angio in supracondylar fractures for you?
110% no. There is no indication.
Even pale hand?
Pale hand, that means the artery is cut at the level of supracondylar. Call a vascular surgeon, do open reduction with an intromedial approach and repair the artery.
No, in today's medical legal scenario, sir, without any documentation, right away we can
no, you can always do an open reduction. You don't need any documentation to do open reduction. While doing open reduction, if you find that artery is normal, you just reduce and close the skin after reducing and fixing the fracture. But if I am called as an expert and somebody asks that by doing CT angio, did you waste time in this ischemic link, then what will be my answer as an expert?
Again, CT angio is not a must because we have a Doppler scan. One is the handheld Doppler scan which you can keep it over your OPD. Another one, you can always call your radiologist. You can literally see the color Doppler being demonstrated nicely. That is also a good documentation.
No, the thing is, if you have a supracondylar fracture, you have a pulse oximeter reading of 20 with pulse not palpable, where can that artery be? CT angio will tell you only the location of the arterial injury. In supracondylar fracture with no other fracture anywhere else in that limb, is there either it is going to be 3 centimeter above or 3 centimeter below, and 6 centimeter incision you can always take when you are doing vascular repair, because ends will be retracted.
No, the thing is, sir, even our vascular surgeon wants a CT angio.
So that's what they are.
Because
they are
the
trained.
vascular surgeon is not very keen to take up the case just on Doppler study. So whenever there is like a pale hand, he just orders for an CT angio. That is why I am
No, the thing is, what information does he get by ordering CT angio?
He just want to know what segment is gone.
No, they will not get segment, because the distal fragment is fed by the collaterals. It's not fed by the artery, because its artery is already cut.
There is a general tendency, because they treat lower limb injuries as well. So there is a question of location, but in supracondylar it's very clear.
Is there this
You have to, you should not waste time on going for the CT angio. Should not waste time. That's the panel decides.
This is an algorithm published in one of the journals. They are saying that the median nerve injury at presentation has more positive. Is this so that it is have a more positive correlation that they may not have a pulse after close reduction? Is it really having any positive correlation, sir, with that?
So I think one of the paper has already refuted.
Yes, sir. That's why I wanted to ask. Okay, this is a vascular protein. For want of time, I just skip through this. But this is the last case. This actually, in this case, this happened in Preethi, I think so now, because it's an institution one. We didn't get anything in this, so we have to explore it. Fortunately, we had a vascular surgeon who was able to come and help us out. So if something that has to be taken is that I think as youngsters you should start trying to learn about color Doppler, and that is more than sufficient, but there are ways by which you can document or convince the parents to do a good surgery at the end of the day, and moreover you will get good results also as well. And CT angio is not a must. Probably some people may disagree with me, because MLC cases are on the rise these days, so you have to think before it. And regarding pale pulseless hand, I think Dr. Ishwar sir will talk about it, and that's why I didn't go. Thank you, sir.
Thank you, Dr. Soma. We have a pink hand. Now we have a pale hand. We need the blessings of Lord Ishwar. Dr. Ishwar, please.
Thanks. So, you see the name has changed, so that's actually kindly donated by Vidya. So, the place where I work, I practice in many places, so I have many perspectives, small town perspective, tertiary practice. So each practice has got its limitations and the way you work around it. So the way I practice, any of these vascular, the pale, pulseless hand gets referred immediately to a higher center without any investigation. So I speak to the surgeon there and immediately refer. So we are spoiled in the place we practice. It is at Palakkad. It's another 45 minutes. We go across to Ganga with all their vascular repair channels ready. So I get a one-on-one with Dr. Venkat there and I send across my patients. We don't do vascular repair. So that's why I requested Vidya to share his case. So this is a case of a polytrauma where there is a distal humerus injury, supracondylar fracture. There is a puncture wound on the anterior surface of the antecubital fossa there. There is a puncture wound there, and there is also a distal radius fracture. So there was no distal pulse when the patient presented with a very sluggish capillary refill and a pulse oximeter reading around 92. So I think we can discuss as we go along. This is a far more clearer scenario than a pink pulseless hand. This is a pale pulseless hand. So immediately you have a situation where it is practice oriented. Depending on the place you practice, you may either choose to refer or choose to explore. Premal sir, Rudra sir.
You've shown an excellent, significantly good perfusion in the hand, and you're still saying that pale, because pale ones I have seen that they just don't pick up any SpO2. All pale hands which I have treated all these years, they never had any reading beyond 70, if they even pick up. So it's not only to look at what type of figure you get. I think the waveform is very, very important. If you're looking in pulse oximetry, the waveforms are very important. And here you will not be able to feel the pulse because your distal radius is also fractured. So this is the child which will immensely benefit with handheld Doppler examination, because that will tell you whether the pulse is there or not. With SpO2 92 with distal radius fracture, if I am not able to palpate pulse, the first thing even my ward boy will come just with the Doppler in the clinic immediately.
So which do you give preference to, an irregular proper waveform or the actual SpO2 reading in the?
They go hand in hand. So if you are getting any saturation beyond 90 degree, the waveform will be good. And if it's less than 70 degree, you will not see the waveform. So waveforms are very important. It goes hand by hand. You will not get a 92 degree SpO2 without waveforms. I've never seen that.
So, so I think we discussed this. So, in this particular case, of course, there is this issue of which fracture to fix first. So the humerus was done first, and it was plated, and then the distal radius was pinned with a single K wire, and then the supracondylar fracture was at rest. The fracture site was exposed. There was already an incision there. It was exposed, and you can see the vessels. There is a laceration on the vessel right there.
But Dr. Ishwar, if you go back to that X-ray of the supracondylar fracture, it doesn't look that bad. Do you think this fracture can cause an injury to the vessel? Go back to the elbow. Yeah. See, we saw such notorious X-ray in the past presentations where there is a spike penetrating, and then this looks benign to me. But of course, we don't have a lateral view.
I think this spike here is the culprit here, this little spike here, and we are not seeing the lateral view here. So the lateral view, this may be far anterior.
it's the mainly because of the
probably.
mangled limb. We couldn't take it in ER, and the child was extremely this. That's why I told if anything manipulation is required, better to do it in OT so that you get proper view. And Premal sir pointed out regarding that saturation, that was initially in the ER, but by the time we took to theatre, it was like 70, and waveform was absolutely like not like really flat, but there was something, but it was going and coming, not very consistent.
So, do you alert your vascular surgeon for
Yes.
this case? You have him around? Huh?
Yes. So we have a vascular surgeon. So I told him that we are going, so you be prepared. So they are there in the theatre by the time we finish. And 2 times it has happened that we fixed it, and vascular surgeon explored it, and our fixation was kind of manipulated. So the wire came loose. So 2 fractures malunited because they do manipulation during their maneuver. So I think till they finish, we have to be there in the theatre and then check. And
Now coming back to the clinical scenario, because I think everybody has to get a message. Now, do you think the vascular? How did you say that the median? I mean, the elbow is the culprit? Because looking at this, the wrist
Yes.
equally looks bad.
Correct.
So, but you have also opened the cubital area.
Yes.
But how sure were you that it's only based on the Doppler?
Yes.
And distally there was nothing.
Nothing.
From there. Okay.
So just a question. In close studies, all these pulseless implant, pulseless tail hand, are you directly open? Pulseless pale hand. So you know that's a completely displaced fracture. We don't know what's happening at the vessel, whether it is skinned or it is trapped. We don't know what's happening really. So is it advisable to straight away open anteromedial approach, see what's happening, reduce the fracture safely, and or do I have to do a close reduction?
So I think it will not be a wise thing to open anteromedially unless you have a vascular surgeon with you. What will you do? You find a tear.
Sir, just see, anyway, pulseless pale hand, you always have to have a vascular surgeon. Okay. So if there's no vascular surgeon, I wouldn't even open. Probably I would just reduce and refer it. Vascular surgeon is there. So do you still straight away go and reduce or straight away open it?
I will reduce because I have vascular surgeon with me.
So why do you want to cause?
See, because the thing is that even if you open anteriorly, the visibility of your proximal and distal fragment is not that great. You have an access to proximal fragment, but distal fragment from anterior approach is not very well visible. So if a vascular surgeon is with me, I'll still cross reduce. If I get a good reduction, I'll put 2 K wires, and when he opens doing that, I'll isolate the ulnar nerve and put a 3rd K wire, and then I will not wait till, like he said, I'll put 3 K wires.
Okay, so what do you think if the vessel is trapped in between the fracture site?
So vessel, if I get a 100% reduction, the vessel is never trapped. If 100% reduction is not there, you're going to anyway open it up. So why not take a chance? Because close reduction and pinning is far simpler surgery than open reduction and pinning.
So I follow the other protocol. Whenever I feel there is a pulseless pink hand, I always have a vascular surgeon or plastic surgeon as a stand. I mean, pulseless pale hand, sorry. Pulseless pale hand. I don't hesitate to open. There's nothing wrong. What I had seen in, 3 cases, the vessel was completely stretched over the proximal fragment spike. It took at least 15-20 minutes for the vascular surgeon to separate the vessel from the fragment. So he had to very meticulously separate the vessel. So had I done a close reduction in that scenario, it would have completely transected the vessel. It would have been much more complex. Once we released the vessel, it was very simple. We didn't do anything. We just put some xylocaine, okay, and the vessel, the pulse came back. We didn't do repair at all. We didn't do a thrombectomy also. So once we are there, we release the vessel. We know what's happening. There's nothing wrong. I think that's a safe way of doing rather than doing a close reduction. So we know the vessel is at risk. So we don't know what's happening exactly. It's a thrombus or a.
See, I think we are confusing people who are sitting here. We are talking about 2 different things. Suppose, let me summarize. Pink pulseless hand, where your saturation is more than 95, but you are not able to feel the pulse. The first thing you are required to do is you take the child and in close reduction, close reduce it, put 2 K wires, 3 K wires, whatever. If you think the the reduction is not 100% and your pulse deteriorates after doing reduction, that is the case where the artery has come in between. If you did not get 100% reduction and your pulse is not felt post-operatively and your saturation has improved to 98, then again your artery is not between the fragments. I've rarely seen pink pulseless hand getting pulsation back on table. It generally takes 24 to 48 hours. So you're not going to get the pulse immediately post-operatively. So if you have a handheld Doppler, that will help you. But if you don't have, your saturation is good, your capillary circulation is good, then you can observe that child for 24 to 48 hours for any deterioration or any signs of compartment syndrome. He is talking about pale pulseless hand in which will not get saturation. There will be no or very delayed capillary refill in which you know that there is an arterial injury at the level of supracondylar. So there is no need for CT angio in that case. In that case, you will have your vascular surgeon. Then it is up to you whether you want to open it up and then fix it, or you want to just close, reduce and fix it and open and see, because either way you're going to do that first. I think that's a chicken first or egg first. That depends on your own setup, your own training, your own bias, your own comfort and what your vascular surgeon says, because here you become a secondary person. When a vascular surgeon comes in, you become a secondary person to hold that patient after reducing in KY. In all other cases, you are the first person who is going to take all the brunt and all the responsibility.
Jyoti,
Sir,
one second. Just to add to what Premal said and add a small town perspective, I think number of our junior colleagues will be in setup which are not optimal. So I had cases where in late evening supracondylar presence, nothing great, just a regular type 3 supracondylar. You expect pinning and be off. Pulse is normal. But on table, I have had cases where after reduction, a mushy reduction, and pulse goes every single time I get an optimal position. That is the best position. But it's not the perfect position. So I have come back, I have talked to the parents, I have said I'm going to leave it unreduced. I don't have a vascular surgery backup. You go to the place where vascular surgery is there, they will do open reduction. So don't forget to back out if you feel that the pulse is going after reduction. The reduction will never be perfect, but you can always come back and talk to the parents and back off and not pin it, leave it with a slab and refer to a place where there is a vascular repair available.
See, I think it's just, I'll give, just a second. Yeah. I'll just give you a simile. Virat Kohli is not required to do century every time. So we are also not required to do, because pitch situations can change. Today if it rains, the pitch will be different. If it does not rain, the pitch will be different. Same thing, you assume that this is a simple supracondylar fracture, but things can turn around. So it's sometimes you don't have to have your ego that why did not I do it. That's the wisest decision. It's a soft reduction and the pulse is labile. That means what is in between? It's the brachial artery only. But that happens once in 10 years. It doesn't happen every day. How often did you have it? Once in his lifetime. So I don't think we carried away by one such incident, what he did, what I did, what did. Generally, if you are doing supracondylar and if you are not in an institute, I would just urge you to invest your 15,000 to 20,000 rupees in a machine which lets you speak at night, because hypertension, as sir mentioned, is far worse than having pulse or no pulse.
Sir, the same thing, sir. That is, it might depend on the institution which we are working, maybe. And it's the handheld. He told that already the pulse was there, but intraoperative the pulse went away. So in such a scenario, should we always have a vascular backup, or shouldn't take the case aggressively? That is what.
Then you won't be able to practice at all.
Yeah, that is a message. But the thing is that
no, so thing is, if you so thing is the how often does that happen? That's why.
Yeah, but that depends on how acute. That is an orthopedic surgeon starting his career, maybe in the initial first few years, if it happens, then he is in trouble.
No, that's exactly.
We are just no. So that there is something called red flags. So what he has highlighted is just a red flag, and that happens exceedingly rare. I have never seen this situation in my life. So I have been in pediatric orthopedics almost far longer than anybody here. And I have not seen one. So he was lucky or unlucky to have that. And I am unlucky or lucky to have not that. It's the same thing. So I think let us not just discuss about one such case. We have to be, for 99% of the cases, pink pulseless hand, more than 99% of the cases, once you do reduction, you will get pulse back within 48 hours.
At least we should counsel the bystanders that if it
Because we
doesn't
have to
come back,
counsel-
it might need
see
a vascular
the bottom
intervention.
line is counseling is the most important thing in current era. You and I very well know how much people trust doctors.
Yeah.
Look at this NMC thing. We are in every newspaper. Today's editorial in Times of India is also on VR.
No, you have to consult, not before surgery itself, you have to counsel them. Then after it is failed, you have to again do a re-counseling. Then that should be the scenario, not.
I think if you've, over this year, I've realized that if you have been honest to the patient, told them preoperatively that this is a tough case and I'm trying my level best, if not, I'll send you there. I don't think any patient has gone against me or to any doctor who had. I had a similar situation where pale pulseless hand was there. One of my friends reduced it and sent it over. We had everything ready, and it was such a very smooth transfer. They came to me, the vascular surgeon was ready. We re-explored. Actually, we refixed it also because the first surgery was not very good, optimal reduction. Then now that we were opening, we thought we'll get a good reduction. And in that case, it took almost 1 year to get the elbow movement back. And that child also did not get full movement back. So everybody talks about, I'll show some of cases in my talk, that you don't need 100% reduction in supracondylar. Trying to achieve 100% leads to a lot of complications.
So anyway, all is well, that ends well, all the parameters were back to normal, this child, and it went on to heal well. Thank you, and thank you. Vidya, you want to add something? Dr. Vidyasagar?
When I said that I'll wait till the vascular surgeon finishes, if you see the X-ray, intra-op it is different and post-op it is different. This is still acceptable, translation is there, but things will move invariably when the vascular surgeon do that. That's why I would like to wait till they finish.
Thank you, Dr. Ishwar.
Next I will call upon Dr. Kailash to talk about nerve injuries and irreducible supracondylar fractures.
Respected seniors, colleagues, the outset I would like to thank the organizers, Professor Sivakumar sir, Prahalad sir, for this opportunity. Madurai being my second home, I'm privileged and blessed to be part of the faculty. So my talk is on complex supracondylar fractures. So I'll just have a few cases on all these 4 varieties, and kindly bear with me for the next few minutes. So irreducible supracondylars are not that common, but the potentially irreducible are around 8% of all supracondylar fractures. There are various reasons for being. So this is a 4-year-old boy presented with the day 1 of injury. This is a clinical picture. As you can see, there's a fold of skin anteriorly. Probably the previous speaker spoke about the Pucker's sign. And the AP and lateral views, you can see here there's a large spike anterior. Probably the brachialis muscle is buttonhole. So this child had a Pucker's sign, potential irreducibility. And on examination, he had a perfuse pulseless hand, but the neurology was normal. So here we go back to the milking maneuver of the buttonholing of the brachialis. Milking was done, and this just immediately after milking, you can see this flap of puckering is gone away, and it was close reduced with 3 lateral wires and went on to heal. This is the latest follow-up X-ray around 2 years post-op. It came for another problem. So not all irreducible supracondylars need open reduction. So there can be some minimally invasive technique, can be assisted techniques which can be used. One was the milking maneuver. Second, this technique was described by Dr. Virat Shingade from Nagpur. Here, he makes a small incision and uses the blunt end of the suction tip to reduce the fracture, as you can see here. And another technique here, this case was done by Dr. Alrik sir, who gave me this case. Again, he uses a small hemostat, a blunt hemostat with a small incision, and try to lever out the distal fragment and turn it and close reduce it. So not all cases can be done
using this assisted close reduction methods. Some may need open reduction. So newer techniques like predominantly we try to do the anteromedial anterolateral approach because the pathogenesis is there. So let us go for this case. A 7-year-old boy, again road traffic accident. You can see gross swelling on the lateral aspect of the elbow with a small blister. It's actually almost just within 6 hours of injury. Still they are presented with a blister, and this is the X-ray. So here we can see the big proximal fragment is almost translated laterally. It's a posteromedial displacement, completely displaced. So here we can see the skin to the spike distance is almost less than 2 millimeter. So these are the injuries which are very severe, and we have to have a very low threshold for open reduction. So we had anyways we attempt a close reduction always of any case. So also be prepared for assisted reduction methods. Even if they fail, try 1 or 2 times and then immediately plan for an anterolateral or antemedial approach, because depending upon the pathogens. Here we did an anterolateral approach because of the posteromedial displacement. We use because of the instability, we added a medial wire. I used a small incision, use a sleeve and put the medial wire, and child went on to heal well. Here you can see the small scar on the lateral aspect. It's an anterolateral approach. So can we predict the irreducibility, especially in these circumstances? So look out for the anteromedial or the anterolateral bruise and puckering. Sometimes we may be able to reduce the puckering, sometimes we may not be able to reduce. The tip to spike distance as well as the increased angle of the spike, whether it is an anteromedial or an anterolateral spike. And significant amount of smelling and previous reduction methods, always sometimes it may complicate the situation. So another 7-year-old boy, again presented with a hyperextension injury, fallen outside stand. But here the swelling is not much. But these are the AP and lateral views of the X-ray. So when we look at this X-ray very closely, this is not the usual pattern of supracondylar. It's a high open and a bit here in the lateral plane. It's quite a bit more high supracondylar. So in the circumstances, but the patient actually presented on day 2 of the injury. He had a CT with him, lucky or unlucky. So here we can closely see there is a big lateral comminution here, and the severe obliquity of the fracture, and there is also a reverse oblique pattern. So it's a potentially unstable fracture, and there may be a component of irreducibility. So type 4 injury, high oblique. And there was again, when we closely look at, there's a medial spike and a small lateral comminution. We tried again, always try for a close reduction maneuver, but we failed close reduction, but we did a anteromedial approach in this case. So child went on to heal well. So sometimes we get this kinds of injuries. It's an 8-year-old girl, it's a comminuted supracondylar, it's an RTA. She had a fall from a 2-wheeler, hit by a 4-wheeler. So here, all the problems happen. So there is gross displacement, it's a collapse of both columns. We have a small intra-articular component too here. So what do we do in this case? Do we order for a higher investigation? Do we anticipate irreducibility? Thinking of the implant armamentarium and approach, whether attempt of close reduction, open reduction, what approach we want to do. Prema sir, your thoughts on this case?
I think most important thing is you will be able to decide what type of implant you're going to use by taking a traction film, which is not possible, of course, without giving anesthesia. But I think here you will like to keep few things ready. Maybe I would keep long KYs ready, because in this my preferred way of fixation, if I get hands on, is to put 2 intramedullary KYs going from below. People can come from top, like it is described in the TENS manual, that you can take an entry from just below deltoid insertion, put 2 KYs, 10 nails, come here and give that. And you can even do plating also. So anything is okay, depending on how comfortable you are. I don't think you can criticize one another that I would have done that, which would be a better than me.
So let us see what was done. So clinically, this was the picture. So there was a big medial aberration, cross swelling. The child actually presented 12 hours after injury. It's a gross edema with a feeble pulse, but the limb was perfused. So as sir suggested, we didn't go for any higher investigation. We took the child to theatre did traction films. So we can very clearly see the lateral column nicely sat here, and there was like a nice articular congruity is also there. We did a lateral wire, I did a horizontal wire for the intercondylar element. We did an arthrogram. Arthrogram was okay, but we tried lot of maneuvers, but this small medial column fragment was not coming into place at all. So a small medial incision, whenever we open the medial part, the ulnar nerve was just under this region, just pressing there, impeding there. So here in this case, I put a screw for fixing the proximal fragment, and for the medial column, again as sir suggested, I put an intramedullary wire and a bicortical wire. So this was the immediate postoperative picture. So it could seem a lot of multiple wires, but still the article congruity, the column, everything has been restored. So at this point of time, we think we have done a great job. So this is at 4 weeks post-op. We can see a nice callus formation on the lateral side, the posterior side, but still there was not callus forming on the medial side. So we decided to remove the lateral intra-articular wires and start active range. But now what do we end up? This was 2 weeks later. We saw this anterior angulation. Probably because of the severe soft tissue injury, the periosteal strip is there. So child developed a small flexion deformity at the minimal collapse there. But the coronal plane, the angulation, the reduction was maintained because of the lateral callus. So, but lucky or unlucky, 2 years post-op, the child almost had near normal range. So you can see the scar here on for the ulnar decompression and the screw fixation. So what are the lessons we learn from this? So don't be so rigid. Whenever we see a supracondylar, rigid with wires. So we can extend, because this child is an older child around 8 years, and we also think about the gross comminution. Because the child on the older side, rigid stability in these cases, probably a medial plate would have prevented this flexion deformity. So if possible, a higher investigation to delineate the nature of the fracture, and especially in the near adolescence, more rigid fixation and early mobilization may give the near optimum results. So let us discuss with this case. It's an 8-year-old boy with a fall from two-wheeler. It's a big grade 2 compound fracture. Here we can see a big anterior spike. Probably it's an inside-out injury. So the pulse was palpable, but he had probably an anterior intransition injury. He had a present with pointing index. It's an anteromedial. So what do we do in this case? So inside-out infection, because it's an open injury, it's an RTA. Soft tissue, what to do because there's pointing index. The status of nerve is, the vessel is still in query because there's the distal pulse is present. The fracture displays is highly unstable fracture pattern with a big anterior spike, and you have to think about the fixation methods, more rigid fixation. So let us see what was done. In this case, we had the opportunity to open video assembly play. You have to click over the video and cursor varli. So here we did an anteromedial extension of the open injury. We can see clearly the black thing is the brachial artery. We have the radial pulse distinctly palpable, but still video play just distal to the fracture. There was no pulsation, just proximal. The significant pulsation of the brachial artery, and there was mild contusion on the median nerve. So we open reduced the fracture, and because the limb was perfused, the radial pulse was palpable. We didn't do anything for the brachial artery, and this was the immediate postoperative picture. And child went on to heal well on this. The pointing index recovered completely within a period of 6 weeks. Without no significant residual problems. Sometimes we get these kinds of injuries. It's a fall from a swing, a boy pushed to the other. So this kind of open injuries with gross contamination, the bone is almost protruding out on the medial aspect of the distal humerus. And this doesn't end here. When I look at the wrist, there's a gross swelling here. See, it was like a floating elbow, so it displaced distal radius and ulnar fracture. It's a type 1 epiphyseal injury kind of a picture. Here it's an open injury, the grossly displaced, unstable fracture pattern. So the bone is exposed, chance of infection we need to reduce. Think about the floating elbow component because of display distal. So exposure and fixation methods, everything, each and every point has to be thought about. So let us see what was done. So as the exposure was extended, with the thumb pressure and slow manipulation, we tried to reduce the fracture. Fracture was reduced, and this was the AP X-ray, the fluoroscopy picture. And I always tend to do internal oblique, external oblique views to assess the columns, found to be reasonably stable, and the wrist fracture was also close reduced. And this was the postoperative picture of the wrist X-ray. But story begins now. So this was the immediate postoperative picture. So I always try to immobilize the patient immediately before coming out of the anesthesia. I use the posterior slabs and side slabs to ensure the fixation is secure. And now this is the picture in the immediate postoperative, day 1 post-op. So what is the plan now? So what is the next plan? Sir, your thoughts on this? Premal sir? Arisha sir? Yeah.
Go back to the post.
Yeah. So again I went back retrospectively, went through all the views again.
So I think this time in TraumaCon I presented very similar case. Or if you pick up your failure or somebody's failure within 48 hours, it's a good way to revise it. I don't think you want to leave it there, then give her stiffness, and then do a surgery with correction of cubitus varus and probably add flexion or extension to it. So I think you may have had a rough day, probably you missed somewhere. Your proximal K-wire, 2 K-wires looks like acting like a 1 K-wire. And whatever has happened, I think you have to, because you picked it up within time, the best thing is to remedy the situation where it is not very late.
Introp, I always do stress views also. I do a varus valgus stress view and flexion extension stress view and rotations. Everything was done in this case. So there was something wrong going on there. So we explained to the parents. They were quite considerate. They were okay. And I went back again, removed the wires. It was like day 0. The same displacement was there. Again we reduced. So here first I put a horizontal wire thinking that there could be a intercondylar component. Here the time I added the medial wire, the fracture became completely stable. So the lateral combined with the medial wire, the fracture went on to heal reasonably well. And both fractures healed well, K-wires removed. But now in the latest follow-up, there was I noticed a progressive problem happening at the elbow, the coronal plane. So you can see in this X-ray, there's something going on here. So the story doesn't end here. So we are all because of the high violence injury, there could be a component of an AVN of the medial side trochlea, and we have to be very careful. There's to be very close follow-up in these patients because the progressive varus deformity can happen, and we'll have to explain the parents too, especially in these kinds of highly unstable fractures and high violence injuries. These are the lessons that we have discussed already. So there's a note on floating elbow. There's a boy with probably a type 2B supracondylar fracture and a distal radial and ulnar fracture. So what do we do? Whether do we close reduce, conservative, put a plaster? Why conservative? Why operative? What complications can we anticipate, especially in these 2-level fractures, and what to reduce first? Sir, your thoughts? Anybody in the panel? Especially in floating elbow injuries. Rudra, sir.
Go back to that X-ray. Yeah, this is definitely unstable for me, the supracondylar fracture. I would definitely fix it.
Yes.
And when it comes to the distal radius, probably because again we have a sufficient metaphyseal fragment there, distal to the fracture site, I would probably pin that as well. So on the ulna, I don't think so we have to do anything, it will just fall back. And then above slab.
So I would differ here. I would definitely fix the supracondylar, but I would leave that distal radius alone. I have a very significant experience on distal radius. If you leave them alone, they do much better. I have already reported if you do something, the only reason non-union develops in distal radius is that you intervene. Not that if you do peening it will intervene. The thing is this bayonet reduction with ulnar length in normal will require significant force. Your 2 will be converted into 3. So I had on single occasion I had a proximal humerus fracture, supracondylar fracture and similar looking distal radius fracture. I fixed only one. I treated 2 conservatively, and distal radius has a phenomenal remodeling potential, and you will not see any sign of fracture, and it has been reported very well, and it won the best Posner prize for best paper Posner prize in I think 2019, where you don't need distal radius. And I have few distal radius where I have explained parents and I have stopped treating distal radius, giving them an anesthesia I don't give.
So in this cases, especially floating elbow, are we not worried about the edema and compartment syndrome because there's a 2-level injury? There are a lot of papers which this way contradicting. Some papers say you manage conservatively whichever is undisplaced or an operative which is unstable, and some papers say fix both, especially because floating elbow we need to have a very close follow-up. The child can develop anytime compartment and increase in compartment because of the edema. So I plan to fixation of both. Child went on to well without any residual problems. So in my practice, especially these floating elbows, I try to fix both because I don't need to have a very close follow-up. And another concern is whether to fix, if we plan to fix both fractures, whether do we fix humerus first or forearm first? Rudra sir?
See again, looking back to this X-ray, I think humerus first. And see, the very reason I said for the radius fixation, of course the radius heals beautifully, especially the sagittal plane deformities, because they're a 6-year-old child. And 90% of the growth of the radius contributed with the distal radius, absolutely no problem. So, but when we have taken the child for the surgery, nothing, we are going to lose in one pin in the distal radius, and also to get a good alignment. So probably I'll fix the supracondylar first always, and take a call on the radius. If it is reducible very well, probably you can consider not putting it. But my lenience is always for a pinning, especially if I get a good bone in the distal portion without damaging the growth plate.
See, I think I have always told in conferences there's not a single way of doing the things always. There's always more than one way. I think what I said is absolutely true, works in my hand. What he said is absolutely true, and both of them have been documented amply. And whatever you are comfortable with, the only thing is that when you are doing distal radius peening, just take care of distal radial physis. This is a very young child.
Yes. Let us go on to the last topic, most interesting here, nerve injuries. It's a 9-year-old girl presented the extension type supracondylar fracture here. When you see the time you see the fracture pattern, it will be quite worrisome because it's complete rotation. The medial spike is very sharp near the skin, and it's complete rotation. It's very close to the anterior structures. A video on. Player. This is how she presents. So we have this component of pointing index. It's an unstable pattern, a large medial spike, and a pointing index, but the limb was perfusing, the radial pulse was palpable. So now we have the options of attempting close reduction or a primary open reduction to explore the nerve. What is the consensus? So I'll just go fast. So a close reduction was done, 3 lateral wires, we accepted the reduction. The video play upon. So the pointing index absolutely vanished in a period of 4 weeks. The child had near normal range. No pain, no deformity, almost full range of movement within a period of 6 weeks, 3 months. So always if there is a pre-operative anterior intronchus nerve injury and we have a MIG anterior spike and the perfusion is very good, all the literature says go for an expected management. Most of these cases is probably a neuropraxic injury. So especially if we have an associated vascular problem with a pale pulseless hand And if there is a worsening neurology, especially post-reduction, we plan for exploration. It's a 7-year-old girl. Again, see this clinical picture, it's a big anteromedial contusion. And here, looks, it's a big, and the spike is just near the skin. And anteriorly, it's grossly displaced, probably type 4. Video. Actually, I have got 2 talks. I have combined both talks here, so kindly bear with me. So, neurology was normal. So again, unstable scenario, large medial spike, we can anticipate. But anyways, we planned for a close reduction. We had a very nice close reduction, three lateral wires, column wire, fossa wire in lateral views. Video. But in the video, but the immediate post-operative picture, this was when I came for the next morning rounds, child had a pointing index. Again, I opened the wrist, the plaster. There was no pain. Child was very comfortable. I always give only syrup paracetamol in the post-operative period to check whether there is increased need of analgesia. So the radial pulse was palpable. So now what do we do? So the child was very comfortable with the absolute minimum of analgesia, but post-operatively developed a pointing index. It's a very good reduction. There is no spike, there is no gap. The reduction was very sharp and good. There was no GUI reduction. Do we observe or do we intervene? Sir, from the panel.
So if there is no fracture gap as such, so then
I can go back to the immediate post-op. Yeah.
So is there a slight anterior translation in the lateral view?
I think that's actually not a true lateral view, but I had all the columns. So medial column, lateral column views. That's the reason why I do all 4 views. Check the intraoperative stability, flexion, extension, rotation, as well as coronal plane varus valgus. So it's highly stable.
So if there is no signs of compartment, we'll wait and watch.
Yeah. So waited. The child had full range of movement, and the pointing index again, like the previous case, completely recovered within a period of 4 to 6 weeks. So the next case, actually, is a case by Dr. Suresh Babu sir from ICH. So 7-year-old girl presented on day 1 of injury, around 10 hours post-injury. This gross edema, displaced fracture here. It's a posteromedial displacement. The spike is tenting on the skin on the lateral side. The big anterior spike. But the pulse, luckily pulse was good. It's unstable pattern, big lateral spike and anterolateral contusion was there. So again, we tried for a close reduction maneuver. Because of the instability, added a mini open medial wire. There was a very small anterior spike, but this, because of stability of the fracture, this was accepted. This was the immediate post-operative X-ray. I think it's reasonably accepted. It's a very minimal rotation, almost less than 20% of rotation is there, which was accepted. Can you play? But the day and from the night, the child had increasing requirement of analgesia. Child was anxious, apprehensive, and we had a development of pointing index. Video play panel. So more analgesia was given. So at this point of time, do we wait or do we intervene?
I think the pain is one thing which is very important here. Probably the pain is telling us something, though definitely I'll intervene.
Yes.
Probably there is some compression, probably we need to have decompressions. Most of the time it's neuropraxia with the edema, with the compression from the soft tissues. But the pain which is not responding to the analgesics probably is a good sign to pick it up.
Yes. So we took the child to theatre, did an anteromedial open reduction. Here we can see at the level of the anterior spike, there was a tent of the median nerve. So probably the anterior spike was pressing on the median nerve. There was a tent there. So we released it. We just dissected the nerve away, and we re-reduced. And this was the picture here. There's no anterior spike. There's almost near normal reduction. Because of stability sake, we did a medial wire. The child went on to very well. Right after surgery, the pain completely gone. Child was in just syrup paracetamol. Can you put the video? The pointing index in the 3rd or 4th day is completely gone. Child is free of pain and almost near normal function. So the consensus is post-operative anteronational palsy. The exploration, if there is associated vascular compromise post-injury, the signs of compartment syndrome, especially the 3 A's in children, apprehension, anxiety, and increasing requirement of analgesia, and even a subtle malreduction along with these scenario, always never hesitate to re-explore. This is another kid, a 7-year-old male child, again a similar pattern of injury.
I think so. There are still a lot of presentations.
Yeah. Just 2 more cases. I just wanted to do all 3 now. That's all.
Yes. So the problem is either we break for lunch because the people down there also finding food is getting over. So that's the only. Then the faculty will not have the food.
So I'll just finish up with this last case. This is a 4-year-old with a swollen elbow, grade 3 supracondylar, operated elsewhere. So cross pinning was done. Post-operatively, ulnar disconnection symptoms presented to me at this time. Wait and watch, remove the medial wire, put a lateral wire or explore. So we removed the medial wire, stabilized with extra 1 lateral wire, there was complete recovery. And this is the last case from Dr. Mandar sir, the grade 3 supracondylar with a big anterolateral spike. Here the surgery was done elsewhere, the pins, close reduction was done, pins buried inside the medial pin. Child developed hyposthesia and weakness and the minimal claw, but they presented at 8 weeks post-op to us. Here there was frank ulnar palsy, complete hyposthesia and severe clawing. Ulnar exploration was done, the medial wire which was buried inside was impinging on the nerve. So the neurolysis was done, the full recovery was there in 3 months. So here the iatrogenic ulnar injury incidence around 1 to 10%. Here recommendation is it's mostly reversible, it recovers in 3 months. There's no conclusive evidence whether medial wire should be removed or not. Whether we remove or not, the literature says it usually recovers in 3 to 6 months. But if buried, just always remove the wire. Look for potentially unstable patterns, open injuries, stable fixation, floating elbow, plan to fix both. Nerve injuries, most probably they recover. Sometimes earlier exploration and sometimes late exploration may be needed. Thanks for listening.
Thank you, Dr. Kailash. When you exposed this slide, wait to intervene, I thought you were talking about lunch.
Next we call upon Dr. Premal sir for presenting his talk on friction technology.
Hello.
Good morning, sir. I am Dr. Aravindan, final year DNB from Preethi Hospital.
So team A is from Preethi Hospital.
Myself,
Can you please make
I
a
am
note?
D. Abhinav Annamalai.
Okay, good.
Team B from Ganga Hospital.
Okay. Team B from Ganga Hospital. Okay.
Team C from Mohan Kumar Medical Salem.
Okay. Team C from Salem.
So team D from Madras Medical College.
Team D from MMC. Okay. So team F from, sorry, team E from Kadalur Medical College. There's anomaly, right? Let's pay. Okay. The rules, the other team should also come. என்ன சொல்றாங்க? They are supposed to be here by 2 o'clock, right? So we can just leave them and proceed. We'll see, we waited. The contestant should be here, right? Even if one person comes, we can start. Okay. Welcoming you all for Preethi Appalam Trauma Course and PG Quiz. So I'll briefly tell the rules of the quiz. We will have 6 rounds and each round will have different rules, and I'll be telling that as the rounds come by. The thing is that after 4 rounds, the bottom 2 teams will be eliminated. Those who have the lowest 3 scores, low 2 scores will be eliminated. So only 3 teams will move on to the buzzer round. Understood? The lower ranked 2 teams will be eliminated after 4th round. So it's just 4 rounds for everybody, so make use of the first 4 rounds. So shall we move on to the first round? All set? Scorer? All set? Okay. See, in all these rounds, instead of me choosing who gets which question, you will be choosing the cards. Okay? And whichever the card number you get, we'll be answering question accordingly. Suppose whoever gets the 1 number card will be attempting the first question. Please distribute the cards, please. So meanwhile, in first round, each question will be for 10 marks. There will be no negative marking. Passing question gets 5 marks. Okay, and time is only 15 seconds for you know it or you don't know it. So there is no meaning in wasting time. So just 15 seconds per question. Got it? It's clear? Next team. It's all for convenience sake. It always goes like this. Just as routine. Okay. No, it passes till it gets the first correct answer for 5 marks. No negative marking. Get it? So just a warm up. It's open. It's not for marks. So who can identify these 2 structures? Anybody? Just a warm up, not for marks. left or right? Okay, fine. So don't worry. These are anatomical structures which only experts will know. All the other questions will be the structures which you'll be seeing in everyday practice. Okay, just for just for completion, the structure here is the coracohumeral ligament. After removing the coracoacromial ligament, this is see, that is the upper triangular space. Okay, so just for warm up, the questions will be very easy. The idea of the first round is that everybody should get marks. At the end of first round, all of you should have opened the count. Okay. Now who has the first card? Okay. So team D, Hari, team D gets the first question. Okay. Your time starts now. Identify the circled bone. It's basic anatomy level MBBS question. Hamid, that's correct. So they get 10 points, Hari. Team D gets 10 points, okay? So that's the correct answer. So that's all the questions will be. So I want all of you to score marks. Who gets the second card? Team B. Your time has started. Identify the tendon. The clue is in the other picture, showing a common pathology the tendon gets affected.
EPL.
Please tell the full form.
Extensor pollicis longus.
Extensor pollicis longus. Are you sure?
Sir, there are two markings. Which one?
Pardon? Okay, it's not the correct answer, so question passes. Oh, sorry. Arrow has to come. So you get time again. I'm sorry. What is this tendon? I was not asking about the only tendon.
Abductor pollicis longus.
You want to say it is?
Abductor pollicis longus.
Abductor pollicis longus. No, it's not the correct answer. Question passes to team C, Hari. Please note.
Extensor carpi radialis longus.
Extensor carpi radialis longus is obviously a wrong answer because it is crossing the wrist joint. Team D.
Extensor pollicis brevis.
Extensor pollicis brevis is the correct answer. So team D gets 5 points. So what is the common pathology? I think everybody would have identified, no? Decurrent tenosynovitis seen in OPD every single day. So that is the correct answer. So team D gets 5 points. Okay. Who has the third question? Team A. Again, another very common pathology seen every day in OPD. Arrow comes in now. What is that muscle?
Anconius.
Anconius, are you sure? No, it's the wrong answer. So question passes.
It's tennis elbow condition, extensor carpi radialis brevis.
Okay, that is the correct answer. So team B gets 5 points. Okay, tennis elbow is a very, very common pathology you see every day in OPD. You should know the anatomy. So extensor carpi radialis brevis. So who has the fourth question? Team C, Hari, team C gets the fourth question. So identify this muscle. Again, the clue is in the other picture.
Extensor carpi radialis longus.
Extensor carpi radialis longus is not the correct answer, so the question passes. Team D.
Extensor carpi radialis brevis.
Extensor carpi radialis brevis is the correct answer. See, this is the same picture I have shown the previous image also. Extensor carpi radialis brevis, radialis longus, extensor digitorum communis. So it is the same picture. This is a dorsal Thompson approach. So the correct answer is extensor carpi radialis brevis. So who gets the fifth and the last question? Team E. Identify this structure as marked in the arrow. Yellow one, not the red one. Again, the clue is in the first picture.
Median now.
Median nerve is not the correct answer. The question passes to team A. If you are not able to answer, please pass instead of wasting time.
Radial nerve.
Radial nerve is the correct answer. So what is the approach we are seeing here? It is anterolateral approach to elbow, and radial nerve is at risk at this approach. Okay. So that finishes anatomy rounds. Hopefully you have learned 5 points from this round. So we'll have the marks here.
Team A, 5 marks.
Correct.
Team B, 5 marks. And Team C yet to open the account. And Team D from MMC, 20 marks. And Team E yet to open an account.
Okay. So this will be the scheme of the quiz, not some exotic lesions, what we see commonly. Okay. So the next round, can you please cut off the display for a minute? Add some spare questions in case of any trouble. Okay, we'll be moving on. Please connect the display. So the next question, again, please pass the cards, please. Please pass the cards. The next question will be on clinical examination. Again, small clinical examination which every one of you should know. And if you get the question correct, you will have another question based on the same answer. So you can get bonus points if you get the correct answer, right? You understood? The person getting the correct answer will have a bonus question for additional points. Understood? Okay. Who gets the first question? So Hari, team A gets the first question. Which nerve is being tested? He will have 30 seconds for each for this. The examiner is palpating the suprascapular region and he is assessing the external rotation strength. Which nerve is being tested here?
Suprascapular nerve.
Suprascapular nerve is the correct answer, so they get 10 points. So since you have answered it correctly, I have one more question for you. What is the common cause of a lesion in suprascapular nerve? This is the most common cause. Like 95% of patients with this lesion will have only this cause. Rotator cuff is not the correct answer, so the question passes for 5 points to team B. If they get it right, they'll get 5 points. Your chance is over. Okay, the question passes to team C.
Impingement syndrome.
No, team D.
When it passes through the suprascapular knots.
Okay.
The ligament.
No, what is the commonest? Team E. No, entrapment due to? No, that's rare.
Osteo.
No. The commonest cause is a ganglion cyst. Ganglion cyst is the commonest cause causing entrapment. So who gets the next question? Team D. Okay. So name this clinical test. This is for team D. So forearm is pronated and examiner is resisting the dorsiflexion.
Cosen's test.
Correct. So they get 10 points. So since you have answered it correctly, you have a bonus question. Give any two differential diagnoses. You are an OPD, you suspect a tennis elbow, and any two different, there are lots. Any two differential diagnoses. If you are taking time, please pass.
Bursitis. Bursa.
And? Okay, the question passes. Team E, your chance.
Inflammatory arthropathy.
Inflammatory arthropathy is rarely a... Team A. Tennis elbow, differential diagnosis.
Pronator arteries impingement.
Okay. Just one more, common conditions. Okay, I think I'll give the points for team A and we'll move on. Okay, there's a long list of different diagnoses. So what is this sign? as the child is attempting to reach to his mouth, there is an obligate abduction. Who gets this question? Team B. Team B. Okay. As the child is reaching for mouth, there is an obligate abduction. Again, a very common sign, entrance exam level question. That's UG entrance exam level question.
Blower sign.
Hornblower sign is the correct answer, so they get 10 points. So since they have got the right answer, there is one more question for you. Commonest tendon transfer to team.
Musculocutaneous.
No, common tendon transfer.
Trapezius to.
Okay, lower trapezius transfers, but still you can give it to them. So they get 20 points from this round. So who has the fourth question?
Team E.
Team E. What is this test? It had been discussed extensively yesterday. The examiner holds the arm in about 40 degrees of flexion with supination, and there is axial loading and valgus loading, and as the elbow is slowly extended, the joint gets reduced.
Posterolateral rotatory instability.
Okay, it's pivot test. You will give 10 points. So since you have got it correct, you have a bonus question. Which ligament is usually the cause?
Lateral ulnar collet. LUCL.
Lateral ulnar collateral ligament is the good correct answer. Avoid abbreviations. Okay, they get 20 points. So who gets the fifth question?
Team C.
Team C. So what is the muscle being palpated in this test? The examiner is assessing a power of a muscle between thumb and the index finger as the finger is being abducted.
Abductor pollicis brevis.
Abductor pollicis brevis, can it be? They are telling index finger, no? Question passes to team D.
Dorsal interosseous.
Okay, I give it to you. They get 5 points. So for bonus, you got to get another question.
Sir, 1 second, sir. The rotation can come this way also.
No, it's always this way. Or if you prefer, maybe next round we can have that way. If that's what you want.
Last, they are having more chances of passes.
Fine.
We
so
are not getting any passes.
Next 2 rounds will come this way. Got it? Okay. What is the nerve supply for first dorsal interosseous?
Median nerve.
Median nerve. Okay. The question passes to you.
Ulnar nerve.
Ulnar nerve is the correct answer. To be specific, it's deep branch of ulnar nerve. So now we have 2 rounds over. I hope you have enjoyed these 2 rounds. Can you please cut off the display for a minute?
Sir, you doesn't announce the marks for pass.
It will be done now. So meanwhile, I'm just moving off. Okay. See, I have spare questions which will be used in terms of tiebreaker. That's why. Okay. So Hari, you will have to tell us mark from this round alone and also the total marks. Tell me the scores from second round.
Scores for the second round. Team A 15 marks. Team B 20 marks. Team C yet to score, and Team D 15 marks, and Team E 25 marks. In total,
all correct? Okay. So tell us the total. You are okay with the marks of this round? So total, Hari?
Total of Team A is of 35. Team B of 25, and Team C yet to open the account, and Team D of 35, and Team E of 25.
Okay, all correct. So this round, the cycle is the other way. Okay. So here, before knowing the question, you have an option of doubling it. Okay, blindly. If you are confident, this is all classification from Campbell or Rockwood, etc. If you think you have learned the classification, you can choose to double it. Okay. So who gets the first question? Cards not displayed it? Okay. So before seeing the question, you can choose to double it. If you double it, you will get negative marks also if you get it wrong. Okay. The passing question, it's always for 5 marks. So who gets the question? Team B. So you think you know your classifications well? Have you learned? So you want to double it? No. Hari, they don't want to double the marks. What is this classification?
Rockwood's classification.
Rockwood's classification is not the correct answer, so question passes to team A.
Needs classification.
Needs classification, the correct answer. So team A gets 5 points. So who has the next question? Team 1. So you want to double, you're thorough with the classifications. You want to double? Team A has, Hari, team A has opted to double it, okay. What is this classification? Again from Campbell.
Schatzker classification of follicular fractures.
That is the correct answer. So team A gets 20 marks from single answer. So who has the third question?
Team D.
Team D. Do you want to double it?
Double.
Okay. Hari, team E chose to double it. What is this classification?
Mills classification.
Mills classification is only 2 types, no? Mills type 1 and type 2. So the question passes to team D. No, they get minus 10 points, team E. Team D from Campbell.
Sound classification.
No. Passing?
Jacob classification.
No.
Jupiter's classification.
No. The answer is V's classification. It's in Campbell only. Okay. So who gets the fourth question? You want to double it? Are you sure about your classifications?
Safe.
Pardon?
Not doubling.
You don't want to double it. Okay. So what is this classification? It's based on the mechanism of injury of distal fractures and helps in decision making also. It's just not an anatomical classification.
Henderson classifications.
Huh?
Henderson classification.
Henderson is not the correct answer. All of this from Rockwood only. The question passes to team C.
Rickman classification.
No. Team B. Team A.
Fernandez classification.
Fernandez classification is the correct answer, so they get 5 points. So who gets the fifth question? Team A 5. Who gets the fifth question? Team C. This again a classification of proximal humerus fracture. This has a practical significance. So what do these figures imply? What are these criteria?
Hurtle's criteria for avascular necrosis.
Okay, fine. They get 10 points. Right. So at the end of this round, who gets how many marks? So here, I'll display the picture even before, okay? The question will be based on that picture. If you think you have learned the topic, you can choose to even triple it, okay? You can get maximum of 30 also, but if whatever the marks you choose, you will get minus half. If you don't want to answer, you can just skip it, be safe, okay?
So at the end of third round, Team A scores 30 marks. Team B had to score. Team C has negative marks, minus 10. You answered one.
They answered correctly. They get plus 10.
Yes, sorry, plus 10. And Team D doesn't score a mark, and Team E also.
Team E got minus 10.
Minus 10.
Team E is good. So what is the total so far?
I will tally it.
Okay. So this round's marks you are okay. Still moving on. Okay. Who gets the first question? Okay. This is the image for you. You can choose either A or B. It's your option. Okay. And you can also choose how many marks you want for that. You can choose any one. But make a choice fast.
Yes, sir.
You want to answer about A. How many marks you want for it? How many points you want for it? 10, 20 or 30?
There is any negative marks for this?
Yes, yes. Whatever more points you score, if you get wrong, you will get minus half of that. You want to play for? 30. So you have chosen A and you want to triple it, okay? So What this, of course, you will know that it's aneurysmal bone cyst. What is a malignant lesion which mimics aneurysmal bone cyst in radiography?
Osteosarcoma.
No. What osteosarcoma? There are so many types, right? I cannot accept osteosarcoma as an answer.
Parasteal osteosarcoma.
Huh?
Parasteal osteosarcoma.
Parasteal osteosarcoma is not the correct answer. So they get minus 15 points. The question passes to team D. You will get only 5 points for it.
Osteogenic osteosarcoma.
No. Or we'll do one thing. Just for sake of cutting time, there will be no passes in this round. Okay. So who gets the second question? Hari, are you ready with the total marks? At the end of third round. So there will be no passes in this round, okay, just to finish it fast.
At the end of round 3, Team A scores
Telangiectatic osteosarcoma
65.
is the correct answer.
Anyway, we answered osteosarcoma.
No.
Team
Osteosarcoma
B
does not look like this at all.
scores 25. Team C total score is 10. Team D is 35. And Team E is 15.
Okay. So who gets the second question? Team C? Okay. What do you want to choose and how much? You can also skip it if you don't want any negative marks from that. Or whatever marks you choose, you get half of that at minus. Which one do you want to answer?
B.
You want to answer about B. Okay. And how many points for you? 10, 20 or 30? 10 points. Okay. So what is the lesion? B. What is the lesion seen in the X-ray B image? Pardon? A pathological fracture is there, but that's not the answer. There's this metabolic bone disease.
Hyperparathyroidism.
No, that's not the correct answer. So you played for only 10 right, so they get minus 5 marks here. Who has the third question? So the answers are oleostesis and pycnodysostoses. So which one do you want to choose and for how many marks? So at the end of this round, 2 teams will be eliminated, so play accordingly. You choose A, okay. For how many marks? For 10 marks, okay. What is the dominant cell type implicated in the pathogenesis?
Fibroblast.
Can you be more specific?
Fibrotic strands, fibroblast.
No. It has myofibroblast is the correct answer. So they get 10 points and they've just chosen to add on. So who gets the question number 4? Team B. So what do you want to answer about? Figure A or figure B?
Figure B.
Figure B you want to answer about, okay. Sorry, and how much do you want to, for 10 or 20 or 30? 30, okay. So what is the significance of seeing these findings? They have chosen to go for 30.
Hyperlaxity.
Okay, so hyperlaxity?
Generalized ligament laxity.
Okay, and name only one condition where your decision making will be altered? Whether you want to do surgery or, you see this, and any one condition where your decision making regarding surgery is different.
During ligament ACL reconstruction.
Okay, and also recurrent shoulder. So you can give 30 marks for them. Okay, so who gets the last question? Team D. Which one do you want to take up and how many marks you want to play for? Can be fast, no? You're running out of time.
We'll skip.
You want to skip it. Okay. So that's the end of this round. So the question is, what is the ideal method of fixation for GT fractures for type A, and which bundle is for most vagal stability, and these are the answers. Okay. So the bottom two teams, no sir, there will be only 3 teams. No, it's only buzzer round.
Last round passes has not been given, sir.
Pardon?
Passes. Last round has not been given.
There were no passes.
First 2 rounds, the passes are going this way. That
See, in quiz it happens, no? Sometimes you're lucky. I didn't tell you to sit here.
Yeah.
You chose that yourself.
The thing was according to the lot that you chose. So it is equally divided. It is just randomized.
Even the questions you get were out of random, no?
You just choose a pass, and we are just going.
Hari,
through
can
it
we have the scores and we have 3 contestants to proceed?
The final score of Team A is 75. Team B is 55. Team C is 5. Team D is 35. And Team E is due to minus 15, it's 0.
Okay. So who all are qualifying for the buzzer round? 3 teams, top 3.
Team A, Team B, and Team D is qualified for the next round.
Okay. So Team C and Team D are eliminated. Thanks for contesting. Best of luck. Okay. So buzzer. So I will need a spotter because we don't have a buzzer here. I need a spotter to say who raised their hands first. Okay. We'll have 5 questions for these three teams. Correct answer gets 20 marks. Wrong answer, it's minus 10. Okay. There are no passes. Total 5 questions. Okay. After this round, only the top 2 will get to the next round. So go accordingly. Raise the hands. Okay, and they'll be watching who raised the hands first. In case of mismatch, you'll see it. Okay. And the interesting thing is that all the questions from this round were from yesterday's talks only. So if you're attentive in yesterday's class, you should be ready to raise the hands. Okay. The first question, are all the contestants ready? Okay. What is this implant? Team C was the first. Team D was the first.
Multilocking humerus nails.
Okay, so they get 20 points. That's Team D, not Team C. Okay. They get 20 points. Okay. So moving on to the second question. Is everybody ready? Okay.
Team
B. Team B was the first.
It's L. Prakash and Miro system.
Can we give it to them? Because I thought it is a different frame. It's not L. Prakash frame, right? That's Miros. It's not Miros. So they get minus 10. It's Solapur frame. Yesterday was a big talk, no? Okay, fine. So ready for the third question? Ready? So this is a Solapur frame. And ready for the third question, okay? This again from yesterday's talk.
Team B.
It was B? Okay, fine.
Intra-articular lateral elbow hinge implant.
Internal fixator. We'll give it to them. Okay. 20 points for team B. Are all of you ready for the next question? Ready for the next question, right? Team D was the first.
Kaplan's lesions.
Yes, Kaplan's dislocation. Okay. So, ready for the last question of this round? Only in case of a tie, we will have some more questions, okay? If there is no tie, this will be the last question. Okay. What is this grading? Team D. Okay, so you get the
Zoom grading for radius plate.
Zoom grading. Okay, fine. So that's the correct answer. So did you all learn it from yesterday or you before only? Yesterday, all the questions. Kaplan, you know before. Okay. So they have been attentive. Okay. So what is the results after this round? Can you just cut down the screen, please, for a moment? So top 2 teams will go for rapid fire round.
Team A, total score of 75. Team B, 65. And Team D, 95.
So which 2 teams qualify for the...
So Team A and Team D qualifies for the next round.
Okay. Team A and Team D for the next round. Okay. Can I have the pass of cards, please? Pass of cards 1 and 2. Please pass the cards. So in rapid fire, we'll have 10 questions, but you'll have at the most of 1 minute to answer. So if you answer it fast, you will get more questions to answer. Okay, all are simple, straightforward questions.
Each team 10 questions.
Each team 10 questions. That's rapid fire, right?
Okay.
You will choose which set of questions by yourself. Who gets the first set? You get the first set. Okay. Can you have the timer for 60 minutes? Yeah. You cannot come back and all. You can pass it, think over it, give the correct answer. No negative marks. Okay. Each question 5. I'll just count the number of correct answers here. Okay. Due to save time, I will not be telling the correct answers also, just to give more time to you to answer. Okay. Shall we start? Timer starts now. Yes. What is the surgery depicted here?
Latter J procedure.
You get 1 correct. What is the instrument shown here?
Pass.
Pass. What is this view?
Axillary lateral.
No. What does this picture show?
Radial nerve tendon transfer. Jones wrist tendon transfer.
Jones transfer, correct. What is this sign called?
Terry Thomas.
Correct. What does this MRI show?
Supraspinatus.
Correct. And what does this show?
Glenoid bone index.
Okay. What is this implant?
Reverse shoulder.
What is this test called?
Card test.
Not card test.
Sorry, Froman sign. Book test.
Okay. What is this pathology? X-ray showing.
Pass.
Pass. Okay. So they got. They still have time, right? Time over. So you get only 6, even though rheumatoid arthritis is correct answer. So they have got 6 answers correct. Okay. I'll come back and say which 6 is correct for you. Okay. So now we'll move on to the second team. Okay. You are ready? Shall we start the time, please? What does this show? All are from Cambridge.
Capsule plication.
Okay, capsule shift. We'll give it to you. What is this instrument?
Pass.
Okay. What is X-ray view?
Valve views.
Okay. What is this procedure shown?
Rim research.
No. What is this pathology shown? Mark, keep a note on time, please.
Avascular necrosis.
Off.
Unit.
Okay, 3 correct. What is the pathology shown here?
Bankhart's lesions.
Okay, I'll give it to you. What does this depict?
Glenoid track.
Okay, 5 right. What is this implant?
Reverse.
Time out. So what is the score in this? So if there are no tie break, this is the end of the questions.
Team A scores totally 6 questions and Team D of 5 questions.
Okay, so what is the total mark? Do you have a clear winner or is there a tie?
Just a minute. Clear winner.
Okay, fine. So I hope all of you enjoyed. I have a lot of questions. So due to lack of time, I'm just skipping the audience questions, sir. We have 10 more talks to go. So this sign? Benediction sign, okay. What does this X-ray show? Osteoarthritis. If I have time, I'll just show the questions. So this classification was discussed yesterday. Double is classification. What are these lines? Anybody? Gillas lines. What is this view called? Zanka's view. What is being shown here? Lateral collateral ligament repair. And what is demonstrated here? VC. Okay, fine. So I invite the scorer to announce the result, and I hope you all enjoyed attending and learned everything from Prahalad sir and Professor sir for giving me the opportunity. Thank you. it was in fact a very close contest. The team got 145 and the losing team got 135. Given all the combination permutations, they could have been either way. So it is just a matter of playing. So the second place was the team from Preethi Hospital. Great, sir. And the first place was from Madras Medical College.
Yeah, now we will continue our pediatric session. And we invite our chairperson, Professor Ghulam Mohiuddin sir, Professor N. Manikandan sir, and Dr. Gopi Manogar sir. We request Chidambaram sir, Prahalad sir, or Sivakumar sir.
Ashok, please.
Don't throw away the cast. Yeah, good afternoon, and we are starting the post-lunch session. So, yeah. Now I will try to be very crisp now. So from yesterday, actually what we are discussing is various types of fractures and how to fix, using which implants we should fix. All those things have been described. But suddenly such a talk is coming. Don't throw away the cast, otherwise conservative management of pediatric forearm fractures. Just yesterday night I was discussing with Dr. Kailash. He was showing me this case. See, this is an 11-year-old boy, fall on an outstretched hand. He sustained a both bone distal forearm fracture. So the initial close reduction X-ray was this. Now, the treating surgeon, he didn't attend the Preethi trauma update course. So what he thought, that this is completely translated, so it is 100% displacement, you should go and operate. So what he did is, he did some, I think, open reduction and K-wire fixation. And what do you think will happen now? Will it heal? It went for non-union, it went for deformity. So as Premal sir properly just mentioned previously, the only way a distal fracture is going to go for non-union is when you intervene. Actually, there are papers which show that such a deformity can be left untreated also. It will remodel very well. I want you to all go and read this article. This is a well-written article on the non-operative management of pediatric upper extremity fractures in the same topic, don't throw away the cast, by Professor K.E. Wilkins. So we always say children are not small adults. See, in adults, we think the forearm is a joint, you have to always fix the forearm fractures. But in children, more than 80% of these fractures can be managed conservatively because they have excellent remodeling potential. Also, these children's bone are more porous and soft. So the adult bone will fail only in tension. The children bone will fail both in tension as well as in compression. So there are special fracture types. So before that, we should know the muscle forces which are acting in various parts of the forearm. The proximal third is the supinator and biceps territory. The middle third is the pronator teres territory, and distal third is pronator quadratus territory. This is very important. The fracture types of children, first is the torus or buckling fracture. Second is the plastic deformation. Third is green stick. And finally, the complete fracture as seen in adults.
A torus or buckle is nothing but a periosteal buckling due to compression. They even say that there's no need to cast them, just give a splint and give analgesics and send them off. Within 3 weeks they will be normal. And when the strain increases, the next stage is the plastic deformation. This is a special fracture which we see only in children. See, there is no fracture line visible, but the entire bone is deformed, it's curved. This occurs because of multiple microfractures throughout the bone. Should you fix the plastic deformation? There are certain criteria. If the child is more than 6 years age, if there is more than 10-degree angulation with visible deformity, resection of pronosupination, in these conditions, you have to intervene. So though it seems innocuous, you actually need anesthesia to reduce this, because you have to give sustained pressure for 2 to 4 minutes. Around 100 to 150% of the body weight of the child has to be applied over a fulcrum. So this needs anesthesia, and once you reduce this, you will get put in a cast. The second stage, as the strain increases on the bone, now the tension side fails. The compression side is still intact. This results in the green stick fracture. If both the bones are fractured in the same level, there is only a bending violence, there is no rotational violence. But if both the bones are fractured in different level, then you should always think there is a rotational force involved. Now, depending on the apex of the deformity, you can identify which sort of force. If the apex is dorsal, it is a pronation injury. If the apex is volar, it is a supination injury. Now, how to treat this? Actually, Evans in 1951, he described this in JVGS. So, if the apex is volar, the supination injury, you will just pronate to reduce. If the apex is dorsal, you supinate to reduce. But again, volar, pronation, we may get confused. So, Noonan and Price, in their article in Journal of American Academy of Orthopaedic Surgeons, in 1998, they told about a simple method. You just rotate the palm towards the apex of the deformity, and you will correct this. Now, typically in our UG and PG, we were taught that if it is a green stick fracture, you have to complete the fracture. Here I am telling you just derotate it. So, see, the advantage and disadvantages are, in osteoclasis, if you do, you are completing the fracture, there is a wide surface area of the fracture, exuberant callus will be formed, refracture rate is less. But the rate of displacement, recurrence of the deformity is around 25% when you compare with just 10% in the derotation. So, nowadays we just derotate. How to identify whether there is a mall rotation after putting a cast for green stick fracture? There is something called as radius crossover sign described by Price again in 2012 JPO. When the arm is in supination, forearm is in supination, there is no crossover. When the forearm is in pronation, the crossover is proximal. When the forearm is neutral, the crossover is distal. Now let us take a case example. What do you think? Whether this case is properly reduced or not? Now simply what you have to do, split it into proximal and distal parts. When you see the proximal part, it looks as though it is in pronation. The distal part looks as though it is in neutral. It means the rotationally it is small aligned. Now coming to the complete fracture, the treatment plan of the complete fracture depends on various factors like age of the child, time since injury, displacement level, stability and type. Now Price has described this acceptability criteria depending on the age, first less than 9 years or more than 9 years. If it is less than 9 years, more amount of angulation, 15 degrees can be accepted, mal rotation up to 45 degrees can be accepted. If the child is less than 9 years, usually 10-degree angulation accepted, except in distal most fractures where you can accept a bit more angulation, and rotation up to 30 degrees can be accepted. But 100% translation is acceptable, bayoneting is acceptable, provided that the overlap, the shortening is less than 1 centimeter. What is the effect of angulation in the arc of motion? Actually, the radius rotates around the ulna in an arc. So, when there is an angulation of around 20 degrees, there will be more than 30% loss of rotation arc. Now, we'll go for reduction technique. If there is a severe edema, kindly wait. Put a slab, elevate the arm, wait for 40 to 70 hours till the edema subside. Then again under anesthesia, you have to exaggerate the deformity and walk it along the distal fragment, and then you will lock it and you can put the cast. Casting technique is the most important in the entire conservative management. See, you have to apply proper padding. You should not apply over padding or under padding. If there is over padding, the elbow is not even placed properly at 90 degree, then the cast will become bulky and the so-called banana cast. You have to apply a very snug fitting cast, and also you have to give proper molding. The 3-point molding as well as the intraosseous molding. And as ulnar border has to be maintained in a straight way. You can use either a clipboard or you can use a ruler to maintain the ulnar border. And if there is an edema, you can bypass the cast, and after 3 days you can complete the cast. There is something called as cast index. This tells you whether your cast is good or not. If your cast index, it's nothing but the inner cast diameter in the lateral view divided by the AP view, it should be less than 0.7. Now, sometimes in a very young child, less than 2 years with a short stubby forearm, then you will not be able to put the cast in flexion because it will slip, the forearm will slip within the cast. In such cases, you can do a extension casting with proper supracondylar molding. And also, you can include the thumb in all the casts because after some time the edema is going to set in and the thumb will going to get compressed by the edge of the POP. So it is not for stability, it is for preventing the pressure, so you can include the thumb in the cast. How to assess the reduction in complete fracture? You have to see whether the radial bow is maintained. As I told, 1 centimeter shortening, 100% translation is acceptable. Angulation as per the price criteria. Rotational malalignment is poorly tolerated. How to check the malrotation? Simple. The radial styloid and the bicipital tuberosity should be around 160-180 degrees opposite to each other. In full supination, the bicipital tuberosity will be medial. And then in the neutral position, it goes posterior. And then in the pronation, it comes lateral. So you have to follow for compartment syndrome. The cast edema subsides in third day, you take an X-ray and complete the cast. Weekly, you have to take check X-ray for first 3 weeks because most of the times within the first 3 weeks, due to the subsidence of edema or some other reasons, there may be re-angulation. If something happens, you can even re-manipulate and recast. In 20 to 40% cases, it is necessary. And average, you have to immobilize them for 6 weeks. Finally, if there's a mild deformity in a uniplanar apex is there, less than 5 degrees can be easily corrected by so-called cast wedging. What you have to do, you have to open a wedge closer to the apex of the deformity, and this is a simple non-invasive OP procedure you can do. So finally, take home message, close reduction and casting is the gold standard even now for children's fracture, except few indications which next primal sir will be telling. And reduction should be done under anesthesia. You have to derotate the green stick fracture. Always keep in mind about the acceptability criteria and always check for the proper reduction in the post-casting X-ray. Good casting technique is must and follow-up X-rays should be done. Thank you.
Premal sir, please.
My job has been made very easy. So let me show you some cases. It is just going to be reiteration of the basic facts which have been told to you. So let's start with the story. 2-year-old, and this is an injury film. I know it's not a very good picture, but what do you think you want to do here? How many would just give a plaster on OPD basis? Just raise your hands. Okay. How many we want to do full POP on OPD basis? Okay. Close reduction and plaster? Okay. And IM nailing? Nobody. Okay. This child was treated like this. Sorry for the film. This is how the plaster was removed. And he came to me with cubitus varus after 8 years. Any guess what is happening here? Cubitus varus in a forearm fracture. We are running late, so I'll just show you that ulna had gone for non-union. And do you know what the cause is here? Anybody? Any guess? Open reduction. As I told in the morning, majority of the non-unions are related to operative intervention in pediatric forearm fractures. So this is a paper which shows ulna non-union, majority it was open, and here also this paper also says majority is the cause is the open reduction. So operative treatment is on increase because parents are demanding to us. We are not comfortable doing plaster treatment. We are not able to explain the parents once the angulations are there in post-operative X-ray, and people don't pay us well if we do not put any metallic implant in our practice. And this all as combination has led us to do more and more operative. So 9-year-old, isolated radius injury. What is your choice? Anybody ready to give plaster on OPD basis? No. Close reduction and POP? Isolated bone. Only one person. IM nailing? Okay. And plating because of single bone fracture? Okay. So this is what I tried doing close reduction, but this is the best I could got, and the moment I got it to length, it used to angulate. So ultimately I accepted this, and Ashok told, I had attended Ashok's lecture earlier, he said that things will remodel, and it did remodel, and this is the functional result. And it tells us to say that you do not need to open a forearm bayonet reduction if it is less than 1 centimeter overriding. Contrary to this, let's look at this 6-year-old male. This is the injury films, and this is how the child came to me on day 2. This is the angulation. What do you do? This child was asked this doctor parent were asked to come go for re-reduction and plastering. They refused. Child came back after 6 weeks with union with a 30-degree angulation, and at 1.5 years they still had a persistent 20-degree angulation because the angulation criteria described by Rice Charles were not followed up. This child did not have much functional problem, but if you can look at his right side, the pronation is definitely restricted. But fortunately it is forgiven because God has given us enough amount of abduction to compensate for the pronation. So mid-shaft fracture, you cannot accept angulation beyond the limit which Dr. Ashok already mentioned. But if it's a translation, it looks really bad to the parents, but if you can convince them, you can continue with a conservative treatment, and ultimately they will bring you 2 more patients and it will be financially also lucrative. So 8-year-old male, fall on outstretched hand. This is the post-operative picture. How many of you are ready to accept this? Yes. How many want to re-operate this case? Yes. Why, doctor? Why you want to re-operate this? Sorry? Proximal? But at this point of time it is aligned. How are you sure that it will in future it will happen like this? Okay. So this is the post-reduction film. If you look at the film carefully as taught by Dr. Ashok, you will see that the radial tuberosity is seen here, but the styloid is not seen there. So this is a 90-degree malrotation, and here you can see the radial styloid. You do not see the radial tuberosity in the same film. Right? So this has been already told. So I will not reiterate. So this is the post-reduction film of re-reduction film. Will you accept this or not? I have done it. Who dares to say I will not accept? Anyway, so now we have got the rotation right. Don't look at only the fracture side, look at both sides, and this is the function on the follow-up. What you need maximum rotation. If you get the rotation right, the rest of the things will be taken up by this. Most important problem which causes, we take a very small X-ray. Elbow and wrist are together, and that is why we miss sometime rotational malalignment. 12-year male presented with this type of fracture. I think this is a indication where you can go ahead and do nailing, because more adolescent children, the outcome is like an adult. What you need to take care is take a posterolateral entry from ulna, keep the distal end of radial nail proud above extensor retinaculum, respect the radius distal radial physis, maintain the radial bow, and maintain the interosseous spread. If you do this, you're going to get good results. You all do more nailing than I do. I don't need to teach you anything beyond this on this topic. This child, another most important thing, we all have started using 10 nails, and I have in my more than 70% of the fixation, I still use K-wire, which cost about 45-50 rupees, and it gives equally good result. There is not a single paper which tells me that 10 nail fixation with its pre-bending gives a superior result compared to IM K-wire. This is the functional result of the same child. Somehow he remembered to get the nail done after the COVID and everything was over, about after 5 years. So 3-year-old son of a pediatrician whose uncle happens to be my postgraduate student. He had a fall like this. He put it in a plaster after looking at IITV, removed the plaster and never took a follow-up. Child had a fall again after few months, broke this. And this how was the deformity. How many of you would like to operate this child? Because now this is a refracture within 4 months of the first injury. How many would like to give plaster? Please raise your hand. Okay, and how many would like to refer to Preethi Hospital? Please raise your hand. Okay, there are few hands, good. So, Dr. Shiva, I am doing my job well. So this is the best position. Yes, will you discharge the patient? Or you would do something to the radius? Wedging, but this is under anesthesia only right now. See, this is IITV films. Couldn't get better. 1 week later, ulna also displaced. You see, I gave a plaster with bored. You can see very straight ulnar border there. But even after that swelling got down, so now what? Yes, Vidyasagar, you want to say something? K-wires. Okay, you have at least gone one scale down from 10, so you have come down to K-wire. Okay, if you stay with me, I'll stop you operating. So what I did was, what Ashok told me, you can do that. I did a waging here. Now we got a reasonable alignment with radius and ulna. That's 5 months later. And this time I protected the child with a brace because this was a naughty child. There are papers saying that green stick fracture tends to refracture more than complete fracture, and you should use brace. And this is the 2-year follow-up of the same child, this excellent remodeling. So when you get forearm fracture next time, well-modeled plaster is an art forgotten. We need to relearn that. And if you do not get it on first attempt, 1 week later, you still have a second chance where you can do wedging and correct and still continue with your conservative treatment. Nailing is a good option for older kids and in some special situations like OI or pathological fracture. But do it well, follow them up till complete union, document radiological union, especially if you have done an open reduction. And K-wires do work very well. TENS is not must. And be ready for occasional surprise as I have shown you. Thank you very much for your kind attention, and thank you very much for my invitation here. I have loved, I have come here for the third time. Thank you very much once again.
Thank you, Dr. Premal sir. We now call upon Dr. Rudraprasad sir for giving his talk on distal radius fractures, what is acceptable, when to operate.
Okay. Yeah, I think it's more or less the same repetition with the 2 talks what we had now, because forearm, distal radius, everything boils down to the same thing. And I think with this, I think we'll be sending a strong message on conservative management. So my objective is to discuss on when to operate on these distal radius fractures. Okay, now let me put it this way, when to operate, and then later I'll discuss the ways of conservatively managing it very well. Again, this is the same thing, repetition. So when do we operate? A very few indications for a distal radius fracture, not many. So when you have done an open reduction, when a fracture is open, there is a compound injury, and there is very unacceptable alignment is there. Probably that is the best situation. And then the fracture is very unstable, especially when there is associated distal ulnar association or distal radio-ulnar joint association. And coronally and rotationally, it is very much malaligned. It is not acceptable. So sagittal plane deformities, any amount of deformities can be accepted, like the way we discussed about bayonet deformities. With the shortening of even up to 1 centimeter, it can be accepted. So it has been found by many research that if there is a distal ulna is associated with the distal radius fracture, they tend to be little unstable. You can try to manage them conservatively, but keep it in mind that then this can be an unstable situation. And this is a bayonet fracture, same thing, bayonet displacement. This can be very much accepted. And as discussed by the previous speakers, that it's very important that, that we understand these fractures with respect to the alignment and other things. But whatever said and done, the maximum growth is given by the distal radius. It's about 90% of the forearm growth is coming from the distal portion, that's around the wrist. So the casting guidelines are stressed very well. I don't think so I have to go back. I think this is one area that we have to give importance, because a good cast can keep whatever deformity correction you have done very well. A casting index has been stressed already very much. And this is the same thing, again, Dr. Told in the earlier talks. They are very much inherently stable. There's torus and buckling fractures. Smaller kids, I don't put anything, not even an arm pouch. I just tell them, don't touch that area. Probably within a week or 2, they unite very well. At the most, you can give an arm pouch. I don't even put them in a plaster cast. They're quite stable. So when you're treating, if you observe this kind of an angulation, you still don't have to worry, because as I said, there is a remodeling potential so much. Younger the child, better is the remodeling. So the same fracture, you can appreciate how well it is remodeled over weeks. Very, very fast, even though they keep complaining that there is a deformity, what we have to do is just reassure the parents, tell them that it's going to be fine. And functionally, the kids will be fine. It's only the parents who are quite, worried about the deformity. A few things about the physeal injuries. Again, we do see, physeal injuries in the distal radius. It's about Salter-Harris type 2 is the one which is commonly involved. And if they come immediately, obviously we all do a close reduction and casting. And of course, morning we discussed with Dr. Vidyasagar's case about the vascular injury, nerve injuries which may be affected very rarely in the distal radius, but median nerve is one thing we have to look into in case of physeal injuries, because quite a bad deformity it produces. So non-displaced fractures, these physeal separations, you can definitely put them in a cast. You don't have to do anything. Displaced physeal fractures, you should go undergo a close reduction, preferably under anesthesia. And most of the time they fall back. And up to 10 days probably. I mean, of course, these are all the periods which are described by each person in a different way. What we do is up to 2 weeks. We try to do it, but most of the time what I practice is more than a week. I tend to leave them alone. I don't do any manipulation. And I think with manipulation we'll be causing more insult to that area. And again, up to 50% of the malalignment in the 50% of contact is enough in the physeal injuries. You don't have to. If there is 2 years of growth remaining, that is sufficient. That the fracture remodels very well. So residual angulation greater than 20 degree will normalize substantially, but not always completely. So that we have to keep it in mind. There is some amount of a deformity may be remaining, but they don't cause much disability or any problem. So this is again the same example, physeal displacement, what we see commonly. These kids, especially when they come late, we don't do anything. Again, because of the fact that the distal radius contributes maximum to the growth and it remodels very well. The same with the remodeling. And again, distal metaphyseal fractures, again, they do very well if they are not with the distal ulnar fractures or a distal radial ulnar joint that often. But if there is a metaphyseal fragment, quite a good amount remaining, probably you can consider for a fixation if they are unstable. Otherwise, still these can be treated with the close reduction. Bayonet, as I said, they can be managed. Very rarely you may have to do a K-wire fixation. And one message is never cross the physis. Again, we all have learned about the K-wire fixation with the distal radius in adults, but in children, even this physis is contributing so much, the physeal scarring can lead to a very bad deformity. So there are ways of reducing this bayonet fracture with the minimal displacement. Both can happen, volar and dorsal. The same way considerations can be done. So I think this is the same message what I am giving. These are the fractures which are treated by K-wires, but make sure that if at all, if there is a situation you have to treat them with a fixation, make sure that the physeal plate is not insulted, because these are the growth plate disturbances which can result, and that requires a bad prognosis and then some other approach. To conclude my talk, this management is most of the fractures, avoid fixing through the physis. Above elbow, if depending on the age, and physeal injuries more than 10 days, better to avoid any kind of intervention. Operative intervention is used when only open injuries are in different situations.
Thank you. 1 minute, Ishwar. We'll felicitate Peramal sir and Rudra sir. They need to take the flight. And Peramal sir, we enjoyed you much and for the non-stop your inputs.
We request Chidambaram sir to felicitate Rudra sir.
And Sivakumar sir, please. Dr. Ishwar, please. Harish. Yeah. Dr. Harish.
Sorry for the reshuffle. We all three are going in the same flight. So I'll just give some tips on how to avoid pitfalls in managing and diagnosing, especially Montegio fractures. So we need to understand the forearm as a joint, the concept of forearm as a joint, which is formed by the radius and the ulna. So there are two bones with 5 joints and 8 movements occurring between radius and ulna at the forearm, at the elbow as well as the wrist. So if any break in the continuity of this as a joint can lead to disruption of the orientation of the radius and ulna and adjacent joints as well. So you can see this fracture here of the ulna. So if you see the fracture of the ulna, you see that the radius also is dislocated. So two important lines is we have to remember when we are seeing a forearm fracture, especially when you suspect Montegio fracture, the ulnar bow line and the radiocapitular line. So the ulnar bow line, the radiocapitular line is morning what we saw. If you draw a line along the proximal radius, it should point to the center of the capitulum in whatever degree of flexion the elbow is. And another line is the ulnar bow line described by Lincoln and Mubarak. If you draw a line from the proximal metaphysis to the distal metaphysis, so there should be less than 1 mm of deviation. If there is any deviation, that means there will be an associated disruption of the proximal radial ulnar joint. So you see there, there's a radial head dislocated. So what we see a isolated radial head dislocation actually is a Montegio lesion here. Okay. So where do pitfalls happen, especially in acute ones? The borderline diagnosing borderline Montegio lesions and its variants, we tend to miss the lesion as such. And at the time of treatment, inadequate reduction of or fixation of the ulna can lead to inadequate reduction initially, or if the fixation is inadequate, subsequent displacement can happen. That's what I call it as a gradual displacement. So all these can lead to chronic Montegio lesions, which is much more difficult to treat compared to acute setting. So I'll just touch on acute Montegio lesions. We know the Vados classification. So type 1 is more common compared to an adult, where type 2 is next common. In children, type 3 is more common. So we need to remember these modifications and the variants of these Montegio lesions. I'm just running through because of short of time. So the Montegio equivalents, what we call isolated radial head dislocation or associated fracture of radius and radial neck fracture. Okay. So this type 4 variant was described by Professor Wilkins. So there's a segmental fracture of the ulna along with a radial neck fracture. So it was treated with an intramedullary device. Okay. So as I said, you have to remember two important lines: the ulnar ball, the ulnocapital, what do you mean? The radiocapitular line and the ulnar bow line. So if there is any disruption, that means there's a Montegio lesion. So these different variants of Montegio lesions can happen. Okay, so the different variants, and you can see the equivalents as well here. So we need to be able to pick up all these things and treat accordingly to prevent chronic Montegio lesions. So it is the character of the ulnar fracture rather than the direction of the radial head dislocation which directs the optimal treatment of these Montegio lesions. Okay, so a stable anatomical reduction of the fracture results in anatomical reduction of the radial head. So this is what forms the basis of treatment of all these Montegio lesions. So what is the best treatment? So simple, if it's a plastic deformation, you correct the bowing under anesthesia and do a casting. So you don't need to specifically reduce the radial head. Once you correct the ulna, the radius falls back in place. So if it's a green stick fracture, again do a close reduction, and the radial head will fall back in place, and you do a good casting. So whenever there is a transverse or a short oblique fracture, you can put an intramedullary device. Only if it's a long oblique or a completed fracture, you need to stabilize with a plate. Okay. So type 1, you correct the bowing. This is what, especially when there is a plastic deformation or a green stick fracture, you correct the angulation, the radius falls back in place, and you can put a cast in with the forearm in supination and elbow in hyperflexion. Only problem with this cast treatment is when there's a setting of lot of swelling, you will not be able to hyperflex the elbow because of the swelling, which can lead to vascular compromise and compartment syndrome. So type 2 lesions are reduced and immobilized in extension. So type 3 lesions, you correct the varus deformity, radial head will get reduced back in place, and you put a cast in a neutral position. So when treated in a cast, as I said, there's a tendency for redisplacement. This is because of the pull by the muscle forces. See, you can see this illustration. This is actually by Professor K. Wilkins. You can see initially it was aligned well, then gradually it started to angulate laterally, and radial head started to lateralize. So here the ulnar fracture was, osteoclasis was done, and intramedullary fixation was done, and the fixation was stable, and radial head, you can see that it's gone back to its position. So what happens in a cast is the ulna can get angulated posteriorly by the pull of the triceps, and there can be radial deviation of the ulna by the pull of the common flexors. So this can gradually displace the radial head anteriorly or laterally. So solution is a well-mounted cast, and if you think there's a lot of swelling, you need to go back and recast the child after assessing after a week or so after the swelling subsides. Other solution is to put an intramedullary fixation. So the aim basically is to provide a stable ulna. If the ulna is stable, the radial head will be located. So this is a type 1 variant in a 11-year boy. You can see the proximal third shaft of the radius along with radial neck fracture. What we did was, because I had to restore the restoration of length and alignment of the ulna is very important. Once the moment you see, I just put one screw on either side, the ulna was stable, the radial head was back in its position. We just supplemented it with a intramedullary wire. In subsequent similar case, I didn't even use the intramedullary wire, it was quite stable. Okay. So this went on to heal well. So a good outcome for Monte in a Monteggia lesion in children requires early diagnosis and stable anatomical reduction of the ulnar fracture. So take home message is, do not miss an acute Monteggia lesions. Simple is, you take a full forearm X-ray and draw those two lines. And we have to identify the equivalents of plastic deformation where it can cause isolated radial head dislocation. And key is to restore the length of the ulna and alignment of the ulna. Thank you.
We request Venkatesh Babu sir to felicitate Harish sir. Sagar sir. Prahalad sir to felicitate Vidya Sagar sir.
Now like to call upon Dr. Ishwar sir to give his talk on radial neck fractures. Which one needs surgery?
Oh, I'll just briefly touch upon various aspects of radial neck fractures. Adobe தான் போடும். So we'll just go over the various subheadings as described. So you have to remember that radial neck fractures are basically Salter-Harris fractures. So they are either variants of Salter 2 or Salter 4 types, and or completely metaphyseal. Most of them are because of the valgus overloading. The child falls on an outstretched hand with a valgus overload, and the radial neck gets fractured because of the valgus force. And they may be associated with a medial side fracture, a medial epicondyle fracture. And also the radial head and neck doesn't have any ligamentous attachments. So it's just surrounded by the annular ligament, but they are not having any attachments. And quite often these injuries, especially if subtle and if non-ossified, are missed and are picked up in retrospect. And much of the neck, the metaphyseal part, is extracapsular. Some of it is intracapsular, but some of it is extracapsular. So the fracture itself may not cause any noticeable swelling, and many of it gets passed on as pulled elbow. We need to consider this, and we need to detect it because the proximal radial ulnar joint has got a very sensitive center of rotation. This fracture disrupts that center of rotation. So you can see in this figure here, it is actually an eccentric center of rotation. So if this malunites, this rotation won't take place properly. So that will affect the forearm rotation. Ossification is around 3 to 5 years of age, and many often fragmented or bipartite ossification centers are observed, and it fuses with the shaft very late. And that is good news because there is a longer remodeling curve for these fractures then. So there are two ways to look at it. Classification wise, we can use, one is the Chambers method, which is less commonly used, which is dividing these fractures into 3 groups. So this is based on the displacement of the radial head, and also whether the injury occurred during a dislocation or during relocation of the elbow. Sometimes it is associated with a dislocated elbow. So sometimes as the elbow dislocates, the radial head neck gets fractured because of the valgus force. Sometimes as somebody is trying to reduce the dislocated elbow, the radial neck can get fractured. Group 2 is associated, and it's like a Monteggia type lesion, a Monteggia type 3 variant, and that's also associated with ulnar fractures. And group 3 are the assorted injuries. They are a bit like the thrash lesions. They are like the OCDs and physeal injuries. This is the most commonly used classification, the Judet classification. And Judet classification, for simplicity's sake, you can just imagine this to be the dividing line, the watershed line between what is acceptable on this side is conservatively acceptable. Anything more than 30 degrees or that side is requiring some form of intervention. So 30 is the rule. 30 degree and 30% translation is the approximate rule at which you have to decide to intervene. So conservative treatment, the outcome is to restore the center of rotation as much as possible and ensure that the radial neck is somewhat stable inside. So as I said, 30 degree angulation and 30% translation. So 30-30 rule is all you have to remember as far as the radial neck is concerned. So there are a number of techniques which are described. So the essential features are that the forearm should be in pronation. You need to give a longitudinal traction. And since it's a valgus injury, you have to create a little bit of varus stress so that there is a little bit of a gap into which the radial neck can be pushed inside. So there has to be a varus stress. And when you're giving that varus stress, you can put your thumb here to actually manually reduce it. It helps to be done under image intensifier control, and you can rotate the forearm in such a way that you can place this radial neck fracture in profile so that you know you can reduce it in the AP plane alone. This is the Israeli technique. Instead of the forearm, instead of the elbow in extension, they use an elbow in flexion and they pronate it and maintain the pressure on radial head to reduce it. So we can use any one of these methods, either the Patterson's method or the Israel method, to get it reduced. If that fails, and as far as possible, we try not to disturb the vascularity, not to try to introduce instrument or not to open that area. But if it fails, we can try percutaneous reduction with artery forceps or elevators. So this is a case where we have done it using a 10 snail. This is a Monteja variant. We have introduced 10 snails and done using the Metazoo technique. But if you do decide to open, you can use the standard Cocker approach to dissect it, and acceptable reduction criteria are the same in open as it for closed. And you can use any one of these fixation options. You can use K-wires, 10 snails, and mini fragment plates. But in practice, K-wires or 10 snail is what we use. So this is a case where there is a Monteja fracture with a neck of fracture, where we have done it closed reduction and done 10 snailing. This is again another case where there is a more than 30-degree angulation, which is just pinned with K-wires and radius taken care with a 10 snail. And good functions after that. So this is the last case. Even in neglected cases where there is a complete separation of the radial head and this was lying like this for almost 2 weeks undetected, we can open it, take care not to dissect too much, and put it back into place. And usually, without even any fixation, it just stays back. And this child had good results after that. So there are sequelae. It's a very precarious blood supply, so we need to watch out for AVN, osteochondrosis kind of situation, malunion, and therefore affecting the rotation of the forearm. So the principles to keep in mind is the 30 rule. 30% angulation is acceptable, and about 30% translocation is acceptable. And it is important to keep it under 30 so that the forearm rotation is relatively normal. Thank you.
Dr. Kailash will be talking on acute Monteja fracture.
Good afternoon, everyone. My talk has been really simplified by my previous speakers, Dr. Harish. My talk will be just an extension of him. So I'm talking about acute Monteja fracture management. I have some few cases for each type. So always in Monteja fractures, we always start with the story because most of the fractures are missed. So 8-year-old boy, seemingly like a borderline forearm fracture managed by a cast. When he comes back at 2 months, it is this. Here we can see the anterior bowing of the ulna with the loss of the ulna bow is there, and we have this anterior type Monteja type 1. So it was managed by complex surgery around ulna and radius, open reduction of the radius, as destruction of osteotomy. Results are good, but the story goes on again. This time we have a precarious elbow X-ray here. He presented to me 5 days later. I took him out of the plaster and took proper elbow X-rays. Here again, we have a small plastic deformation in the proximal ulna, and we have this anterior Monteja. But luckily, because it's 5 days old, I could do a flexion, hyperflexion, close reduction. He went on to do well. So why we miss these kind of Montejas? It has been described as early as 18th century, even before the onset of first X-rays, and Bado type has been described as early as 1954. Because not every time we say these kinds of injuries. We see these subtle injuries with inadequate radiographs, and it's a common thinking that all pediatric fractures remodel well. It's not so. Always in every forearm fracture, you rule out a Monteja variant. So proper early diagnosis management is important. So as my previous speakers told, an extension of this Bada classification is a LETS classification. So it will be very important before planning management, because as we closely see, this A, B, and C types belong to type A. A is an anterior bend or plastic deformation with a subluxation of the radial head. B is an green stick fracture with dislocation and this complete fracture. Type D, LETS is corresponding to type 2 of Bado, and LETS type E is corresponding to type 3 variant. So let us go for the case example. This is a 6-year-old boy presented with this X-ray. There's not much bowing of the ulna, but there is dislocation of the radial head, 3 days old, no significant deformity. Whether we plan for a close reduction, because the ulna is almost straight, do we want to do a primary distraction of the ulna because an acute injury, or do open reduction of the radial head? So always classify first, let's type A, Bado type 1. So we attempt a close reduction under anesthesia, but here when I try to close reduce around 90 degrees, there is still it's not transecting well, There's incongruent reduction when you do hyperflexion at around 110 degrees, subsiding the biceps pull, we get the reduction, and the child does well because early pickup, early diagnosis, and early management, especially in that's type A, Barrow type 1, and supported by literature. So here, let us understand the basics of type 1 Montegia, because the planning of management depends upon that. Whenever the injury happens in hyperextension, first the biceps overacts and tries to dislocate the radial head, whereas the subluxation happens and the ulna tries to deform with the weight of the gravity, and the complete fracture happens. This is a sequence of events described by Tomkin, and most of the times Professor Wilkins in his talks, he always stresses on the hyperextension violence and the mechanism of reduction. So flexion reduces the fracture. This is a 6-year-old boy present again a hyperextension. We can see the significant amount of deformity in the proximal ulna. Here we have this classical type, let's type B, Barrow type 1 Montegia with a tension failure in the anterior angulated ulnar fracture with the dislocation of the radial head. Again, what is the plan? Because of the hyperextension violence, reduce the ulna, give a hyperflexion with 3-point pressure of the ulna, you reduce it. Sometimes a hyperflexion is needed if the radial head is sublux. But let us see what was done here. Here, an intramedullary wire was done, but the child went on to do well. But why not conserve in this case? Here, what happens is sometimes when there is proximal portion of the ulna is involved, when we try to hyperflex to make the radial head congruent, there will be excess pull of the triceps, and we can gradually have this ulna going for posterior angulation. So to prevent this, especially in the proximal fractures, it is better to stabilize the ulna so that there is no late angulation because of the triceps pull, because we need to hyperflex to reduce the radial head. So this is another case. Here we have the straightforward complete fracture of the ulna, but the pattern of the fracture, we see it's a long oblique type. Let's type C and Barrow type 1. A close reduction was attempted. Here almost a congruent reduction. So how many of you will leave this alone? Sir, Ashok sir? Will you manage it conservatively, accept this because it's reduced well, congruent radial reduction, the ulnar length is maintained? Yeah, it's an unstable pattern. Lot of multi-centric studies have come up. They were 100% they displaced because it's unstable, it's a long oblique pattern, there's high chance of redislocation and displacement. So plan for nailing, intermediate nailing was done. Almost full pronation supination was achieved within a few weeks. So what have we learned from this? Type 1 length unstable fractures will have a low threshold for operation. Sometimes, most of the times we get away with IM nailing, but sometimes if it's a long oblique or a spiral and a comminuted fracture, we need an open reduction and plating. Sometimes even after reducing the ulna, the radial head may be congruent. Sometimes we may need to open the radial head because of the fact that orbicular ligament can be interposed. Next, go for the next type here. The 8-year-old boy, we have this plastic deformation of the ulna in the coronal plane under lateral dislocation. Now again, classifying it's Barrow type 3, let's type E. So literature says most of these fractures can be managed conservatively. Sometimes because of over pressure, the high proximity of the post-interosseous nerve, they can develop in palsy. Here we tried to close reduce, there was incongruent reduction, we did IM nailing, child went on to do well with full movements. So especially in these type of fractures, in type 3, there's high chance of proximity of the post-interosseous nerve. Don't try for multiple attempts. If needed, do assistive reductions and fixation. This is a very complex pattern. It's a road traffic accident. We see a lot of edema around the elbow. Let's type B, like a Barrow type 2 equivalent. It's a posterior dislocation of the radial head. It's complete displacement and a proximal ulnar fracture. The gross swelling with the proximal ulnar unstable fracture, radial head fracture. You can see closely here, there's a distal radius ulnar fracture also, but is undisplaced. So extension casting mechanism can be done, but because of the instability, I try to reduce it by extension. The radial head popped in because the injury mechanism was extension type. So the story doesn't end here. Here we can see there is some synostosis between the proximal radius and ulna. there's cross union, even if they manage them conservatively, the complex fractures, now the option is between a stenosis takedown versus a derotation osteotomy. So to remember the importance of complete radiographs, the three parameters which was stressed by Dr. Harish, the radiocapital line, the ulnar bow, and the new line which is called as a lateral humeral line, which is a line parallel to the humerus shaft. It has to be in the border tangential to the radial head. If it's transects, it means that the radial is subluxed. And there is high index of suspicion has to be happen whenever there's an ulnar fracture. Understand injury pattern and classify. And three golden points as said by Professor Wilkins: correct the angulation, maintain the ulnar length, and maintain the radial head reduction. So this is a basic management protocol which has been already told to you by Dr. Harish. So most of the type 1 and type 4 may need operation. Mild type 1s may be managed conservatively. Type 2 and 3 are very rare but can be conservative most of the times. So montage is always a Pandora's box. Early diagnosis and pickup is the key. Acute treatment is the easier part. If missed, always have a guarded prognosis. Have a very low threshold for conservative management. Thank you so much, sir.
We now call upon Dr. Bhaskar to give his talk on neglected montage.
Good evening, one and all. My sincere thanks to Professor Dr. Sivakumar, my teacher, Dr. Prahalad, and the Preethi team for having me here. The topic is, I can say this is not a delayed montage, this is a delayed, missed, neglected. I can say this is a mysterious montage because no one can assess how the montage will become in the future if not treated properly. So just I will skip a few points. Just I will directly go to the case scenarios. So the neglected manager, even they were neglected, they've been brought at the very young age. Early days we can manage conservatively as we manage by the acute manager fractures. So but the thing is we have to have a vigil follow-up, otherwise the acute manager will become a delayed or missed manager. This is a case, it's my own case. So just as a 7-year child, this montage found out in the first day, just give a hyperflexion casting. The child has removed by himself on the 4th day. The parents missed the follow-up. This is what we found at the end of 4th weeks. It's absolute become a missed montage that became a big headache for the doctor and for the parents. So when the missed montage, these are the controversies happening and the discussion going on all pediatric forums. When we having a case of missed montage, these are the questions. First, whether he need a open reduction or closed reduction. And if he needs osteotomy, what kind of osteotomy? If osteotomy, whether he needs bone grafting or not. What is the implant of choice? It is a TENS or KY or plating. And whether he needs annular ligament reconstruction or not. If yes, how we have to do. And the role of external fixator and the transcapular wire, this is always a controversy in all the pediatric forums. This is the first case. This is an 8-year girl slip and fall. This is attended by one of my friend in Niribir hospital. He found it's absolutely it's a clear case montage. The radial head was completely out. He taken to the OT and just he didn't do anything. Just he put a radiocapital wire. He thought everything went on fine. So on the 4th day or 5th day, the X-ray was taken. So then he found this radial head is completely out. The mistake he made is he didn't recognize the ulnar component, which is the reversal of the ulnar bow. He missed it. So he took a lot of pain to convince the parents to take the child for the second op. So the child accepted, for the parents accepted on the 11th day. So we took the child to the OT. So we removed the wire. The radial head was completely out. So we tried to put the head in, but being a 11th day, the green stick fracture was a little sticky. So the primary surgeon promised the parents they won't create any scar over the girl child. So we have to do a percutaneous osteotomy, and we reversed the radial ulnar bow and we put a TENS. And this is nearly 2 months follow-up. Everything was fine. The radial head is congruent and the osteotomy site was healed well with the full function. This is the second case. It's from Sivagasi. It's treated by a senior surgeon. This is managed conservatively. This was the picture. So we took the child to the OT. See, when we receive a missed montage, we can have like first we can try a close reduction. Generally after 3 to 4 weeks, it's very difficult to go for reduction. So then we have to create a space for the radial head. So we did the osteotomy and put a plate. Then we tried to push the radial head inside, it didn't budge at all. So we plan to open the radial head and we debride all the loose and return another ligament. Even though we could bring the radial head into the so we plan to do an annular ligament reconstruction using the forearm fascia. So this is the end of 3 months, full function, healed well, it's a congruent joint. The next case, this is from Thuthukudi. So operated is a grade 1 olecranon comminuted fracture with some bone loss. Debridement and the tension band wiring was done on the first day itself. In the perioperatively, the CM findings all looks good. So this is the picture on the 4th day. So we took the child on the 12th or some 13th day. So we considering the alignment of the ulna, there's a length and the angulation. This is the CM picture. When pushed the radial head, it's like a ping pong. It goes in and comes out. So we thought maybe some hindrance to put the radial head inside. So we opened to the Cockett's approach. So we found there is no structure was there to hold the radial head. So we planned for a annular just a ligament reconstruction, not the osteotomy, because already in the ulnar length and angulation was satisfactory. So this is what we have done. We make a forearm fascia. Already operated and the open injury in the forearm fascia is not strong as we expected. So we created annular ligament reconstruction we augmented with a synthetic fiber tape. This is a 3-month-old follow-up. The child was having a full, now the implant been removed along with this button also. This is an interesting case. This is a 7-year child, came with the complaints of recurrent popping up of some structures over the, so I don't know whether it's a mandigia or a recurrent radial head dislocation. I went through the literature. So every time we supinate and pronate, it comes out and goes and sits in its place. So this is the picture, one in supination, another in the pronation. Probably it could be because the child was having a trivial fall. So the problem we have to address whether what is the, because we send the child for the MRI, and the MRI shows dislocation of radial head. They didn't give any point regarding the collateral ligament or annular ligament status. So approach, no ligament, and the collateral is also not great. So we plan to reconstruct the annular ligament and the collateral is also reconstructed. We did the osteotomy not as a conventional what we are doing for the chronic mandigia. This osteotomy we made like a derotation osteotomy to keep the head in a proper position. So this is 3 months old follow-up. Except 5 degree of FFD, the child was having full range of function with no radial head dislocation now. For completion's sake, this is a case of 8 years child. He is a known hemophilic child. Is brought at the end of 3rd month. Is a missed mandigia. Due to the fear of the hemophilia, just we plan to do an external fixator with the minimal blood loss. Just we put a fixator and we created in such a way to distract in the flexion distraction osteotomy. At the end of 3 months, the joint was well congruent and the range of motion also good. So conclusion, the duration of the surgery of the mandigia is very, very important because it depends upon this we can plan whether we can do conserve or surgical management. Finally, in the ulnar bow and the congruent radial, this is the key point. We can bring either by conservative or osteotomy, X-piece, whatever it is. Reduction is incongruent or springing. There is nothing wrong. There is no sin in opening the joint, and annular ligament reconstruction may be needed. Because if you go for annular ligament reconstruction, we can mobilize the child as early as possible and we can have a good sleep. This is a take-home message. Recognition very, very important in both acute and chronic mandigia. It's not benign as many people believe. It won't create any problem. It's not a scenario here. It's having a unique complication. In the neglected mandigia, we can attempt a mandigia and radial head reconstruction. We can bring the near normal, except very few conditions like when the radial head is completely deformed and the flattening of the capitulum and the valgus deformity of the neck of the radius. These are the very few conditions we cannot address the neglected mandigia. Otherwise, irrespective of the age of the child and the age of the injury, we can attempt a reconstruction in chronic mandigia. Thank you.
Thank you, Bhaskar. Even though you was last batsman, you batted really well and the message was well given. So in this pediatric session, the first batsman Ashok was telling, don't throw away the cast. That's an excellent message, and most of the speakers agree, if the both bones forearm, you should treat it conservatively. And for the postgraduate, try to learn how to put cast. The cast index has been stressed repeatedly by all the speakers. Even though it was well said by Ashok, other speakers didn't insist because Ashok has already done it very well. So postgraduates and those who are finishing and taking practice, please see to that you know how to put POP. So conservative treatment and POP is the keystone. And as a D-Ortho students way back, 40 years back, not 40, it's 50 years back, the first point I learned is master conservatism. Then only you can become a good surgeon. So you should master conservatism. That's a key point I want to tell. And it was Walter P. Blount in his presidential address in American Academy of Orthopaedic Surgeons. He said, don't throw away the sticks. That is for osteoporotic fractures. Because of old people, they try to throw away the walking sticks, not the ordinary sticks. Walking sticks they threw away, and there was a surge of osteoporosis, and they tend to develop osteoporotic fracture neck of femur. Now people are aware, they are avoiding it. So similarly, don't throw away the cast. So this is an important message I want to tell. And Venkatesh Babu, I want to tell something. Thank you very much for having attended this pediatric session. I congratulate all the pediatric orthopedic surgeons who has done very well, and the message is well taken. Thank you so much.
Thank you, sir. Sir, thank you very much, sir. I think you have given 3 years MCH hand surgery course in 1.5 days. And I love to stay back again and kindly convene these sort of courses hereafter, sir. And do involve us. Thank you very much, sir.
Thank you, sir. Request chairperson to honor our Iswar. Dr. Ashok Kumar. Dr. Dr. Bhaskar. Hi, sir. Dr. Kailash. We are also happy to announce the orthopedic quiz. Dr. Ghulam Mohidin, yeah. Chidambaram sir to felicitate Ghulam Ayya. Geethan sir var solunga adukkaga sir enga irukkaru hi sir next year ma கொடுத்துடலாமா அவர் இல்லைம்மா டாக்டர் கோபி மனோகர் சார் இவர் வரல கிளம்பிட்டார் அவர் இல்லைம்மா டாக்டர் வெங்கடேஷ் பாபு இருக்கா ஆமாம் ஒரு எஸ்டிம்டு ஃபேக்கல்ட்டி ப்ளைனாக இருக்கிறது டாக்டர் வெங்கடேஷ் பாபு சார் like to invite Dr. Geethan, Dr. Arul, Dr. Bharat, Professor Chidambaram sir, Kumar sir, yes sir, Prahalad sir, yes sir. We would like to announce the Orthopaedic quiz first runner-up, Dr. Abhinav and Dr. Aravindan from Preethi Hospitals. First runner-up. வாங்க சார், வாங்க பரத் சார், ராகவ் சார், வாங்க வாங்க, டக்கு நில்லுங்க. கீதன் சார், அதுக்காக தான் கூப்பிட்டது. டக்கு நில்லுங்க வாங்க. சார் என்ன? அரவிந்த். வாங்க சார், பரத் சார், அருள், ராகவ் சார், கொடுத்துரு சார். And the winner in Orthopaedic quiz is Dr. Gokul Dev and Dr. Arun Kumar from Madras Medical College. And the best poster presentation by Dr. Shankara Kumar, Kadalur College. Government Kadalur Medical College.
Poster was based on SIRVA, sir, shoulder injury related to vaccine administration, how to prevent it, and what are the laws available in United States for compensation, and how we are not having adequate redressal mechanisms in India about that, sir.
Good evening, one and all. So, I think so. We had exhaustive 2-day Preethi here. I am really thankful to all our senior faculty and faculty members who have come all the way from several parts of India to share their great experience, and all the delegates, even now they are sitting. So, without taking much time, I thank you all for being here and making this program a great success. So, we all know the success of this program, a lot of people have put their great efforts. So, I thank each and everyone for their efforts. So, this will motivate us to come up with a much better course next time. So, we all look forward to give much better course again next year. Thank you, one and all.
I want a minute, please sit down.
So really, really, I enjoyed my 2 days here. Thanks to my good friend Sivakumar and the excellent organizing team. And this is not the age to enjoy the food. I think this is the age to enjoy the knowledge. I learned a lot, and I can tell you, Sivakumar, I have not stayed in the last few years because you can't, in this age, concentrate so much. But as you have seen, I have hardly left the place. Today afternoon also lunch, because he told me to go, I went. Because it was really really, you know, it was, for me, it was really fantastic. Because knowledge is something, if I don't learn, I cannot teach. It's not teaching first, it's learning first, teaching. And whatever I teach him, he teaches somebody. So this has been a fantastic teaching session as I am concerned. I'm so happy about it because everybody has to learn. You have to learn, I have to learn. We all benefit. It's a fantastic one. Keep going. That's all I want to say. Thank you.
Feedback from others, other delegates. சாரே எல்லாருக்கும் பொதுவாக சொல்லிட்டாரு.
Thank you, sir. Thank you, one and all.